Assalamu alaikum and a very good morning everyone. We welcome you all to the second day of 43rd PADCON 2024. We have a very stimulating session today on immunodermatology. We have with us leading experts who are pushing the boundaries of knowledge in areas like autoimmune blistering diseases, inflammatory skin dermatosis, and emerging immunotherapies. Today, we will explore the breakthroughs in disease mechanisms, diagnostic techniques, and the latest therapeutic advances, the innovations that are reshaping our approach to the patient care. I am Dr. Maria Anwar from Gujranwala Medical College and Teaching Hospital.
Assalamu alaikum everyone. I'm Dr. Munifa Noor from Shalimar Hospital. First of all, in our panel of experts, I would like to call Professor Dr. Khawer Khurshid, who is a distinguished alumnus of the King Edward Medical University and a renowned dermatologist and cosmetologist. He holds an MBBS, MCPS, and an FCPS in dermatology from King Edward Medical College, from where he served for over 35 years before assuming his current role as the head of Department of Dermatology in Rashid Latif Medical College. He is celebrated for his exceptional contributions to dermatological science with over 50 national and international publications to his name. He is a key academic leader and has served as a paper setter and examiner for the CPSP and MD Dermatology program at the Shaheed Zulfikar Ali Bhutto University and the UHS. As a mentor, he has guided more than 60 trainees, many of whom now hold prestigious positions in the field all over the country. Renowned for his teaching excellence, he continues to inspire the next generation of dermatologists with his expertise, leadership, and dedication to advancing the discipline. Sir, please come on the stage.
Next, I would invite Dr. Tahir Kamal, who is a senior consultant dermatologist. He is an FCPS and he did his post-graduation from Wales, Cardiff with distinction. He is a teacher, a supervisor, and an examiner. He has got a keen interest in research with many publications to his credit. One of the pioneers in aesthetic dermatology with special excellence and interest in reconstructive surgery. Professor Tahir Kamal, kindly come on the stage.
Now I would like to invite Dr. Ghazala Bhatt, who is currently serving as the Associate Professor in the Dermatology Unit 1 at Jinnah Hospital. Ma'am, could you please join us on the stage?
Our next panelist is Dr. Abdul Qudus Bhatt, who is a senior consultant dermatologist who has retired as head of the dermatology department from Benazir Bhutto Hospital, Rawalpindi. I think he is not here. Let's start our session. Our first speaker is Dr. Tahir Kamal, who I just introduced, is a senior consultant dermatologist and aesthetic physician. Sorry, kindly.
Bismillahirrahmanirrahim. Esteemed panel of experts, respected participants, my seniors, my colleagues, Assalamu alaikum and very good morning. Let me begin my talk with this certain concept. Sorry, can I have the slide change? So my talk is on actually pemphigus, and we are all aware of the fact that we deal with this problem which affects quality of life of patient, and especially in cases of chronic pemphigus vulgaris, where we face a lot of morbidity and mortality. And this study was actually designed to look into the factor which can affect ultimately the outcome of patients, especially regarding the mortality. We all know the fact that with chronic pemphigus, they are prone to infections because of immunosuppressive medication, and obviously they are immunosuppressed with immune modulators, which we have to, obviously as a part of treatment, we have to administer. But there are certain factors, especially upcoming dermatologists, which we look into and we should, which ultimately decide the outcome of the chronic disease like pemphigus vulgaris. And alpha-1 antitrypsin is one of the indicators which will guide us whether to decide our treatment plan and management plan. So the title of my study is Role of alpha-1 antitrypsin and FEV1 in patients with pemphigus vulgaris. I am representing and working presently in dermatology department of Alton Hospital. This is table of my contents. There is no conflict of interest to be clear. So as I said in my intro that pemphigus vulgaris is a chronic autoimmune blistering disease, and basically they are desmoglein 1 and desmoglein 3 antibodies, mainly desmoglein 3 antibodies. And we should keep in mind that these antibodies, beside obviously damaging the skin and causing blistering, it affects the mucosa also. And alpha-1 antitrypsin is a protease inhibitor which tends to protect the lung damage and the mucosa. So it can be, initially in our thought, it can be an indicator which can decide whether it is an important factor which can decide ultimately the outcome. So there are skin erosions and potential systemic impact. Alpha-1 antitrypsin is a protease inhibitor, and it could be deficient due to genetic factors or consumption due to disease. Normal level of alpha-1 antitrypsin is 100 to 300 milligram per deciliter, and FEV1, if we count in liters, in males it is 3.5 to 4.5 liters, and in female 2.5 to 3.5 liters in 1 second. So both are the parameters to decide the effect on lungs. So obviously, as the disease progresses, the important factor is obviously large area of body is involved, and sometimes with conventional medication we are unable to control the disease. So this was the rationale of the study. Patients with pemphigus vulgaris may have altered alpha-1 antitrypsin, and it can correlate with the disease severity and lung damage. And forced expiratory volume 1 as a lung function parameter to assess potential pulmonary involvement in pemphigus vulgaris patients. So objective was to evaluate the association of alpha-1 antitrypsin and FEV1 with the disease severity in pemphigus vulgaris patients and as a biomarker for lung damage. It was a case control study with 10 biopsy-proven pemphigus vulgaris patients and 10 age-matched healthy controls. Pulmonary function tests including FEV1, total lung capacity, vital capacity, as well as HRCT was also carried out in these patients to actually see the lung condition. And disease severity was assessed with cases and controls. There was 60% female and 40% male in the cases group, and controls 30% females and 70% male. And this was the age matched. Less than 50, greater than 50 years, as you can see in the So out of 10 patients kept in this group, the scoring was according to moderate 4, severe 4 cases, and extensive 2 cases. The cases group and the healthy group are compared using the independent field test, and then ultimately it was evaluated with SPSS version 26. So in cases group, if we talk about FEV1, 40% of the pemphigus vulgaris patients showed decreased FEV1, whereas 20% of pemphigus vulgaris patients had reduced alpha-1 antitrypsin level. And show the details. Lung abnormalities were also found in the severe cases, and especially in those who had low level of alpha-1 antitrypsin, like grandma's fluid thickening and compounding 4 patients. Controls had normal lung function test, and alpha-1 antitrypsin levels were within normal limits. So, as I said, FEV1 less than 0.05 and alpha-1 antitrypsin less than 0.05 was considered significant. So, this is the chart. We consider FEV1 cases and controls. It is in liters. So, mean value was 1.54 in cases of pemphigus vulgaris cases, with a standard deviation of 0.53. Controls at the mean value. So comparing these two groups regarding FEV1, the p-value was significant, less than 0.05. It was in 0.1. If we come to alpha-1 antitrypsin level in cases and control groups, it was 95, mean value 95 milligram per deciliter in cases, and 190 in cases of control groups. So with the standard deviation of 17.09 and 27.3. So here there was significant difference among the cases and control group. So if we compare with national studies, Illinois actually showed regarding the changes in the lung function, if we consider FEV1, was 68% lung changes were found. We also only went for pulmonary function test. With our current study showing 40% of the lung changes regarding FEV1. So he concluded differences may arise from the disease severity and hospitalization duration. Goyan et in 2001 showed no conclusive evidence linking desmoglein antibodies to respiratory lesions or consistent with this fact. Holmes Stockley showed lower alpha-1 antitrypsin associated with chronic obstructive pulmonary disease. It does align with our finding because in this study, the alpha-1 antitrypsin level mean value was 144 milligram per deciliter. In our study, the mean value was 95. Correlate disease. is an indicator of mucosal damage, and we should actually take these cases where alpha-1 antitrypsin level is significantly low, especially if it is below 100 milligram per deciliter, as a distant case of pemphigus vulgaris. Because in this study, we actually tried to indulge those patients who had clinically or cutaneous control of pemphigus vulgaris patient, because initial inflammatory process can alter level of alpha-1 antitrypsin. So we tried to control that factor. They were stabilized with the medication, and then the levels were taken. So if even clinically there are no bullous lesions and levels are low, we should take it as a distinct case of pemphigus vulgaris, and we should, I suggest in the message take home that we should actually move on to the other therapy like cyclophosphamide pulse therapy, and maybe we can go on to CD20 antibodies, monoclonal antibodies like rituximab. Should consider that in those cases, because that will ultimately those patients can predispose to definitely to infections, and then ultimately that might be reason for high mortality rate in chronic pemphigus vulgaris, besides the suppression of medication. So pulmonary involvement can affect lung function. Alpha-1 antitrypsin is a marker, can predispose to lung complications, especially the infections, because lung become inhibitus, and there is clinical relation. So we should further research, and maybe we will be able to find some linkage between anti-desmoglin antibodies and the disease severity, along with the involvement of lung in some way, and then it might be another factor to label it as a biomarker for severity of disease as well as lung damage. Thank you so much.
I would like to call Professor Dr. Arif Maan from Faisalabad to join us on the stage in the panel of experts. Sir, please come. Our next presenter is Dr. Saida Mahanam Ali, who is a consultant dermatologist in the Department of Dermatology in the Jinnah Postgraduate Medical Center, Karachi. Please come on the stage.
Good morning, dear doctors. I am Dr. Sayyeda Mahanam Ali, consultant dermatologist at Department of Dermatology, Jinnah Postgraduate Medical Center. Today, I welcome you all in my research presentation of efficacy of dexamethasone cyclophosphamide pulse therapy or azathioprine pulse therapy versus conventional treatment in patients with pemphigus vulgaris. So I will continue. I share no conflict of interest. As we all know, that pemphigus vulgaris is an autoimmune blistering skin condition that requires prolonged hospitalization. Over the decades, pemphigus vulgaris has been treated with conventional treatment, but since 1981, pulse therapy have come out to be an emerging treatment option to treat pemphigus vulgaris, leading to quicker remission. But the question arises, if it can give prompt and quicker remission compared to conventional treatment is still a matter of debate, and the answer to this question can lead to better management of this devastating skin condition. So the objective of my study was to find out the efficacy and safety of a DCP-DAP pulse therapy versus conventional treatment in patients with pemphigus vulgaris. So it was retrospective cohort study conducted at Jinnah Postgraduate Medical Center, conducted from January 2021 to December 2023. Sample size was 100 and both in as well as outpatients were enrolled. The patients were biopsy proven cases of pemphigus vulgaris and non-proliferative consecutive sampling was used. The data was collected by dermatologists and dermatological residents after the permission from Ethical Review Board, and the photographs were also taken by the consent of the patient, and follow-ups were made by telephonic communication. P-value of 0.05 was considered significant. So the inclusion criteria was patients with age greater than 18 years, any gender, no prior treatment, biopsy-proven cases of pemphigus vulgaris, and PADCON score of greater than 15. An exclusion criteria was pregnancy, lactation, severe comorbidities, Hep B, C, connective tissue diseases, drug hypersensitivity. So among 100 patients, they were divided into two groups, each having 50 patients. In DCP, DAP pulse therapy was labeled as group A, while conventional therapy was labeled as group B. In group A, dexamethasone 100 mg IV was given along with cyclophosphamide 500 mg or azathioprine 50 to 100 mg per day for 6 months, and in group B, oral prednisolone with a dose of 1 to 2 mg per kg with azathioprine 50 to 100 mg per day or cyclophosphamide 50 to 100 mg per day was given. Data variables were corrected for epidemiological as well as clinical data. PADCON score was categorized as mild, moderate, and severe. Moderate was 15 to 45 score, and greater than 45 were severe cases. Outcome measures were taken: clinical remission greater than 50% reduction, hospital stay duration, relapse rate, as well as adverse events. So 54% were females in group A and 52% were females in group B. Mean age was 45 years in group A and 43 years in group B. Group A had efficacy rate of 92%, and in group B it was 76% with significant p-value of 0.0097, indicating that group A is more efficacious than group B. Median time was 6 weeks versus 12 weeks in group A, B respectively, while the hospital stay was 14 days and 28 days in both groups respectively, showing that hospital stay duration was less compared to the group B in group A. And relapse rate was 16% at 12 weeks in group A, while it was 32% at 12 months with significant p-value in group B. Adverse events were noted like infection, osteoporosis. Infection was 12% and 24% in both groups respectively. Osteoporosis was 8% and 16% in group B respectively, with significant p-value of infection. This is our patient who was treated with DCP pulse therapy, who showed significant improvement in 6th week. And this is a picture taken at 3rd month. Similar patient. This is another patient of the DCP group treated with DCP treatment, showing significant improvement. Another patient who was treated with DAP therapy, showing marked improvement. This is a similar patient. This is a patient who was treated with conventional treatment and showing good response. The patient showed significant clinical remission at almost 2.5 months. So the conclusion of my talk is that DCP and DAP pulse therapy is superior to conventional treatment in giving faster remission, reduced hospital stay, and fewer side effects. We recommend that DCP DAP pulse therapy should be considered first-line treatment option in patients with pemphigus vulgaris. The strength of the study was the sample size was of international standard, and limitation was a small sample size, and it was retrospective study, and larger control trials are required to confirm the findings. My acknowledgement to dermatologists and dermatological faculty residents. Thank you very much.
Our next speaker is Major General Zafar Iqbal Sheikh. He is a graduate of Army Medical College and Fellow of College of Physicians and Surgeons, Pakistan. He did his advanced training in clinical dermatology from University College Hospital, London, UK, and in aesthetic dermatology from New England Medical Center, Boston, Massachusetts, USA. He served as a professor and supervisor in dermatology at Army Medical College and Military Hospital, Rawalpindi for almost 2 decades. He was appointed as Dean of Faculty of Dermatology at CBSP from 2013 to 2018. He has the honor of being elected twice as the President of Pakistan Association of Dermatologists. He was awarded Hilal-e-Imtiaz Military in 2018 in recognition to his meritorious services in the field of healthcare. Kindly, sir, come on the stage.
Assalamu alaikum everybody. It's a great pleasure to talk to this team for two months, especially some 3 decades ago. So how old we are in the present. I still remember those 3-4 hours we spent and still has an impact.
All right, I shall be talking on the subject of JAK inhibitors, the very promising upcoming treatment of moderate to severe alopecia areata, and claimed to be as game changers, especially in the refractory alopecia areata. So I have no conflict of interest, and the data that I'll present is from renowned international journals. Since we don't have much of our data, these drugs are new in Pakistan, so I will be using the data that has been published already. These are the different types of alopecia areata, but this slide is just basically to demonstrate that we will be talking more on the alopecia totalis or the alopecia universalis, which are actually the candidate patients for the use of alopecia, these JAK inhibitors. All right. So this table shows you the different modalities of treatment that we have for the management of alopecia areata. When the severity of disease is severe, we have to resort to the systemic treatments, and Most of these treatments are required for prolonged period of times, and they have their toxicities. So, and the sustainability of these treatments is also not well established. So, looking for something like new treatment. So, JAK inhibitors are stuck with the yes. Now, anyway, while to understand these JAK inhibitors, especially in the clinical trials, you've got to know the severity assessment of these JAK inhibitors, because in most of the clinical trials and in the clinical practice, you have a baseline severity score, severity of alopecia severity score tool, which is called the SALT score. You have a baseline, and then you assess the treatment outcome by percentage reduction in the SALT score. And the second important thing is the pathogenesis of alopecia areata. That makes you understand what is the mechanism of JAK inhibitors, their pharmacokinetics, and where they act. So this is the SALT score assessment. To make it just very simple, if the patient has full hair, SALT score is 0. SALT score 50 would mean that the 50% of the scalp hair are lost, and this SALT score 100 is like alopecia totalis. For the use of JAK inhibitors, as I said, that it is the moderate to severe cases where the systemic treatment are indicated, and we'll be talking about the JAK inhibitors in such cases. Another assessment tool is the dermatology life quality index score, and people having a large effect on their quality of life are the candidates for systemic treatment. Now, coming to the pathogenesis of alopecia areata, this side you see the healthy hair follicle, and there are certain features which prevent the normal follicle from the immune attack, and that is called the immune privilege. It may be a little Rivian for you people, but it is essential to understand how JAK inhibitors work. So you have low levels of major histocompatibility complex in this region, and higher level of transforming growth factor alpha melanocytic hormones and protective interleukin 10, and they are called the guardians of immune privilege. When under certain genetic factors or the hormonal factors, the follicular epithelium is damaged, there is release of interleukin 15 from the follicular epithelium, which activates and attracts the T lymphocytes, and which produce interferon gamma, and there is then more effect on the epithelium, and there is a vicious circle of damage that establishes. So this slide shows you the collapse of immune privilege. There is gathering of lot of inflammatory infiltrate around the hair follicle that constitutes the CD4, CD8 lymphocytes and the natural killer cells, and these production of these cytokines like gamma interferon, the interleukin 15, they are mediated through cytokines, which involves the JAKs and the JAK-STAT signaling pathway. So little bit about the signaling pathway of the JAK-STAT. Well, so what are JAKs? JAKs are actually family of cytoplasmic non-receptor tyrosine kinases. They are present in the intracellular. These are JAKs in the cell. There are 4 types: JAK1, 2, 3, and tyrosine kinase 2. It's also called TYK2. These JAKs are actually stimulated by the specific cytokines, and these then bring a transformational changes in these receptors, and that activates the JAKs. We'll show you in the subsequent slides how it happens. So these are the different types of cytokines that stimulate particular JAKs. For example, we are at the moment talking about the alopecia areata, and the two cytokines like interleukin 15 and interferon gamma are visible against JAK1. So if you block this JAK1, you will break the cascade of inflammatory process in the alopecia areata. So I'll now speak a little bit about the JAK-STAT pathway. Let me go to the next slide that shows you better. So you have these receptors, cytokine receptors. This is the cytokine binding to the cytokine receptors. This, as I said, brings a transformational change in the receptor, and it activates the JAKs and their phosphorylation occur. This JAK would then phosphorylate the terminal subunits of this receptor, and this will bind another group of protein which is called the STAT proteins, the signal transducers and activators of transcription, that is STAT. After this docking, there is an activation of or phosphorylation of the STATs, and they get dissociated from the receptor. Then they bind together, it's called dimerization, and then there is a translocation into the cell nucleus where they bind with the specific sites in the DNA, and then there is a gene transcription to form or produce more pro-inflammatory cytokines. So what JAK inhibitors do? JAK inhibitors are the ones that are the drugs that you take orally. These JAK inhibitors, they can block all the possible pathways of JAK-STAT signaling. It prevents activation of these JAKs, further phosphorylation of these receptors, then docking of these STAT, and then translocation and transcription. So all the processes can be blocked by these JAK inhibitors. So they are divided into two generations. One is the first generation. They are sort of pan JAK inhibitors. They block more than two or all of the JAKs. The second generation of is a selective inhibitors that predominantly block one. If they have effect on the second JAK, that's a very minor one. So that this separation actually determines their safety profile. The untoward effects are lesser when you're using the selective JAK inhibitors. So list of JAK inhibitors is long, but these are the ones that have been used specifically in the treatment of alopecia areata. We are all very well versed with tofacitinib. That was the first JAK inhibitor which we had in our country. Roxatinib is another one which is actually approved for the treatment of vitiligo now, coming up probably this month in Pakistan. Baricitinib is another one which will be coming, inshallah, maybe within couple of months in Pakistan. Then duroxatinib and delgocitinib. And the second generation is ritelcitinib, upadacitinib. Upadacitinib is approved by FDA for the treatment of atopic dermatitis, and it has an off-label effect on alopecia areata. So these are the ones which are actually most commonly used. So tofacitinib is a pan-JAK inhibitor. In the treatment of alopecia areata, it's yet not FDA approval. There are no phase 3 clinical trials on tofacitinib in alopecia areata. Roxatinib also works, but it is approved by FDA for vitiligo, not for alopecia areata. Baricitinib is the first one which got FDA approval in 2002, followed by ritelcitinib in 2023 and duroxatinib in 2024. So this actually slide shows exactly where these JAKs would act. Tofacitinib will block JAK3, JAK1, Rituximab will block the JAK3 and interferon gamma production is reduced, and baricitinib will act on JAK1 and JAK2 on the follicular cells. So the clinical data on the this JAK inhibitors was first published in 2014 when it was seen that a patient of chronic plaque psoriasis when having alopecia universalis, and there was significant improvement in alopecia along with the plaque psoriasis. And then a news appeared in Yale Arthritis Drugs Spurs Regrowth of Hair. This was study done at Yale and Stanford University. So this study was a small study on sample size of 66 patients. It showed non-responders were 36%, 32% intermediate, and strong responder were 32%, and the effect was far better in men than women. I'm very short of time actually. Should I continue or what do I do? Madam? Time थोड़ा सा रह गया वैसे. But okay, baricitinib was approved in 2022, and this slide shows that baricitinib was given 4 milligram and 2 milligram. The results with 4 milligram were far superior than the 2 milligram and the placebo. Same was another Brave 2 study which showed a far superior response with 4 milligram as compared. So this what shows is that the effect of JAK inhibitors is dose dependent. So we come to another this JAK inhibitor rituximab, which was approved in 2023. They split it in 5 different categories, the patient sample. I think there were 2 groups in which they gave loading dose followed by 50 milligram and 30 milligram. Then another 2 groups, 50 milligram, 30 milligram, and another 10 milligram and a placebo. So that was the patient sample. If you see this one with the loading dose, the blue line, it's a very quick response in the initial phase followed by a slow response. But if you see this purple line, this reflects the 50 milligram dose. They continued the study after 24 for another 24 hours, for 24 weeks. So this study was specific because they used this drug in the adolescents also. So all doses were included in the statistical analysis were superior to placebo. And just I come to the last inference. Response was dose dependent. By the end of the study, the therapeutic outcome of 50 milligrams was superior to 30 and 10. So standard dose for this rituximab was 50 milligrams. The third drug was approved this year, baricitinib, published in Journal of American Academy in 2024. Again, 2 doses was used, 12 milligram, 8 milligram. So there was a statistically significant more response in 8 milligram. Okay, we skip some more important things. Now this is a little bit important. Pediatric population, we do not have enough data in the pediatric population of alopecia areata, and it's largely dependent upon the small sample size and studies. Tofacitinib we are using in these adolescents in Pakistan at the moment, and it is right because this drug is approved for juvenile rheumatoid arthritis. So the safety profile of this drug is proved. Rituximab is approved from 12 years onward, and udapicitinib, which is for the atopic dermatitis, is again approved for atopic dermatitis in adolescents, and it has an off-label effect on alopecia areata. So this is 11 years old boy, 12 years old girl. and concomitant atopic dermatitis and alopecia areata. So they have a very narrow therapeutic window. If you increase the dose, you have higher risk of adverse effect. With lower dose efficacy is affected. So what it means is that you need to monitor the patient when you are treating them. So this is the list of untoward effects. I don't need to go into their detail, but in all the studies that have been done, clinical trials, the safety profile was very good. There were very few side effects recorded in all those these clinical trials. So these baselines are same which you use for other biologics or other immunosuppressants. JAK inhibitors are contraindicated in pregnancy and lactation, so let me skip this also. So cautions, you should not be using them in patients above 65 years, with patients with cardiovascular, embolic disease, and lymphopenia or neutropenia. So come to the conclusion, it's a promising treatment modality. Ideal JAK inhibitor is still not yet known because there are no head-to-head comparison of different JAKs. Duration of most of the published clinical trials 24 to 48 hours. Therefore, we do not know so far the sustainability of response, and we do need further clinical trials to see different, to search for the ideal JAK inhibitors in the treatment of alopecia. So thank you very much. I'm sorry for being a little late. I was actually told that my talk may be for 20 minutes, so I prepared accordingly. But any questions? Thank you very much.
Our next speaker is Professor Dr. Sahibzada Mahmood Noor, who is a renowned dermatologist and a leader, serving as the head of dermatology in the Lady Reading Hospital in Peshawar and supervising in the College of Physicians and Surgeons, Pakistan. He pioneered dermatology fellowship program in the Khyber Pakhtunkhwa, initiating FCPS training at the Lady Reading Hospital in 2007, with many of his students now leading major teaching hospitals in the region. He was Associate Dean and later Dean of the Lady Reading Hospital and has held the position of General Secretary of the Pakistan Association of Dermatologists. He is a prolific researcher and has a number of international and national publications to his name. Moreover, he has been the guest speaker on a number of forums and takes a keen interest in autoimmune diseases, especially psoriasis, and bullous disorders, particularly pemphigus. As a pioneer in the medical education, he introduced a paperless MHPE program at Khyber Medical University and has led the Postgraduate Medical Institute as CEO since 2021. Dr. Mahmood Noor has fostered partnerships, advanced postgraduate training, and launched various initiatives such as certification programs in simulation and airway management workshops. Moreover, he has inaugurated a facilitation center and standardized the ETEA test and significantly enhanced the institution's growth and excellence. Sir, please come on the stage for your presentation.
Bismillah ar-Rahman ar-Rahim. Dear audience, it's pleasure to be in Lahore once again. It's always a nostalgic feeling to talk to you people because this is the very place which was instrumental in my training, and today wherever I stand, it's all because of the training that I had in Lahore. So we move on. So my talk will be basically on the investigative aspects of the autoimmune bullous disorders. So the objective of the presentation is that we will be discussing the updated guidelines for the management of the pemphigus, identify complications of the rituximab therapy, and manage complications of the rituximab therapy. So this is the Lady Reading Hospital, Peshawar, where I work. So my today talk would be based on the experience that we have gained over a period of time in treating the autoimmune bullous disorder, particularly the pemphigus vulgaris. So these are the three publications that we had from our unit, that is the clinico-epidemiological study, 148 patients, a pre-infusion checklist of rituximab and an audit, and this is the latest one, the management of the pemphigus during the COVID-19 era. So based on all these experiences, we have gathered cases which are real time, and I would like to discuss with you people, which will be beneficial for you people also. So the first scenario is a 40 years old male is administered 2 doses of rituximab 1 week apart for the treatment of pemphigus. What is the protocol for subsequent doses? How will you taper the steroid after rituximab dose, and how will you taper the adjuvants, immunosuppressants? Any wild guess? नहीं, ये मेरे वाले ना बताए ना जी. So we move on. The beauty of the rituximab is that once you administer it, so you can taper the steroid within next 3 to 6 months. So if it is mild, you taper it on 0.5 milligram, and then you go on to 0.1 milligram. And if it is moderate to severe, you taper it in a slower form. Now this is very important that once you have tapered the steroid, then you switch off the azathioprine based on the 8 weeks. That is, in the first 8 weeks you reduce it to 50 milligram, and then in the next weeks you stop it. Same is the case with the mycophenolate mofetil. You decrease the dose by 500 milligram every 8 weeks. Now this is a study that what is the subsequent protocol? 1 decade ago, when the rituximab we first time gave it to the patient, we thought that it is a panacea for the treatment, and the patient would not need any further treatments. But with the passage of time, the literature said, and that's what we experience, is that the patient started having relapses. So it is very important. The protocol is that once you have given 1 gram, 2 doses of 1 gram, 2 weeks apart, you must consult the patient about the subsequent doses. That is, he will need a subsequent dose at 6 months, 1 year, and 18 months. This is the updated literature that they say that they will have 500 milligram at 6, 12 months, and 18. And then the very important thing, which has recently, if you go back 5 to 6 years back to the literature, you will see that it was said that the rituximab was taken as the third line treatment. But now the literature says that you need to treat them as early as possible with the rituximab, because they will have lesser chances of relapse. The second scenario is a 25-year-old obese female, 6-year history of pemphigus, no other comorbidities, presently on 10 milligram of maintenance dose of prednisolone and azathioprine. She has a history of prolonged use of steroids in maximum dose of 1.5 milligrams several times in the past. She has recently developed pain in the hip joint with restricted movements. So how will you further investigate this patient? Very important that at times when we are treating these patients, we take into account that we will treat them with the DEXA scan. So please take into account that although it's not our practice and we do not do it as frequently, but it is more appropriate to have an MRI of a patient when diagnosed with pemphigus vulgaris at the initiation of therapy, and then these subsequently. Another patient, 46-year-old obese male, 60 years of pemphigus vulgaris, uncontrolled diabetes and hypertension, presently on prednisolone, and he developed aseptic necrosis of the femur. So if you come across a patient, and we came across these aseptic avascular necrosis of the femur quite frequently in our patient, because they are on the steroid for a very long time. So you need to reduce the dose of steroid as early as possible. So the ideal is that you need to give them rituximab, but due to the financial constraints, if you cannot give them rituximab, so it is more appropriate to put them on plasmapheresis or the cyclophosphamide pulses. So it is, the guidelines will not tell you because they are set by the Western people, they have access to the rituximab, but in our unit it's a protocol. If a patient is diabetic, hypertensive, and he is diagnosed with the pemphigus vulgaris, you need to give them cyclophosphamide pulses as a first line rather than waiting them for the complications to occur, because that will give you a chance to taper the steroid as early as possible. So this is the one of the patient who had this avascular necrosis of the femur, and he was given the cyclophosphamide pulses which controlled his disease. Another scenario is 38 years old male, diagnosed case of pemphigus vulgaris, and he had a first dose of rituximab as per protocol, and after few days developed high-grade fever with fatigue, inability to walk without support, dizziness and blurring of vision. Subsequent, he had also paraplegia. So this particular patient, all his lesions cleared, but he developed these complications. So it is one of the rare complications of the rituximab therapy, that is the progressive multifocal leukoencephalopathy secondary to Ritux therapy. So it's important that you diagnose these patients, you have these complications in your mind, because it's quite potential drug which causes these side effects. So IV immunoglobulins is the treatment if the patient develops these kind of complication. Another scenario is, what is the serological monitoring, how you monitor it. Now again, this is a catch here, because we rely on our clinical acumen, but it is said that desmoglein 1 and 3 needs to be done at the initiation of the therapy, 3 months into the treatment and subsequently. Another scenario is, now this is very important, a few years back it was considered that you need to do the quantiferon gold TB test before you start the rituximab therapy. But now it is said that you do not need to do the quantiferon test, because it is the B cells that you are eliminating, not the T cells which are responsible for the immunity against tuberculosis. So all you need to do is the X-ray chest, take a history of tuberculosis in the family and the contacts. If the patient has no active tuberculosis, you do not need to do the quantiferon gold TB test. Another scenario is a 37-year-old male. If you ask me, in our practice, or I think my colleagues from Lahore will also concur with me, that the tuberculosis is not that much of a big problem in treating autoimmune disorders. It is the hepatitis B and C that we come across in our patients, which is more frequent as compared to the tuberculosis in these patients. So you need to liaise with the gastroenterologist, and these are the protocol that you need to give them lamivudine 2 weeks prior to the rituximab and continue for 2 to 3 months thereafter. These are some other guidelines that you need to give them and take away, and you need to have the copies of the hepatitis B virus DNA concentration also. Now this is another one, a 33-year female patient, case of pemphigus vulgaris, was started on maximum steroid and azathioprine, but consolidation was not achieved. Rituximab infusion was given. Patient soon started feeling lethargic. She also developed palpitations and dyspnea on exertion, which was progressive in nature. There was no other associated systemic symptoms. What is it? Very common, we come across 2 of our patients, they developed the shortness of breath, and we investigated for everything, X-ray chest. We kept the possibility of pulmonary embolism in our mind. So this particular patient had pulmonary embolism, and it was a pancytopenia following the rituximab. Another one is the following the next scenario is regarding the pulmonary embolism, sorry for that. So rituximab infusion can have hematological adverse effects due to bone marrow suppression also. So this is the last scenario. A 45-year-old obese male was diagnosed with pemphigus vulgaris, steroids 1 milligram per kg, body weight and azathioprine 150 milligrams. She also received rituximab 1 gram infusion. Patient developed dyspnea and palpitation. Her ECG showed sinus tachycardia. X-ray chest done showed peripherally placed wedge-shaped opacities. D-dimers were raised and venous Doppler ultrasound leg were normal. What further workup is required in this case to confirm the diagnosis? So it is the ECG and all these, but very important that you need to do the CT scan, which is CTPA, and the patient you will diagnose. So you need to take into account those patients who are on the steroids. They have an additional risk of the pulmonary embolism. And there is a one particular phenomena which is called thrombotic storm, which is induced by the rituximab. So patient on steroids, you are administering them rituximab, so you need to take into account that they may develop pulmonary embolism. And if they develop the shortness of breath, you need to take this particular complication of rituximab therapy into account. So another one is 13-year-old girl, case of pemphigus, raised D-dimers. So the cell lines were deranged. So IV immunoglobulins are the important that you need to take into account that they help to enhance the immunity. Another important thing, and this one of my colleague, Dr. Faria, asked me that what you need to do, you need to take into account if the ALT is raised in these particular patient, it's a contraindication if it is raised 4 times the normal. So the azathioprine and rituximab, they are contraindication. You cannot administer the rituximab to patient with raised ALTs and the liver function test. So you need to wait for it to settle down, and you can have different strategies. You switch off the azathioprine or you move on to the rituximab. Cyclophosphamide has also a favorable side effect. And if the patient has raised liver function tests or altered liver function tests, the cyclophosphamide, oral cyclophosphamide is one of the drug which can be given to them. I end my presentation with prayers to my mentor, my teacher, Professor Tahir Said Haroon, who trained me in this very particular city, and it was all due to his mentorship and his teaching that I have attained this position. We must pray for him. May God bless him, and may God have Allah unko jannat mein jo hai na uncha maqam de. Thank you very much ji.
We are very honored to have Dr. Sayyida Pak Ahmed with us. He has retired as Associate Professor at Pims Hospital, and he has also served as Professor of Dermatology at IMDC. He is a supervisor examiner and examiner of FCPAs, MCPAs and MD Dermatology at Shaheed Zulfikar Ali Bhutto Medical University, Islamabad. Sir, kindly join the panel of experts. Hall is now open for questions and answers. If somebody has any question. There is a question.
Assalamualaikum. I have a question from Sir. So the protocol that we follow at our center in Khan, it is National University. So before, now we've selected the patient, and the patient we think is good of figure, needs rituximab. So we start azathioprine when it use prisoners at least 2 weeks before administering the first dose of rituximab. So is it, I mean, I will try to share the protocol reference to you eventually, inshallah, but have you heard of any such protocol? I mean, this was new for me, that you continue these immunosuppressants and you take it in long dose once in the next 3 to 6 months. one will get about 14 to 16 post-rituximab months, 14 to 16 months. Now they're going for their fourth dose, fourth 6 months.
That's very appropriate because this is what it needs to be emphasized, because we mostly see that after 1 or 2 doses of this rituximab due to financial constraints, and because the patient is okay, he has got no lesions, so they usually stop all the medications and then they appear once the disease has relapsed. So you need to consult the patients in advance that you need to continue with 500 milligram at 6 months, at 1 year and 18 months. And very important because this rituximab is given by the Roche people, and they have this program that for 1 gram they give it another 1 gram free.
Yes.
Yes. So if they do not have this subsequent doses and they stop and the disease relapses, so you do not give them 500 milligram. You need to give them again the 1 gram and 1 gram.
Before 1 year.
Yes.
And they're bound to give it free again. If it relapses before 1 year, they say.
Yes, but it's usually, we have seen that it's after 1 year that
We
they
haven't seen any relapses prior to 1. One more thing. Now it's said that it has to be continued for 6 months in intervals for good. It has to be continued every 6 months, 500 milligram.
This is
doses.
what they recently have said,
Yes,
that you
good
need to continue
Now
lifelong.
the question arises, now we have a young patient who's had her third dose and now she's fit and good, mashallah, fine, healthy, without any relapse, no steroids. Now she wants to conceive. It is said in the protocol that at least it should be 1 year without rituximab before.
Yes, exactly.
So what should be done in such cases?
So you have to wait, the patient should wait for another 1 year before she conceives.
But
This
she
is,
has to take the next 6 monthly dose.
in that case, the 6 monthly dose you give them, but then you need to do the desmoglein levels, follow them, they conceive, and then you give them.
After that.
Yes.
Thank you, sir.
Welcome.
Assalamualaikum, sir. I am Dr. Moizzat Tahir, and indeed your presentation was very nice and very benefiting to all of us. Pemphigus vulgaris is a disorder, autoimmune and naturally very disabling disorder. Rituximab is something new which we have adopted over the last 3 years. So personally, I do not say that I have a long data of experience to share here, but what practice we do generally is, I myself do is that we give the rituximab, the first dose as 1500 milligram, and we switch off all the immunosuppressants. And then after 15 days, we give the second shot and then repeat it at 6 months and then 12 months. If the patient has a disease which is more severe, then the delta corticosteroid can, or the steroids can be continued and gradually taken. The rationale for switching off the immunosuppression is that besides all the other side effects you have shown here, the most dreadful one is the infection. Recently, we have seen a young girl of 20 years, which is right now admitted in the military hospital Rawalpindi with mucormycosis, with a mortality rate of 54% and currently on amphotericin B. And she was on 2 immunosuppressants. So if we practice immunosuppression too much in young population, which is an overly crowded, living in an overly crowded places, plus the monitoring of these tests, it is something which is dreadful and we must be treated. I would like your expert opinion on that.
Thank you for highlighting. It's encouraging for me that early morning in Lahore, the people are discussing the autoimmune bullous disorder and the rituximab. Alhamdulillah, we have now over one decade of experience with rituximab. What you have said, mucormycosis, what she may be having some underlying problem like diabetes or something which has got which caused this mucormycosis. We routinely give them 2 immunosuppressants because this is what the guidelines say and that we have been following. We taper the steroids per S2K guidelines which I have shared. That is, we do not switch off everything. And these infections in these patients that we came across, the mostly that the side effects that we have seen are most of the liver function test, derangement, the pulmonary embolisms. Yes, we do see the infections, but not to this end. It may be the first one that I have heard that the mucormycosis occurring in a patient with pemphigus vulgaris having rituximab. How many cases are there in the literature? I do not know. So that may be one odd case, but the practice is that we do give them steroids and then we taper the first the steroids and then the azathioprine.
Design, I want to ask the percentage of these some serious side effects of rituximab and immunosuppression in the prison, especially if we are treating a young patient. But should we add this in the counseling? It can happen. What is the percentage? In your experience, you have visited study around 48 patients and only one patient. What is your experience and what is the data? And secondly, what hope we should give to the patients, especially young patients, that for how long they have to take, what is the longest duration can take, what is the actual treatment, I mean the disease remission. So it's a big thing for the poor patients. They have to afford it and they have to manage it, and then they suddenly develop some serious complications. We have to explain the, I mean, say the percentage, how many chances of being into that type of conditions.
The chances of having these pulmonary embolism and all these side effects are rare. It's not that common that you come across with these rituximab therapy. But why I have highlighted here is that when we started treating them, we were not aware of them. Aseptic necrosis or avascular necrosis of the femur, we were not aware of them. If you the literature is also not that like, you're not informative about these conditions. So they are rare, but you need to be well aware of them. The pulmonary embolism, the infections, the avascular necrosis due to steroids, and you need to tell the patients that they should be aware. It's very important that when you administer the rituximab, you monitor their TLCs and for next 48 to 72 hours, you call them after a week and you see that if they have sent. And when you are sending them home, you tell them that if you have a shortness of breath and the cardiac, at times it is recommended that you need to do the echo also. If you have cardiac effects or the shortness of breath, they should come back and you need to investigate them.
Thank you, Dr. Mahmood, for very elaborated answers. We should wind up this session as we are getting late for next session. So we have become more knowledgeable after this session. Particularly, presentation was excellent. Dr. Tahir Kamal, Dr. Saida Mahar, then General Zafar Saab and Sabzada Mahmood Noor. Very, very luminous lectures. We have become more knowledgeable after this. Let's wind up this session.
I would like to call respected Professor Dr. Khawa Khurshid to come on the stage and give shields to our honorable speakers. Sir, please come on the stage. First, I'd like to call Dr. Tahir Kamal to come on the stage and receive his shield. I would like to call the entire panel of experts to come on the stage for this shield presentation. I'd like to call Dr. Saida Mahnam Ali to come on the stage and receive her shield. Next, I'd like to call Major General Zafar Iqbal Sheikh to come on the stage and receive his shield, please. Now I'd like to call Professor Dr. Sahibzada Mahmood Noor to come on the stage and receive his shield.
Thank you for the intro, Dr. Munifa. I never knew that 2 decades ago a small little girl will be introducing me 20 years later on the stage. Thank you very much.
Now I'd like to ask Sir Khawer to present the shield to the panel of experts. Dr. Afaq Ahmed, respected Dr. Abdul Qudus Bhat, respected Dr. Ghazala Bhat, and last but not the least, Professor Arif Maan. I would also like to ask Professor Arif Maan to present the shield to Dr. Khawer Khurshid. Now, sir, I'd like you to present the shield to our moderator, Dr. Maria Anwar.
Now I ask Dr. Munifa to please receive her shield for moderating the session. With this, we conclude our session. Thank you very much for attending the session.
Assalamu alaikum and Bismillahir Rahmanir Rahim. It is truly a pleasure and honor to see so many esteemed dermatologists gathered in this hall for the scientific session today. Your presence reflects your commitment in the field of dermatology. Welcome to Infectious Insight Advances in Disease Control. In this session, we'll not just talk about the disease, we'll learn how to tackle it head-on with latest advancement in control strategies. Infectious diseases evolve, and so must we. From innovation to implementation, today's talk insights could refine how we approach infectious disease in the world. I'm Dr. Khadija Malik.
And I'm Dr. Shaista Ambreen. We both are consultant dermatologists and representing Jinnah Hospital, Lahore. Our panelists today are leaders whose work has shaped the field of dermatology. Ladies and gentlemen, it is an honor to introduce our truly distinguished figure in the field of dermatology, a mentor to many and a true teacher of teachers, Professor Atif Kazmi Saab. With decades of expertise and a profound impact on advancing dermatological knowledge, Professor Atif Kazmi has guided countless budding dermatologists. Please join me in welcoming Professor Atif Kazmi Saab to stage as a key member of our panel of experts. It is an honor to welcome a distinguished leader in dermatology, Professor Dr. Muhammad Iqbal Tareen. With a remarkable journey of 28 years, he retired as professor after shaping countless careers and advancing the field significantly. He has served as president of Pakistan Association of Dermatologists not once but twice. Professor Tareen remains a guiding light for dermatologists across the nation. Please join me in welcoming him to the stage.
It's an extreme honor for me to invite Professor Khawer Khurshid, a distinguished alumnus of King Edward Medical University. Dr. Khawer is a renowned dermatologist and cosmetologist. He has served at King Edward Medical University and Mayo Hospital for over 35 years. He is currently head of Department of Dermatology at Rashid Latif Medical College. Professor Khawer Khurshid has exceptional contributions to dermatological science. He is renowned for his teaching excellence and has guided more than 60 trainees and still continues to inspire next generation of dermatologists. So kindly grace the stage as one of our honorable panel of experts. Now it is my privilege to introduce a leader and a pioneer in dermatology, Professor Rabia Kapoor. She is head of department at Jinnah Postgraduate Medical Center in Karachi. She has significantly shaped the field of dermatology through her dedication to education, research, and clinical practice. She is known as a master trainer in aesthetic dermatology. She is an inspiration to many in our field. Please join me in welcoming her to the stage as one of our esteemed panel of experts.
It is my pleasure to introduce Dr. Zahid Sheikh. He is assistant professor at GMC Teaching Hospital in Gujranwala. Dr. Sheikh brings a wealth of clinical expertise and a strong commitment to advancing dermatological care through teaching and practice. His contribution to the field make him an invaluable voice in our panel. Please join me in welcoming Dr. Zahid Tahir Sheikh to the stage. It is my privilege to welcome Dr. Lakraj, consultant dermatologist, DHQ Hospital, Mirpur Khas, Sindh, to join our esteemed panel of experts. Dr. Lakraj is a distinguished authority in dermatology, renowned for his groundbreaking contributions and unwavering commitment to advancing knowledge and practice of dermatology. His expertise has earned him a great respect in the academic and professional communities. We are truly honored to have him on stage.
It is our honor to pay tribute to a remarkable figure in dermatology and humanitarian work, Dr. Christine Schmotzer, a medical director of the Aid to Leprosy Hospital in Rawalpindi. Dr. Schmotzer's unwavering dedication to the care and treatment of leprosy patients has transformed countless lives and set a standard of compassion and excellence in the field. Please join us in honoring Dr. Christine Schmotzer with this special tribute video. video was just a small token of appreciation for her tremendous and outstanding contribution in the field of dermatology. Time is our best friend. To ensure everyone gets this time, let's treat time like our favorite friend. Time to pause for the Praveen Nasimani is a highly skilled dermatologist known for her exceptional clinical expertise in the field. She mentioned the field of dermatology. She has been an active advocate for dermatology, global stage, representing the dermatology sector worldwide, senior people as Benson she served as the senior consultant for Mars, where her compassionate care and commitment to the patient and patients made a lasting impact. Specifically, please come and share your thoughts about today's great clinical experience. I am very honored to share that comes from a country where there is and that no disturbances. So forgive me if I do anything unfair here. Today, after such a serious topic, my topic today, KB, might feel, might sound very simple, but thing is involved, we have very less patients. Whatever the patients that maybe we hardly see. But recently, I was in a private hospital and came across four cases, rather four families, and believe me, four KB patients coming in a private treatment involving is the same. Because we just have a population of four now. So I always used to think, what case is so simple, just treat it with permission and it is done. When the patients who are coming to me, they seem to be very anxious and very unhappy with the treatment, and it has been going on for 2-3 months. So I really had to read about it and see where the other doctors were going wrong with these medications. So I tried to discuss a little. So with clinical outcomes and a happy patient, we have to know a little bit about the life cycle of the mind and make a very good diagnosis and know about the complications, treat them, and treat the patient and also give much importance to prevention. We used to think that scabies is not seen in very rich and elite communities, but we have to have a high level of suspicion if clinical findings are consistent. And this is one reason where in Maldives some cases are missed because doctors thought that it is not there in the Maldives. And after reading, I found out that it has been classified by the WHO as a neglected even in the European countries. Now let's think about the life cycle of the wine. The total life cycle is of about 9 to 15 days. It comes in importance because we have to reapply some of the medications, actually all of the medications, and the mice stays outside the house for about 7 days, 3 to 7 days. This is important in eradicating the fomites. And the egg has in 3 to 5 days. Also important for reapplication. And then for termite control, it is important that the mice just killed in as higher than 50%. Clinical findings, actually a diagnosis is very, very simple. No investigations are required actually. The pruritus itching is mostly nocturnal, and the first infestation, the itching may start even 1 month after exposure to the mice, and these infestations may be make them start in 1 or 2 days. And then most important is the clinical features, the barrow. This is the pathognomonic feature, and the rest of the lesions are more like an eczema, exfoliated pathology. And then we have to see the circle of Hebra, the distribution. And infants' face and scalp may be involved, unlike the adults. And this is very important. We have to
or in our case, travel to an endemic area, which is where we usually get our patients from expatriate workers or somebody who has traveled to the region. The when we see the lesions, we try to look at papules which tend to have a little bit of elongation. This is, I feel, very important to see a little bit elongated because that is the burrowing of the mite. Clinical findings, the in-test maybe, but they're not required every time. Some clinical pictures, circle of fibra, the interdigital spaces, the areola, genital area, umbilical area, elbows, axilla are important. Laboratory-based, the skin scrapings, not necessary every time, but can be used in crusted scabies and also if an outbreak in the facilities or if we think that there is a treatment failure. There is a diagnosis criteria to 2020 International Alliance for the Control, confirmed scabies, clinical scabies, suspected scabies, and the history features. Skin scraping. Dermoscopy, there is the fighter jet sign with the front part of the mite looking like a fighter jet. And then skin biopsy usually not needed, mostly it's an incidental finding. The types of presentations can really mislead us sometimes. So the typical presentation is the most common, but the other atypical presentations known as scabies surreptitious, incognito, the crusted scabies, and nodular. Mostly any kind of hypersensitivity reaction type of lesions can be seen, even urticaria, SLA-like also. Mostly the classical scabies, differential diagnosis usually like a dermatitis, atopic contact dermatitis, prurigo nodularis, and so on. But even if we have the slightest doubt that it is scabies, it is better to explain to the patient and treat it, because as we see, all other differential diagnoses can be treated with the same medicines, but in case it turns out to be scabies, it's not going to work. So if in doubt, always treat. The complications, sometimes I've seen that the cases that I saw this year, the complications were not treated, and not because as soon as we make a diagnosis of scabies, we just think of the mite and we don't think about the patient. So just killing the mite is not the only thing, treating the complications also. The most common were infection and then eczematization, because Maldives, there is a lot of atopic patients because of the genetic pooling. So a lot of patients come in very severe itching and severe reactions which go on for a very long time. Some come with sleep disturbances and also socio-economic impact. And there is a social stigma because we don't have scabies much, and then people, sometimes they don't even believe it when we, no, I will not get scabies, I take bath every day. They think that it just comes in the people who don't take bath. And also, I saw one patient where there was a delusion of parasitosis even after the patient had scabies 1 year back. But this year she came back because she was still having the feeling that the mites are still there on her body. So when we treat the patient, we have to reassure about the complications. Taking some time, extra time for it really works. The treatment, so for a full treatment, a happy patient, we have to kill the mite and the eggs and treat the hypersensitivity reaction and treat the complications and prevent reinfestation. Reinfestation can be very common, so we have to take care of it. The anti-scab, so when I read, I just read the same things, almost the same things which I read when I was back in school. So it's still that the topical permethrin 5% is the medicine of choice, and then oral ivermectin, and both together if it is very severe case. And the second line treatment seem to be the same, benzoate, protermethrin, ivermectin, sulfur. And there are some new emerging treatments, topical spinosad and oral moxidectin. Permethrin we'll go a little bit deeper into because that is the most important, and if we have permethrin and give a good advice to the patient, we usually end up with a good success rate. It is on the WHO list of essential medicines, 5% cream or lotion. It is acaricidal and ovicidal. So this ovicidal part is debated. When I read about it, some years back it was said that it is ovicidal and only one treatment is required, and this was the reason of the treatment failure in some of my patients. But it is seen that 80 to 100% with a single application still can be achieved if applied nicely. It is safe and only 2% is applied. It is very safe in pregnancy and safe in children above 2 months of age. Now, how to apply? In adults, an average size adult, 30 gram seems to be enough, but in very large patients with a large surface area, we can even give a little bit more in case he needs it. And in children, head to toe, in infants, the face also has to be applied. We can give a cream from 7.5 to 30 gram, depending on the size of the patient. Now, this I knew this time that the skin has to be dry before application. At least 30 minutes before application, the skin should be dry. And then before wearing clothes, stay for it without wearing clothes for 10 minutes for it to be absorbed. And under the nails, nails should be, make sure that it is applied in the nails. And yes, sometimes when permethrin is applied, there may be a transit increasing in the itching. So we have to reassure the patient proactively. We have to remember to tell them, otherwise the patient will think that we gave some wrong medicine and having a side effect. And it has to be applied for 14 hours. And yes, the second application is needed, and in severe cases, more application are needed. Now, why is the second application advised? Because the 100% ovicidal activity is still debated, and even an insufficient amount may be applied, and some areas may be missed also while applying. And even if the patient goes to the bathroom, they might even wash some areas, the genitals also. And if they don't have extra cream, they could not apply it again. And also, a second application reduces chance of reinfestation from contacts and the fomites, and it also reduces the chance of resistance. I read, and there were some few reports of permethrin resistance, but most of the literature says that it still works nicely. And it has to be simultaneously applied to all the contacts within close contacts within the past 6 weeks. And then the next most important drug is the ivermectin, which is also on the WHO list of essential medicines, but unfortunately we don't have it in Maldives. It is only acaricidal, so needs to be applied 7 to 14 days. And pregnancy category C, do not apply it below 15 kg, and in severe cases more dose is needed. And the second line, the second most effective was benzyl benzoate lotion, and then sulfur, mostly preferred in children. It can be very messy, and protamidine is very good for the pruritus, it seems, so sometimes it is even used in combination treatment. Linden and malathion are highly toxic, so not used now. Some people use essential oils, but mostly in combination. And then emerging treatments, there is a FDA-approved medicine spinosad topical lotion, 0.9%, and it's left on for 6 hours. It contains benzyl alcohol, so should not be used in pregnancy, in breastfeeding, and for children below 4 years not to be used. And another medicine is moxidectin, oral medicine, the same as ivermectin group, but advantage is that it has longer half-life, so it can cover the entire mite life, and but it is still not yet licensed. And there are some newer medications also coming. Crusted scabies has a clinical grading. Always treat the hypersensitivity reactions. Even I've seen that oral steroids are very important in patients already having atopy. And treat the complications. Some people even have to use anxiolytics, and proper counseling explanation, give a little bit more time to the patient, and it works most of the time. Prevention of reinfestation is very, very important because we have to treat the whole family and all close contacts. Disinfection of the beddings and clothing needed at 50 degrees Celsius is usually good. If it cannot be washed, keep in a plastic bag or avoid using it for 3 to 7 days. Make sure we explain that also to the patient. And follow-up treatment can be done in 4 weeks. If there are new burrows or new lesions, new symptoms, we can think of a treatment failure and start again or consider our diagnosis again. We have to notify the authorities because this is one of the cases that I saw this year. The patient had gone to Hajj and then it seems there was a breakout in the same group. And proper counseling, always proper counseling works a lot. So for the summary, I'll just summarize. We have to remember that anybody can get scabies, and diagnosis is very simple. And look out for the burrow. Treat with antiscabitic even in suspicious patients. And permethrin works most of the time. Second dose is required 7 to 14 days after the first one. And always treat the hypersensitivity reactions and the complications, and avoid reinfestation as much as possible. Thank you for listening to me. I appreciate this chance given to me so much. Thank you.
Thank you, madam, for a wonderful talk. I have the privilege of inviting our esteemed guest speaker, Professor Zahida Rani. She is currently head of Dermatology Department, Lahore General Hospital, Amiruddin Medical College, PGMI, Lahore. She has served as editor JPAT since 2019 and has 60 publications to her credit. Ma'am has over 25 years of experience as a dermatologist. Today, she'll give a comprehensive talk about fungal infections and drug resistance. Ma'am, please come on stage and enlighten us with your pearls of knowledge.
Thank you very much for your kind words. माशाल्लाह सारे यहाँ पे knowledgeable हैं. I'll try my best कुछ share कर सकूँ English में. Resistant dermatophytosis की बात करेंगे. इससे पहले जो कि क्रिस वाटसन को डेडिकेट कर रहे हैं ये सेशन, तो I've had an opportunity to work with her when I was in Lyon, और leprosy जो section था, I was in charge of that. She's a very dedicated और माशाल्लाह जैसे इतनी उनकी खिदमात हैं, और I find it very fascinating that she dedicated her whole life to serving humanity. It's very commendable. तो माशाल्लाह कंटिन्यूस एफर्ट्स उनकी चलती हैं, और वो लेप्रेसी भी सिखाने. शी इज़ बेसिकली ए गायनेकोलॉजिस्ट जो उनकी स्पेशलिटी है, लेकिन जो लेप्रेसी लेप्रेसी हॉस्पिटल में वहाँ पे वो सर्जरीज भी कर रही हैं, और गायनी का ट्यूबरक्लोसिस भी, एवरीथिंग. डर्मेटोफाइटोसिस मुझे इन रेजिस्टेंस का इसलिए याद है कि आई वॉज पोस्टेड इन सियालकोट इन 2016, और सियालकोट में आई स्टार्टेड ऑब्जर्विंग पेशेंट्स जो दे वर कमिंग बैक विद फंगल इन्फेक्शंस अगेन एंड अगेन विद ट्रीटमेंट. तो I would come to Lahore and I would discuss with my colleagues कि never in my clinical experience prior to this year 2016 कि never a patient would come back और कहे कि मुझे फंगल इन्फेक्शन जो है वो दोबारा हो गई है. We used to give treatment for 1 week, 2 weeks and patient would cure. लेकिन अचानक ये उस टाइम पे ये एक प्रॉब्लम अराइज हुई, हम लोगों ने ऑब्जर्व करनी शुरू की, और फिर आहिस्ता आहिस्ता हमने आर्टिकल्स देखे, रिसर्च पेपर्स, और हमें पता लगा कि ये सिर्फ हमारे ऑब्जर्वेशन नहीं है, ये दुनिया में बाकी जगहों पे भी ऐसे हो रहा है कि फंगल इन्फेक्शन जो है वो रेजिस्टेंट होती जा रही है थेरेपी से. اب ریزسٹنس کیسے ہو رہی ہے؟ فنگل انفیکشنز کرونک ہوتی جا رہی ہیں، نان رسپانسو ہیں، آپ تھیراپی دیتے جاتے ہیں، تھوڑا ٹھیک ہوتا جاتا ہے، اور مریض آپ کو کہتا ہے آج میں نے دوائی بند کی ہے، یہ دیکھیں 2 دن کے بعد مجھے ویسے کی ویسی ڈیزیز دوبارہ ہو گئی ہے. تو یہ ایک سیریس ایشو ایک اسٹارٹڈ ڈیولپنگ، اور جو ڈومیننٹ پیتھوجن ملا آل اوور دا ورلڈ، انفارچونیٹلی ہم تو نہیں اس کے اوپر فنگل کلچر کی ریسرچ زیادہ براڈلی کرتے، لیکن ٹرائکوفائٹون جو ہے اس کے ریزسٹنٹ سٹرینز ملنے شروع ہوئے، اور ہمیں یہ نظر آیا کہ ڈیزیز بہت ایکسٹینسو ہوتی جا رہی ہے، ملٹیپل سائٹس کو انوالو کر رہی ہے، اور اسٹینڈرڈ جو ڈوزج ہے اس کو رسپونڈ نہیں کر رہی اور فوراً ریکر کر جاتی ہے. اب جو ملا ہمیں پیتھوجن اس میں، وہ یہ اسٹڈی یو ایس اے کی ہے، جہاں انہوں نے دیکھا کہ 3 جو اسٹرینز ہیں وہ زیادہ پرابلم کر رہی ہیں، اور ٹرائکوفائٹون انڈوٹینیا ہے، ٹرائکوفائٹون منٹیگروفائٹ جینوٹائپ 7، اور ٹربینافین ریزسٹنس ڈیولپ ہوگی ٹرائکوفائٹون روبرم میں. اور یہ بڑا انفارچونیٹ ہوا کیونکہ فنگی سڈل ایک ہی تھی ہمارے پاس. جو ٹرائکوفائٹون انڈوٹینیا ہے، یہ ایک ٹرائکوفائٹون منٹیگروفائٹ کی سب ٹائپ اس کو سمجھا جاتا ہے، ٹھیک ہے، لیکن اب یہ ایک اپنی انڈیپینڈنٹ، اٹ ہیز اٹس اون انڈیپینڈنٹ کلاس، اور اس کی ڈیزیز بہت سویئر، زیادہ ایریا کور کرتی ہے، زیادہ انفلیمیشن کرتی ہے، اینڈ ویری ڈیفیکلٹ ٹو ٹریٹ. اور ڈائگنوز کیسے کرتے ہیں؟ ڈائگنوسس پہ خیر میں آگے آپ کو بتاتی ہوں کیوں یہ ہونا شروع ہوا. اب اس کی بہت زیادہ لوگوں نے اس کے اوپر ریسرچ ہوئی کہ ایسا کیوں ہو رہا ہے. یہ کیا پیشنٹ ٹریٹمنٹ نہیں لے رہے ٹھیک طریقے سے، یا فیملی ممبرز ملٹیپل افیکٹڈ ہیں اور وہ سارے ایک کو آپ ٹریٹ کرتے ہیں اور دوسرے کو لگا دیتے ہیں، یا لوگوں کی ہائیجین پور ہے، یا ٹاپیکل اسٹیرائڈس کا یوز زیادہ ہے، یا ڈیزیزز کو موربیڈیٹیز زیادہ ہیں، یا ایکچولی ریزسٹنس پیدا ہو رہی ہے. تو پیڈکون کی ایڈمنسٹریشن کے ان کا شکریہ کہ انہوں نے 2 دن پہلے فوکس گروپ ایک بنایا ریزسٹنٹ ڈرمیٹوفائٹوسس کے لیے. تو اس میں بھی یہ ساری چیزیں ڈسکس ہوئی کہ سارا کچھ جو ہے وہ سب کا سب کنٹریبیوٹ کر رہا ہے ریزسٹنٹ ڈیزیز میں. آپ کے پاس اینٹی فنگل سے ریزسٹنس بھی پیدا ہو چکی ہے، پور ہائیجین بھی ہے، پور ایڈہرنس ٹو ٹریٹمنٹ ہے سوشو اکنامک ریزنس کی وجہ سے، اور ملٹیپل فیملی ممبرز انوالو ہیں جو سارے کے سارے ٹریٹمنٹ نہیں کرتے. یہاں پہ میں ایک ذکر کروں گی ڈاکٹر فرزین کی ٹاک کا بھی، شی ٹاکڈ اباؤٹ اسکیبیز. اور اب ہم یہ دیکھ رہے ہیں پچھلے 2 مہینوں سے، میرا خیال ہے بہت سارے لوگ ایگری کریں گے کہ وی آر سینگ مور اینڈ مور پیشنٹس آف اسکیبیز. سو وی should be ready for an epidemic of scabies as well. کے ساتھ ساتھ یہ بھی چل رہا ہے. تو ٹاپیکل کورٹیکوسٹیرائڈ کے یوز نے ایک پرابلم کریٹ کر دی، اسکن تھننگ ہونی شروع ہو گئی، اسکن کا بیریئر فنکشن جو ہے وہ ڈیمیج ہو گیا، اینڈ دا فنگس اسٹارٹیڈ گیٹنگ روٹس ان ٹو دا اسکن اینڈ اٹ واز ڈیفیکلٹ ٹو ریموو دیٹ. اس میں 2 طرح کی ریزسٹنس دیکھی گئی. ایک دیکھی گئی مائکروبیل ریزسٹنس اور ایک دیکھی گئی کلینکل ریزسٹنس. کلینکل ریزسٹنس کا مطلب یہ ہے کہ آپ نے پیشنٹ کی اسکریپنگ کر کے، فنگس اٹھا کے، کلچر کر کے، سینسٹیوٹی دیکھی، اور آپ کو پتہ لگا کہ یہ ڈرگز جو ہیں وہ سسیپٹیبل ہے آرگینزم، اور پھر آپ نے وہ اینٹی فنگل دی اور کوئی رزلٹ ہی نہیں آیا. تو اس کا مطلب ہے کہ ڈرگ ریزسٹنس کے علاوہ ادر فیکٹرز بھی چل رہے ہیں. اور ہمارے یہاں انفارچونیٹلی جو سب سے امپورٹنٹ فیکٹر ہے وہ اسٹیرائڈ کا یوز ہے بہت زیادہ. کہ آپ کے پاس جب مریض پہلی دفعہ بھی آتا ہے نا، تو آپ کو پتہ ہوتا ہے کہ وہ اسٹیرائڈ اور اینٹی فنگل کا کمبینیشن یوز کرتا ہوا ہے اور بہت لمبے عرصے سے یوز کرتا ہوا ہے. تو وہ اس کی اسکن میں ایسی ریزسٹنس پیدا ہو گئی ہے کہ اب اس کی ڈیزیز ختم نہیں ہوتی. اب ہمارے پاس چیلنجز کیا کیا ہیں؟ ہم نے دیکھنا ہے کہ ریزسٹنس کے کیا میکینزمس ہیں، اس کی کلینکل امپلیکیشنس کیا ہیں، ڈائگنوسٹک ڈیفیکلٹیز کیا ہیں، اور تھراپیوٹک لمیٹیشنس ہماری کیا ہیں۔ اب ریزسٹنس کے کازز جیسے آپ کو پہلے بھی بتائے، لیکن یہ کچھ اور کازز ہیں، جیسے یہ بھی کہا گیا کہ یہ بھی ریسرچ نے کہا کہ اگر آپ اینٹی فنگل کی ڈوز جو ہے وہ اپروپریٹ نہیں دیں گے، ڈوز ان ایڈیکویٹ ہے، ٹائم شارٹ ہے جس کے لیے آپ نے اینٹی فنگل دیا ہے، تو ریزسٹنس پیدا ہو جائے گی، نہیں رسپانس آئے گا۔ آپ کی پیشنٹ کمپلائنس پور ہے، سوشو اکنامک ریزنس کی وجہ سے پیشنٹ کچھ دن کے لیے لیتا ہے۔ بہت سارے مریض ایسے آتے ہیں جن کو سالہ سال سے فنگل انفیکشنز ہے، اور وہ آ کے کہتے ہیں کہ ڈاکٹر صاحب جس دن زیادہ تکلیف ہوتی ہے اس دن ہم ایک کیپسول کھا لیتے ہیں، اور اس کے بعد پھر ہفتہ گزر جاتا ہے، پھر لیجن نکلتا ہے، پھر کھا لیتے ہیں، اور ریزسٹنٹ اسٹرینز آ گئی ہیں ہمارے پاس۔ اب ڈائگنوسٹک ڈیفیکلٹیز کیا ہے؟ میں لاہور جنرل ہاسپٹل میں ہوں، وہاں پہ ہم نے یہ پلان کیا کہ ہم دیں گے اپنے اسٹوڈنٹس کو ان کی ٹریننگ کے ایز پارٹ آف دیئر ٹریننگ کہ فنگل کلچر کریں۔ تو یہ سرپرائزنگلی ہم نے بہت ساری لیبارٹری سے پوچھا، اور انہوں نے کہا کہ ہاں ہم کلچر آپ کو کر کے دے دیں گے، ہم آپ کو سینسٹیوٹی نہیں چیک کر کے دے سکتے، ہمارے پاس کٹس ہی نہیں ہے سینسٹیوٹی چیک کرنے۔ یہ اتنی حیرانی کی بات ہے کہ اب کیا کریں؟ اب مریض کو آپ نے کون سی دوائی دینی ہے اور کس سے اس کو ٹھیک کرنا ہے؟ آپ کے پاس کوئی یہاں پہ سورس ہی نہیں ہے، تو وہ اس کے لیے اب ٹرائی کر رہے ہیں کہ ہمیں ایسا ملے۔ پھر پی سی آر کیا جا سکتا ہے اس کے لیے، کٹس اویلیبل ہیں پی سی آر کرنے کی، یہ ہاں ڈائگنوسس امپروو کریں۔ تو یہ میں نے نیٹ سے اٹھائی کہ ریپڈ آئیڈینٹیفیکیشن آف پیتھوجن کے لیے کلچر سینسٹیوٹی آپ کر سکتے ہیں۔ یہ تینوں کے تینوں جو اینتھروپوفلک، زوفلک اور جیوفلک ہے اسپیشیز ان کے لیے، لیکن یہ کٹ اویلیبل فار ڈاگز اینڈ کیٹس، ویٹنری میڈیسن میں یہ کٹس اویلیبل ہیں، میں نے ہیومنس کے لیے نہیں دیکھا۔ پھر یہ ہیومن کے لیے ڈرمیٹوفائٹ پی سی آر ٹیسٹنگ کٹ اویلیبل ہے کہ یو کین یوز دیٹ فار ریپڈ ڈائگنوسس، لیکن یہ بھی ہمارے ہاں نہیں یوز ہوتا یہ کہ ڈائگنوسس ہم چونکہ اسپیشیز کا نہیں کرتے، تو اب ہمیں نہیں پتہ کہ ہم ٹربینافین ریزسٹنٹ اسپیشیز ہے اس کو تو نہیں ٹربینافین سے ٹریٹ کرنے کی کوشش کر رہے۔ پھر اب ایک تو ہمارے پاس ڈائگنوسٹک ڈیفیکلٹیز ہیں، ہم بالکل ہی نہیں جان سکتے۔ پھر ہمارے پاس تھراپیوٹک لمیٹیشنس بھی ہیں، ہمارے پاس 4-5 اینٹی فنگل تو ہیں، اس سے زیادہ تو ہے نہیں، انہی میں گھوم پھر کے انہی میں ہی ہم نے پلے کرنا ہے۔ اور ایک اگر آپ کی میجر جو ہے ٹربینافین اس کی ریزسٹنس اتنی زیادہ ڈیولپ ہو گئی ہے، تو اب آپ کیا کریں آگے؟ آپ کے پاس بہت سارے آپشنس تو اویلیبل ہیں، لیکن وہی بات ہے کہ جو کہ انیڈیکویٹ ڈوزیج پیشنٹس یوز کرنا شروع کر دیتے ہیں، تو وہ پھر ریزسٹنس ان سے بھی آپ کو ملنی شروع ہو جاتی ہیں۔ اور پھر ناول اینٹی فنگلز آ گئی مارکیٹ میں، بہت ساری آنا شروع ہوئی، وہ بھی استعمال ہو رہی ہیں، لیکن پھر ہمیں یہی نظر آتا ہے، پھر ہم نے آلٹرنیٹیو تھیراپیز کا بھی سوچا، لیکن بات گھوم پھر کے یہی آتی ہے کہ مریض ہمارا نہیں ٹھیک ہوتا، اور مریض اب تو آتے ہیں اور وہ کہتے ہیں کہ ڈاکٹر صاحب 5 سال سے چل رہا ہے یہ سلسلہ، اے سمٹومیٹک ہو جاتا ہے، کیور نہیں ہوتا، پھر ہم گزارا کرتے رہتے ہیں، پھر ٹریٹمنٹ شروع کرتے ہیں۔ اور جو گھر کے ممبرس کی بات ہے، جیسے میرے پاس پچھلے دنوں ایک فیملی آئی، تو وہ 13 ممبرز آف دا فیملی تھے، 13 ممبرز اینڈ 11 آف دیم ور انفیکٹڈ ود وائڈ اسپریڈ ٹینیا۔ اب پریونشن کیسے کرنی ہے؟ کیا گڈ ہائیجین پریکٹسز، شیئرنگ پرسنل آئٹمس کو چھوڑ دیں ہم؟ اس میں بھی سرپرائزنگلی شاید باقی لوگ بھی اپنا ایکسپیرینس شیئر کریں کہ ایون پارٹنرز میں ایک پرسن جو ہے وہ زیادہ افیکٹڈ ہوتا ہے اور دوسرا پرسن بہت شارٹ ٹرم میڈیسن لے کے کیور ہو جاتا ہے، اور پھر ڈسپائٹ لیونگ ٹوگیدر، جیسے کپل کی بات ہو رہی ہے، ہسبینڈ اینڈ وائف، ڈسپائٹ لیونگ ٹوگیدر ون آف دا پارٹنر وڈ بی افیکٹڈ اینڈ دا ادر ان افیکٹڈ فار ایئرز اینڈ ایئرز۔ پھر کاٹن کے کپڑے، وینٹیلیشن، شاورز، اینٹی فنگل پاؤڈرز، کپڑوں کو گرم پانی سے دھونا، دھوپ میں سکھانا، ہیلدی ڈائٹ لینا، اور پیٹس देखना, जैसे उस दिन भी बात हुई हमारे फोकस ग्रुप में, प्रोफेसर खावर खुर्शीद थे, कि अब एक ट्रेंड बन गया है कि पेट्स रखे हुए होते हैं, डॉग्स एंड कैट्स और वो सारे, तो वो उनको भी तो एक दफ़ा चेक करा लें कि उनको तो नहीं फंगल इन्फेक्शन जो ट्रांसफ़र कर रहे हो। और क्या चीज़ नहीं करनी, ये मरीज़ों को बताना भी बहुत ज़रूरी है कि क्या नहीं करना। और इसके लिए तो जैसे जनरल पब्लिक अवेयरनेस प्रोग्राम्स हमारे होने चाहिए, और जीपीज़ को ट्रेन करना चाहिए कि क्या क्या चीज़ें उन्होंने नहीं करवानी मरीज़ों से। फिर एंटी फंगल ड्रग थेरेपी की गाइडलाइंस अवेलेबल हैं ऑनलाइन, आप वो गाइडलाइंस जो है वो फॉलो करें तो ज़्यादा चांसेस हैं कि पेशेंट को आप क्योर कर सकें। तो रेजिस्टेंट डर्मेटोफाइटोसिस जो है वो बहुत सिग्निफिकेंट चैलेंज है इस वक्त हमारे लिए, और सॉल्यूशंस रिक्वायर अ मल्टी फेसेटेड अप्रोच, और रिसर्च करते रहना चाहिए हमें, और कोशिश करते रहना चाहिए कि हम इसको सॉल्व कर सकें। तो आर्टिकल सारी दुनिया में छप रहे हैं, तो मैंने कहा मैं बता दूं कि हमारे जर्नल में भी आर्टिकल छपे हैं ये डर्मेटोफिटिक रेजिस्टेंस के हवाले से और उसकी गाइडलाइंस के हवाले से। इन आई एंड my lecture with a picture of friends sitting together, and all power to teamwork. Thank you very much.
Thank you, ma'am, for such an insightful talk. Now it's time to gain some insights from Dr. Anam Ashraf, who is working as Senior Registrar Dermatology Department at Shalimar Hospital, Lahore since 2019. Dr. Anam is a skilled dermatologist and cosmetologist. She has special interest in promoting academics. She will deliver a talk today on the treatment options of recurrent and recalcitrant dermatophytosis. Dr. Anam, kindly come on stage and share your wisdom with us.
Respected panel of experts, esteemed colleagues, and distinguished guests. Assalamu alaikum. It's an honor to stand before you today at 43rd PADCON 2024 to discuss a topic of rising concern in our field, a challenge of resistant dermatophytosis. I am Dr. Anam Ashraf, working as dermatologist and senior registrar at Shalimar Medical and Dental College, Lahore. Today, I will be sharing my insights into the efficacy of an alternative treatment approach, pulse itraconazole therapy, in combination with isotretinoin in such cases, and discuss the outcomes in improving the efficacy in such cases. So, as already the topic has been discussed in detail by worthy Professor Dr. Zahid Arani, so I will quickly rush through my slides. So, fungi, we all know, are eukaryotic, heterotrophic, uni or multicellular organisms. They are either yeast, molds, or have dimorphic morphology. They penetrate superficial epidermis and they may invade deeper, leading to superficial subcutaneous or deep systemic mycosis. Tinea are filamentous fungi. They invade and feed on keratinized tissue, and three genera, Microsporum, Trichophyton, and Epidermophyton, causes infections of skin, hair, and nails. These may transmit through infected humans, pets, and environment, and obviously the risk increases when there is warm and humid areas, overcrowding, and immunocompromised states. Worldwide prevalence is 20 to 25%. In Pakistan, the exact prevalence is not known. However, few individual studies reported it around 31 to 38%. It has various clinical features depending upon the site of involvement. Diagnostic workup includes microscopic smears, cultures, Woods-M may help, and sometimes we perform histopathology and genomic sequencing. A variety of antifungals are available, as already been described by Dr. Zahid Arani, including azoles, allylamines, polyenes, echinocandins, and among those, allylamines and the very famous terbinafine was once considered a treatment of choice. These act at various levels, leading to enzyme inhibitions or disruption of cell membrane or microtubule assembly. So what causes treatment failure in labs? There are various factors. Madam has already explained. Poor compliance, recurrent exposure with contacts, misuse of steroids, antiseptics. There are individual susceptibilities for these antifungals, and our concerning emerging new species and resistant strains. So how this resistance occurs? In case of terbinafine, it is reported mainly due to targeted mutations in squalene gene, which encodes the enzyme squalene epoxidase, which is the main target of terbinafine. Other causes may include increased drug reflux, drug degradation, overexpression of chaperones, and biofilm formation. So, this terbinafine resistance, initially reported in India, has now become a global health concern because of rising healthcare costs, limited treatment options available, and high mortality rates in immunocompromised patients. This graph shows resistant dermatophytosis across various countries, and we can see that India is the main target. Among strains, Trichophyton rubrum, Indotini, and Interdigitale are the commonest ones. So how to identify the resistance? It may be a clinical diagnosis or through in vitro antifungal susceptibility testing by measuring minimum inhibitory concentrations or through genomic sequencing. Talking about itraconazole, it is a triazole causes inhibition of 14-alpha demethylase, leading to impaired sterol synthesis and cell membrane disruption. What is the role of isotretinoin? In a normal epidermis, it increases the cell turnover, leading to loss of proliferating dermatophytes. It increases skin pH that causes inhibition of fungal growth, and its immunomodulating properties like increased number of helper T and natural killer cells causes increased phagocytosis of these fungi. So as these resistant strains do not show cross-reactivity, we conducted a study in our department with an objective to determine the efficacy of oral monthly pulse of itraconazole with adjuvant daily low-dose isotretinoin in treatment of such cases. It's a quasi-experimental study over 6 months duration in our department. 60 patients of either gender and age 18 years of above were enrolled in our study, having tinea corporis or cruris involving more than 30% body surface area and a disease duration of more than 3 months. They either had a history of recurrence within 6 weeks of stopping the treatment, or they showed absolutely or no or very partial response to the adequate antifungal treatment given for a duration of more than 6 weeks. Patients having less than 30% body surface area, pregnant and lactating females, those having comorbidities, immunocompromised states, metabolic derangements, or drug hypersensitivity reactions were excluded from our study. So we kept it very simple. We prescribed oral itraconazole 200 milligrams twice daily for 7 days a month for 3 months, along with daily 20 milligram isotretinoin for 3 months. We recorded the baseline as well as serials, CBC, LFTs, and triglyceride levels in these patients. Worst area was selected as a target, and we calculated a clinical activity score comprising of erythema, pruritus, and scaling from 0 to 3 grade at baseline, serially, and finally after 6 weeks of treatment. Efficacy was declared when there was a complete clinical or mycological cure, no relapse after 6 weeks of stopping treatment, and a clinical activity score of nearly 0. So coming to the results, mean age in our study was 36.3 years. 55% were male and 45% were female, with a mean duration of illness of 6.83 months. We achieved efficacy in 88.3% of cases. 53 out of 60 patients achieved a cure with a mean clinical activity score of 0.16. We stratified efficacy for different variables and found that age, gender, family history of contacts, pets, or occupational status did not affect the outcome of our study statistically. However, diabetes has a negative impact. Only 71% of patients who were diabetic showed efficacy, as compared to 93.5% of patients who were non-diabetic. We compared our study with various studies done between 2018 and 2023, and these studies had similar treatment regime, and they reported efficacy between 89.5 to 97.5%, which was quite comparable to our study. We simulated our study with Rahman et al., who used similar regime. However, Khattab et al. Gave the similar treatment for 6 weeks, and efficacy was less in that case, only 70% as compared to our study. There were certain studies who done randomized controlled trials using 2 groups, one taking only itraconazole, but efficacy in the combined group was reported to be significantly higher as compared to the alone group. So in the end, we concluded that combination of pulse itraconazole therapy with adjuvant isotretinoin may have a promising potential in managing resistant and recalcitrant dermatophytosis. And it provides a hope because we recommend that we should conduct studies at larger levels using controlled trials with a bigger sample size to measure its efficacy. Because we have very limited number of oral antifungals, and I personally believe that antifungals like oral voriconazole should be kept as a last resort. So thank you so much. It was all from my side. I hope I delivered my message.
Thank you so much, Dr. Anand, for such a nice talk. Now, let's turn our attention to an important and often overlooked issue. I invite our very own Dr. Hira Tariq. She is working as Assistant Professor of Dermatology at Services Institute of Medical Sciences. She has special interest in derm pathology and research. Dr. Hira, please come and shed light on the unique dermatological challenges faced by underprivileged communities and the critical need for attention in these areas. Please, ma'am.
Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. I'm Dr. Hira Tariq, Assistant Professor Dermatology at Services Institute of Medical Sciences. We at Services Hospital are in regular practice of doing community projects to care for the uncared people, the marginalized population. This year our target for people who lived in such almost uncovered shelters or jhompris or tents, whatever you call it. We wanted to feel their plight, their living conditions under such circumstances. So ladies and gentlemen, around 12 million people in Pakistan are bound to stay in these areas, especially in the capital cities like Lahore, Karachi and Islamabad. Even in Lahore itself, we have more than 300 slums and squatters, and per kilometer on an average 400 people are bound to live in these conditions of substandard housing, overcrowding, lack of basic amenities like sanitation and sewage, environmental issues like living beside animals and open pots, economic hardships of being unemployed or involved in begging, and social marginalization from the rest of the urban community. So our target was skin health of slums population, from understanding to intervention, surveillance and prevention. And we put forward our projects to International League of Dermatological Societies, ILDS, and Punjab government. And luckily we were accepted for international grant by ILDS this year. So our objective was to study the prevalence of skin diseases in slum area of Johor Town Expo Center, right behind this beautiful building. We wanted to identify common dermatosis suffered by this population in order to evaluate the impact of environmental and socio-economic factors on this population, and to propose potential interventions, recommendations and solutions to improve their quality of life. Our methodology included a cross-sectional study involving the residents of slum area Johor Town, and we conducted surveys, interviews to gather information on skin health, living condition and their socio-economic status. The data were analyzed later on. Ladies and gentlemen, please imagine the plight of living beside animals. Unfortunately, there were less people and more animals in this area. So we arranged a free medical camp in this area. We conducted surveys, we conducted interviews, examined them, treated them for their conditions, and gave them free medicines as much as we could. Coming to our observations, we had a total of 106 patients out of a population of 285 that made a prevalence of 37.2%. Most of the patients were less than 20 years of age with a female preponderance, and most of the patients, more than 40% of the patients had a family history or contact positive. Coming to their occupation status, most of the patients were unemployed or involved in begging, followed by housewives, laborers. Only 6 were students, 5 were drivers, and 1 was salesman in a nearby store. Education status, unfortunately, most were not educated at all. Say 8 were educated till middle and 1 had done its matriculation. Coming to overcrowding, only 4 patients belonged to tents which were occupied by less than 3%. More than 90% had 3 to 8 persons per tent, and 11 had to accommodate more than 8 persons per tent. Sanitation and sanitary conditions, open holes and bricks were used brick pits were used by most of the patients. There was 1 lavatory for 200 people and 1 lavatory for 75. Income for most of the patients were less than 500 rupees per day.
This is one of the primitive lavatory that these people were using, unfortunately. This was the sewage and sanitary conditions over there. Although they knew that cleanliness and hygiene was better for them, so they were taking 2 to 3 times a week, a bath frequency of 2 to 3 times a week. Unfortunately, most of them had never seen a doctor for their skin disease, and 80% of them had moderate to very large effect on the DLQI, their disease-related quality of life. Frequency of this dermatosis, most of these patients had scabies, followed by eczema, pediculosis, and tinea. So as expected, we can see that infections was the major chunk of diseases. We had special equipment for pediculosis and scalp disorders in this patient. We wanted to put up a qualitative impact into the study, and so we asked them about how satisfied they were with their living conditions, their housing conditions, and other areas of improvement. And to our astonishment, most of them were more than happy with their condition and did not want to shift their place of living. Another observation was that most of the women were suffering from steroid-induced, whitening cream-induced rosacea, but they came to us not to get their skin treated, but to get whitening creams. So they were happy with their living conditions, but not with their skin color. So we had a child with post-tenea capitis scarring. We had a patient of DLE and post-acne scarring. Coming to confounding factors, congested tents were significantly more prevalent of scabies, and so were unemployed inhabitants, income less than 500 rupees per day, and age less than 20 years. Coming to discussing our results with the results in the region, in Jammu, the prevalence of skin diseases in slum areas was noted to be 20%. Most of the chunk was by eczemas, followed by fungal infections. In northern India, infections and infestations accounted for 33%, destroyed close to our observation. In Sumatra, Indonesia, and Ethiopia, the frequency varied from 50 to 80%. Obviously, congestion, lack of sanitation, hygiene practices, lack of education, access to healthcare facilities, all added to their misery. So our recommendations and interventions required are public health initiatives to improve sanitation and hygiene practices, community education to make them aware of the situation and to take preventive measures, providing healthcare services in order to increase making more mobile clinics and outreach programs for this population. So we know that skin diseases are very common due to congestion and poor sanitation. However, the major responsibility comes to the stakeholders' shoulders to improve the housing conditions, sanitation, and healthcare facilities of this marginalized population. Policymakers, healthcare providers, and community leaders need to join hands for the betterment of this community. Because, ladies and gentlemen, this country cannot be a good place to live in for any of us unless we make it good for all of us. In the end, I would like to thank my department, Professor Faria, and especially our postgraduate residents and house officers who took very active and enthusiastic role in this project in order to decrease the pain and poor condition of this patient as far as at least the skin conditions were concerned. I thank you all for your patience.
Thank you, Dr. Hira, for an informative talk. I would now like to invite Major Dr. Anjum Hassan to deliver his talk on a very important topic of the treatment of ulcerated cutaneous leishmaniasis with PRP gel and glucantine therapy. Major Dr. Anjum is currently working as consultant and head of Department of Dermatology at CMH Kohat. He has served in United Nations and received UN Certificate of Excellence. Dr. Anjum has around 30 research publications. Dr. Anjum, kindly join us on stage and honor us with your talk.
Comparison of PRP gel and glucantine combined with glucantine monotherapy in the treatment of ulcerated cutaneous leishmaniasis. I'll try to wrap up my presentation in 9 minutes. cornerstone of the cutaneous dyspnea management. It still requires prolonged treatment, which may extend up to months, and ulcerated cutaneous dyspnea is particularly an important cause of chronic non-healing ulcers, especially amongst the young population where we are working right now, the KPK, that area. To the best of our knowledge, very negligible to no amount of work has been done in Pakistan regarding the assessment of the efficacy of PRP gel in ulcerated tissue. Now, the objective of our study was to compare the efficacy of PRP gel and glucantime with glucantime monotherapy in the treatment of ulcerated cutaneous dyspnea. This randomized comparative intervention trial was conducted at Department of Dermatology CMH Bhopal over a course of 1 year after 2 years of institution. 60 individuals with ulcerating test were excluded from the study. So in group A, a total of 60 patients, overall we included a total of 60 patients, and in group A, those 60 patients were randomly assigned into two groups. In group A, weekly PRP gel dressing was combined with the glucantime injection, while in group B, only glucantime was administered on daily basis. In both the groups, the patients were monitored weekly ulcer chart, the presence of induration, photographic evaluation, and the adverse events of both the treatment modalities. The number of in-hospital days and total number of injections in both the groups were also recorded and prepared. Now, this short video will show the process of PRP gel making and how we are doing. We did the PRP gel dressing. So first we take the 20 ml of whole blood in an aseptic environment, and we take this blood and put in plain CD bath tubes without any anticoagulant, because we want the blood to be clotted and make it in a gel. We just put it in a centrifuge, and we centrifuge it for 10 minutes for a soft spin of 1000 to 1500 RPM, followed by a hard spin of 15 minutes for 3000 to 4000 RPM. After that, we prepare our dressing equipment, dressing equipment, and following that, we're going to clean the ulcer with povidone iodine, drape it. Now is the time to take out our PRP gel. We take it carefully, take it out with forceps and cut the upper part with scissor so that the blood clot is separated, and apply directly on the ulcer. The same process is repeated for rest of the tube so that maximum area of the ulcer is covered. Now we are applying liquid paraffin gauze in order to ensure the moisture of the dressing. We're going to place gauze and grip bandage to complete our dressing process. The dressing is going to stay on the wound for a 1 week duration, and we are going to instruct our patient to report any sensation of burning or pain so that we could avoid any complications. The patient is also instructed to avoid any contact with water or dust. Data collection was carried out and the analysis was done through the latest SPSS model. The next few slides are going to show our results. So out of total 60 patients, most of them were young adult males with a mean age of 29.2 years. In both the groups, the age of patients was comparable. And this is an important table. This table shows that the average number of injections used in PRP gel group was significantly lower than glucantime monotherapy group. Okay, so in the upper part of the table, you can see that there is a significant decrease in the requirement of the glucantime injections. Similarly, the number of in-hospital stay was considerably reduced in PRP gel group. However, this difference was statistically not significant. Another important thing is in the PRP and glucantime group, majority of the patients received less than 20 doses, while the majority of the patients in glucantime monotherapy received more than 20 doses. The average side effect profile in both of the treatment modalities was comparable. Around 2 to 3 patients in both groups were suffering from raised LFTs. However, this was tackled with stopping the injection for a while and then reintroducing the LFTs. This slide shows some of our results. You can see that around 75% of the cutaneous leishmania ulcer were declared healed after 3 sessions of PRP gel. That is 21 days. Another patient, this 2 sessions, and this one had to undergo 3 sessions of PRP gel. Another result. This particular patient, he was advised surgery for his cutaneous leishmania. He was advised to undergo, the resection of his finger amputation by a quack in Karak, but luckily he narrowly escaped, and through combination therapy, he was doing pretty well. Another female patient, which has had 2 female patients. There's another result. These particular patients are currently undergoing treatment, and we have started this combination regimen where weekly PRP gel dressing and intralesional time injections are administered on outdoor basis, resulting in considerable decrease in inpatient workload as well as minimizing the health-related loss of working hours, especially in young soldiers who have to work in operation areas and they have to be there for performing their duties. These 2 patients are again undergoing the same treatment. 2 examples of such patients. Both of these patients had just 1 session and are currently still under treatment. So, coming to the literature review, we know that partial or poor response of cutaneous leishmania to standard antimony treatment may be caused by various host and parasite factors. Therefore, we still have to look for additional healing effects of novel agents to accelerate the infection clearance and wound healing process. PRP gel, due to its higher concentration of growth factors, seems like a good candidate for a clinical dilemma like chronic ulcerative leishmania. To the best of our knowledge, this study is the first of its kind performed in Pakistan. There was another study that was performed in Iran. It was a single-arm study without any control group. Nevertheless, that study also reported the efficacy, the positive role of PRP gel in ulcerative cutaneous leishmania. We also know that various studies have reported that PRP provides a high level of growth factors and cytokines, which act synergistically to increase the fibroblast, vascular, and extracellular matter proliferation, ultimately resulting in wound healing. In addition to growth factors, platelet gels contain white blood cells and biologically active substances such as serotonin, catecholamines, etc. And there is also a hypothesis that platelet gel can have an immune modulatory role in eliminating the microbial agents. The role of growth factors, including platelet-derived growth factors, has shown efficacy in leishmania infection clearance, and it was described in a study, in a 2018 study on hamster models. There were certain limitations to our study. Majority of our patients were male, so the female representation was poorer. Only young individuals were included because obviously we are treating serving individuals who are coming from operational areas. And the diagnosis of cutaneous leishmania was largely clinical because it's not possible to perform histopathological assessment in each and every patient. And the yield of C-square is also not that good. To conclude, this study concludes that PRP gel and glucantime combined is more efficacious than glucantime alone in patients with ulcerative leishmania. Our study also concludes that the combined approach may also ensure a better patient satisfaction, lower number of glucantime doses, a lesser number of in-hospital days, and possibly a lesser degree of disease-related workout loss compared to the conventional approach. We would like to recommend that, being the first study of its kind, further researches on large scale should be conducted and multi-central experiences should be shared. PRP gel may be evaluated as a monotherapy in the treatment of ulcerative cutaneous leishmania by further studies considering its potential immunomodulatory role. clinicians should consider adding weekly PRP gel dressing in the treatment regimen of ulcerated cutaneous leishmania because it's a cheaper option. You just need a centrifuge machine, easily portable, and just have to take the patient's blood sample, make the PRP gel and do the dressing. I won't be standing here without the support and the teaching that imparted by my teachers, Brigadier Rashia, Brigadier Nadia, Brigadier Irfan Bari, and Madam Lisa. I thank them. These are the references. Thank you.
Thank you, Major Muhammad Anjum, for such a nice, informative, and innovative talk. Next, we welcome Dr. Samreen Hafiz, consultant dermatologist. Dr. Samreen will give us insight on comparative study of itraconazole versus terbinafine, highlighting the crucial findings that will guide our approach to treat resistant dermatophytosis. Please welcome Dr. Samreen.
My respected students and my dear viewers, Assalamu alaikum. I am Dr. Samreen Hafiz and I'm a fellow dermatology. I'm working as a consultant dermatologist at DHQ Hospital, Sheikhupura and at Iskatanwar Medical Complex, Lahore. I'm very honored here to present my research work here, and the topic of my presentation is efficacy of oral terbinafine versus itraconazole in treatment of tinea carboris. So in my presentation, I'm going to cover all of these points. Tinea carboris, sometimes referred to as ringworm, is a superficial illness caused by dermatophytes that affects the skin. The dermatophyte's ability to attach to the keratinized tissue of the skin forms the basis of dermatophytosis. The dermatophytes causing tinea carboris belong to the genera Trichophyton, Epidermatophyton, and Mycospora. Trichophyton rubrum accounts for 80% of the infection, followed by Trichophyton mentagrophyte and Mycosporum organism. The objective of my study was to compare the efficacy of terbinafine versus itraconazole for treatment of tinea. This study was conducted at Department of Dermatology, DHQ Hospital, Sheikhupura from July 23 to December 23 after obtaining approval from ethical board. There were 50 cases, 25 in both groups, and the study was randomized controlled trial. So the inclusion criteria was the patient's age ranging from 14 to 60 years, either gender diagnosed with tinea, were unmarried. The exclusion criteria was pregnancy, lactation, patients with known drug allergy, renal or hepatic impairment, immune deficiency, superavid infection, and tinea were excluded from the study. Informed consent and demographics including age, gender, duration of symptoms, previous history, occupation, history of receiving any steroidal treatment were noted. Skin preference were taken for microscopic examination. Patients were randomly divided in two groups using random number tables. In Group A, patients were given 250 mg oral terbinafine once daily. In Group B, patients were given 100 mg oral itraconazole twice daily. Patients were followed at 2, 4, and 6 and 8 weeks. On each visit, patients were checked for complete resolution of tinea by body surface area calculation. Patients who get cured within 4 weeks were considered as efficacious. All the data was recorded in Performa and then entered and analyzed through SPSS version 26. Both groups were compared for mean body surface area score by using independent sample t-test and for efficacy by using chi-square test. P-value less than 0.05 was kept as significant. In terbinafine group, the baseline body surface area score was 6 plus minus 3, which was reduced to 3 plus minus 2 after 4 weeks. The efficacy was achieved in 32% of cases in this group. In itraconazole group, the baseline body surface area was 7 plus minus 2, which was reduced to 1 plus minus 0 after 4 weeks. The efficacy was achieved in 68% of cases in this group. In terbinafine group, the body surface area score after 6 weeks was 3 plus minus 1 and after 8 weeks was 1 plus minus 0. In itraconazole group, most patients cured within 4 weeks, and at 6 weeks, 100% of patients were completely cured. So there was the charting of the tables of the patients. So the discussion is that there were some studies done around the world. One study, Singh et al., also conducted a randomized trial and found that after 4 weeks, complete cure was achieved in 4.3% and 17% with terbinafine and itraconazole, respectively. After 8 weeks, a total cure of 23% was seen in terbinafine, whereas a cure rate of 76% was reached with itraconazole. Therefore, itraconazole exhibited significantly higher cure rates compared to terbinafine in both 4-week and 6-week time point. Another study conducted by Babu et al. Conducted a retrospective analysis where 80% of patients had a greater than 74% improvement when treated with higher doses of terbinafine, that is 500 mg. There seems to be no advantage in using multi-drug treatment or increasing the dosage of the drug. The researchers found that the rate of the regress was 16% in cases treated with terbinafine and 4% in with itraconazole. However, the differences in relapse rates between the two treatments was not significant. So there was a study which showed that all the dermatophyte isolates of Tinea mentagrophyte, Tinea rubrum, Tinea tonsorius, and verrucosum showed higher MIC, which is minimum inhibitory concentration values, against fluconazole and terbinafine, indicating higher chances of treatment failure when treated with these drugs. Similarly, higher MIC against terbinafine has also been reported from India. Itraconazole and ketoconazole had lower MIC for all species of dermatophytes, which indicates that these drugs could be the better choice for successful treatment of dermatophyte infection. There was another study done in North America which showed variations within the squalene gene leading to amino acid changes in the squalene epoxidase protein are known to lead to terbinafine resistance. During the last decade, outbreaks of antifungal resistant dermatophytosis have been documented, with some reaching epidemic levels. These have included recalcitrant diseases in which patients can present with large multi-edged lesions of bizarre shapes and can cover multiple parts of the body. These infections are often caused by hypervirulent species Tinea indotinea, which is a member of Tinea mentagrophyte and is also referred to as Tinea mentagrophyte genotype 8. Conclusion. We found that itraconazole has better efficacy than terbinafine for Tinea corporis. Thus, in future, itraconazole can be a drug of choice for such cases and can be recommended to be used as first-line treatment option instead of going for less effective treatments. However, further trials should be done to confirm the evidence. So these are the references. Thank you very much.
Thank you. Now from our panel of experts, anyone would like to ask a question or to share their thoughts on the presentations? Please, sir.
Bismillahirrahmanirrahim. I think that all the speakers, while presenting their papers here, they were one of the top quality papers they were presented, and the first paper by Dr. Farzeen from Maldives. I would like to welcome Dr. Farzeen Nasir. She has come all the way from Maldives, and her paper on scabies was very illuminating, and obviously scabies is a problem which is very prevalent not only in Pakistan but obviously in Maldives and this part of the world, and I would like to congratulate her for her presentation and hope that she comes back to Pakistan again and whenever we have our conferences, and we people obviously can go to Maldives and attend the meetings there. Then Professor Zaida Rani, she does not need any introduction at all. Great teacher, a luminary, and now a big name in dermatology, and her topic of dermatophytosis, and especially the resistant type of dermatophytosis. We just had a focal group discussion meeting on dermatophytosis about a couple of days back, and it was discussed at length, and this problem is emerging now very commonly regarding the resistance to various therapies, and Zaida Rani had deliberated on it very well, and I think that this needs to be discussed in every meeting regarding the resistance that we feel in dermatophytosis treatment. Then Dr. Anam Ashraf from Shalimar Medical College again, the fungal infections. So fungi are problems that are not only seen in one department or at one city or in one country, but this is a major problem in this part of the world, and she needs to be complimented, Dr. Anam Ashraf, for her presentation. Dr. Hira from SIMS, and she's assistant professor. Very good presentation regarding skin problems seen among patients who live in slums, the gypsies, and this was a very good presentation. And I think that people have come to know now that these problems, skin problems, which are faced in the slums, people living below the poverty level, what problems they have and how they have to be treated. Then paper by Major Dr. Anjum regarding leishmaniasis and PRP. So it is an eye-opener, and I think that we people who are doing PRP in our departments, private clinics, if we come across leishmaniasis, so we should also try this procedure of PRP along with leishmaniasis to see that what results we achieve, and then obviously we can ask our PGs who are undergoing training with us for FCPS and MD that they can have this topic for presentation. And in the last but not the least, Dr. Samreen regarding fungal infection treated with terbinafine and itraconazole, her study on this, and these studies on terbinafine and itraconazole on in Tinea corporis have been presented around for the last 15-20 years since both these drugs were introduced in Pakistan, and it was again a very good study. I would like to compliment and I would like to congratulate all the speakers on their presentation, the way they presented, and I hope that inshallah in future these youngsters, they would be holding the fort of dermatology in Pakistan, and I wish them best of luck for future as well. I would also now like Dr. and Dr. Iqbal Tareen, Professor Iqbal Tareen does not need any introduction, big name in Quetta in Balochistan. Dr. Rabia, I would like if she can.
Very nice presentations. Can you hear? Very nice presentations by all speakers, and very important topics. They were simple but very important. And these infections are commonly seen, especially tinea. Professor Zaida Rani told very important points about the tinea management. But I think particularly we have to look for host factors also, and counseling of patients and GPs is very important, because mostly the patients are coming after taking incomplete dose. If they are taking itraconazole, it is one daily. Mostly we ask the patient, they said we have taken 3 months or 2 months, but it's once a day. But while the patient's weight is more than 100 kg, if it is the patient is overweight, please give the appropriate dose, maybe 300 mg or 400 mg per day, and for appropriate duration, and also go for clinical cure and try to go for mycological cure as well. And patient's factors, like if the patient is anemic or has the vitamin D deficiency, that is very important factor. And I have seen that we discussed in focus group also, that in CPC in Karachi, that adding vitamin D also benefits the patient for the cure. And if patient is anemic, as very common in females, that should be taken in account. These are the important patient's factor besides all the other factors to be taken in account. And Dr. Samreen, the first speaker, she told some new treatments, and I want to ask her if they are available in Pakistan.
Dr.
The
Fazeen was our first speaker.
Farzeen, Dr. Farzeen, first speaker, yes. Maldives, okay. Okay. So, very nice presentation by all rest of them.
फरजीन अराउंड आ गई हैं? अब इनको माइक वो नहीं है हमारे पास, दूसरा वो वाला माइक? अच्छा जी जी।
Since I am not from Pakistan, I don't know whether newer medications are available. Definitely, they are not available in Maldives, and Spinosad it is licensed now by US FDA. We just have permanent only in Maldives, and that seems to work if we are using it properly.
Okay, thank you, Dr. Farzeen. It was an addition to knowledge. Thank you so much.
Thank you very much, our worthy panelists, for such a valuable comments. At this time, I would like to invite our esteemed panelists to join us on the stage for the shield distribution. Please join us.
I would like to invite Dr. Farzeen Nasir on stage to receive her shield as a token of our appreciation. Thank you, ma'am, for coming all the way from Maldives. Please come on stage. I now invite Professor Zahida Rani to come on stage and graciously accept her shield. Ma'am, I think she's in some other hall, so we'll give her this shield afterwards. Dr. Hera Tariq, you're requested to come on stage and receive your shield. Dr. Anam Ashraf, kindly come on stage. Major Dr. Muhammad Anjum, please come forward and receive your shield. Dr. Samreen Hafiz, kindly come forward and receive your shield.
Now it's a time to honor our distinguished panelists. I would request Professor Atif Kazmi Saab to present shield and souvenirs to the expert panel. Professor Dr. Iqbal Tareen Saab. Professor Dr. Rabia Ghafoor. Dr. Zahid Sheikh Saab. Dr. Lakhraj Maheshwari. Now, to present shield to Professor Atif Kazmi Saab, I would like to invite a remarkable figure in dermatology whose achievements in this field have left indelible marks on both academia and practice. Dr. Subrena Suhail. It is an honor to welcome such an esteemed teacher today. It's my pleasure to invite my fellow moderator, Dr. Khatija Aftab Malik, to stage to receive the shield.
I would request Dr. Atif Kazmi and Ma'am Sabrina Suhail to present the shield to my co-moderator, Dr. Shaista Ambreen.
Thank you, esteemed panelists and participants, for your engaging discussion and valuable insight during the dermatology session at PADCON. I would like to express gratitude to our expert speakers for sharing their expertise and experience. The next session will commence in a while. Thank you, and I wish you a productive reminder for the next conference.
Bismillahirrahmanirrahim. Good morning, ladies and gentlemen, distinguished guests, eminent speakers, and my dear colleagues. Assalamu alaikum. I am Dr. Rabia Mukhtar. Welcome to the 43rd PADCON 2024 to this scientific session. This conference will seek to facilitate the interchange and integration of ideas, perspectives, and approaches in skin-related researches. Once again, a warm welcome to all of you and thank you for being a part of this scientific session. And so, without further ado, let's embark on this journey together.
Assalamu alaikum. I would like to call upon the members of the panel, the expert panels. First of all, Dr. Tariq Rashid, Dr. Tariq Rashid, please sir, come on the stage and take your seat. Sir is a former HOD of Allama Iqbal Medical College and Jinnah Hospital, Lahore, and he doesn't need any kind of introduction.
Let us now welcome Professor Dr. Tariq Zaman, Head of Dermatology Department of Fatma Memorial Hospital, Lahore. His remarkable contributions in the field of dermatology has inspired many. Sir, kindly come on stage and have a seat. A big hand of applause for Sir Dr. Tariq Zaman.
Now I would like to invite Brigadier Naeem Raza. Sir is former head of the Department of Dermatology, Military Hospital, Rawalpindi, and he has also served as an advisor in dermatology in Pakistan Armed Forces. Sir, please take your seat.
It is a great pleasure to welcome Air Commodore Dr. Muniza Rizwan, Head of Dermatology Department, PAF Hospital, Islamabad. A beacon of knowledge and inspiration. Madam will join us in a while.
Now I would invite Dr. Uzma Ali. She is a renowned dermatologist in Islamabad and head of the department in Capital Hospital. She'll be joining us shortly. Now moving to the next, let's start our scientific session, and I would like to invite our first speaker, Brigadier Dr. Arfanul Bari. He is the HOD, head of the department of AMA, Army Medical College, Rawalpindi, and he has the Tamgai Imtiaz also. Sir is going to talk about navigating the challenges from manuscript submission to publications. Sir, please come on the stage. Sir.
I would like to invite Sir Tahir on stage. Sir, please come. A big hand of applause for Sir Tariq.
Looking at the audience, it is as expected कि कुछ academic और research oriented जो publication जो presentation होती है उसमें attendance काफ़ी कम होती है. Considering this is the very first presentation of this session, we all become. So, in what number we are, whosoever we are, I think we are at various levels of experiences in this scientific writing. So my presentation is aimed, this is of interest to everybody from a novice writer to a more seasoned and experienced writer. तो ये इतनी बोरिंग और थ्योरेटिकल टाइप ऑफ प्रेजेंटेशन नहीं है. तो दिस वुड बी coupled with real लाइफ टाइम सिनेरियोज, रियल टाइम सिनेरियोज कि आपको जब आप साइंटिफिक पब्लिकेशन में एंटर होते हैं, राइट, आई थिंक एवरी वन ऑफ अस हु इज़ प्रेजेंट हियर, तो उसको कुछ ना कुछ एक्सपीरियंस है. कोई ऐसा नहीं होगा जिसने कोई भी एक पीस ऑफ साइंटिफिक पेपर ना लिखा हो. तो जो हर्डल्स होती हैं, जो चैलेंजेस हैं, तो दे आर मल्टीफोल्ड। एक तो आई विल नॉट टच द challenges which we face in preparing manuscript. So this presentation is basically aimed on the challenges which we face after submitting our manuscript for publication. Starting from the basics, after so many hurdles, पहले तो आपको जो है अपना टॉपिक अप्रूव करवाने में जो हर्डल्स हैं, उसके बाद फिर इसको आगे एथिकल कमेटी की अप्रूवल है, और उसके बाद उसके फाइनेंशियल और सोशल और लीगल चैलेंजेस जो हैं, उसके बाद वी हैव प्रिपेयर्ड ए मैन्युस्क्रिप्ट एंड इट इज सबमिटेड टू अ जर्नल। क्या होता है, दिस इज द साइकिल इन विच दिस मैन्युस्क्रिप्ट गोज। The article is assessed by the editor first, then it is sent to the reviewers. तो अगर आप बहुत ही लो क्वालिटी की पब्लिकेशन हो तो वो एट वेरी स्टेप जो है ना वो एडिटर ही रिजेक्ट कर देता है। मोस्ट ऑफ द पब्लिकेशन आर सेंट टू द रिव्यूअर्स। रिव्यूअर्स assess the publication and decide about their fate. Is it acceptable or it needs revision? Most of the time every submission needs revision. तो revision के बाद जो है it is again sent to the editor. Editor then decides, और उसके बाद most of the time after revision the publication, if they are of worthy quality, so then they are accepted for publication. और उसके बाद फिर these are the challenges. If we categorize the challenges after we submit the publication, so first the editorial challenges, then the challenges arise during revision and resubmission, then the publication and post-publication challenges, the different categories. We do have the communication challenges during whole this process, and there is long term. Sometimes these publications, they might have a great impact on your career also. So editorial challenges में सबसे पहले जो है ना, is the long review time, because the average review time for an article it ranges from 3 to 6 months, and this really tests the patience of the writer. Then there is the problem of rejection in the editorial revision. So how to address these challenges? So first, by following the author's guideline given in the journal, and by submitting the article in an appropriate journal, and addressing the criticism which we receive from the reviewer. So this is the first case study. I think we all have gone through this. जो भी पेपर सबमिट किया जाता है तो उसका डेफिनेटली आपको आफ्टर अ कपल ऑफ मंथ्स एक लेटर मिलता है जिसके अंदर उसके सारी आपकी जो है ऑब्जर्वेशंस और सजेशंस होती हैं. Let's see, this was an article sent for publication, and after a couple of months this letter was received from the editor. इसमें देखें तो एक दफ़ा तो आदमी सर पकड़ के बैठ सकता है कि इतनी मेहनत के बाद एक आर्टिकल लिखा है तो उसकी जो है उसके ऊपर इतना क्रिटिसिज्म है, इतनी ऑब्जर्वेशंस हैं और इतनी सारी जो है उसमें ओमिशंस और एरर्स हाईलाइट की गई हैं, तो एक दफ़ा तो काफ़ी वो पैनिक स्टेट हो जाती है. लेकिन इफ़ वी स्टे काम और स्टे ऑब्जेक्टिव और उसमें देखें तो वन बाय वन मोस्ट ऑफ द ऑब्जर्वेशन which have been raised by the reviewers, they are addressable. अब there are different categories. पहले जनरल कमेंट्स हैं, फिर कुछ रिव्यूअर्स के उसके सेगमेंट वाइज कमेंट्स होते हैं, पेशेंट मेथड से रिलेटेड, रिजल्ट से रिलेटेड, डिस्कशन, रेफरेंसेस. तो इसको जो हम वन बाय वन एड्रेस करते हैं, आफ्टर एड्रेसिंग ऑल दिस वी रीसबमिट आवर आर्टिकल. समटाइम्स इट इज एक्सेप्टेड, लेकिन बाद औकात उसके बाद फिर भी कुछ ना कुछ और ऑब्जर्वेशन आ जाते हैं. 22 years back when I submitted this article, उसके 2-3 months के बाद जो है मुझे वो पहला लेटर मिला, तो then I took another 2-3 months to address all these observations. So after another 2-3 months I got another letter. ये जो है इसमें फिर एक नई sort of observations हैं और एक नए criticism चीज़ें हैं
but most of the things were the healthy criticism, highlighting the minor issues. So these were also addressed. After about 9 months, the article was accepted and published. तो ये वो acceptance का letter मिला था after about 9 months. So it takes about a year for a real scientific publication to be published in a peer-reviewed and authentic journal. So this was a case study, the first case study. We all have experienced this. Then we have and certain kind of challenges we can face during this publication process. We sometimes receive harsh reviews by the reviewers, harsh comments by the reviewers, and they may be disheartening. So how to address these kind of harsh comments? And then sometimes there are conflicting suggestions given by the reviewers, different reviewers, and occasionally you come across the bias from the reviewers also. So by staying objective, by identifying common themes, and by writing to the editor for perceived biases of the reviewers, you can address these challenges. So this is the second case study. This is highlighting the reviewer bias. Reviewer bias can be confirmation bias, personal biases, or mitigation bias. This was an article published in 2007 in Journal's College of Physician Surgeons. When it was submitted, the author received this letter highlighting the pitfalls, omissions, errors, and all the observations were given by the reviewer. So the new thing was this, that the two reviewers, the third reviewer, this is the comments of reviewer C. These were, some of the comments were slightly harsh and derogatory. So each and every comment was replied point-wise. I would just highlight the last that I wrote to the editor, that we are grateful to the reviewers for being thorough in their approach and pointing the omissions or errors and deficiencies, but at the same time we expect a little more dignified response from them. And एक रिव्यूअर ने वर्ड सस्पिशियस यूज़ किया था एक जगह पे ऊपर जो ड्यूरेशन ऑफ ट्रीटमेंट जो है 2 वीक्स लिखी थी और दूसरी जगह पे 3 वीक्स, तो इसके ऊपर जो सस्पिशियस का उन्होंने कमेंट दिया तो उसके ऊपर लिखा कि द वर्ड सस्पिशियस बाय द रिव्यूअर सी वी टुक इट हार्श, और फिर एंड में अपील की एडिटर से कि ऑल द ऑब्जर्वेशन एंड रिमार्क्स आर अप्रोप्रिएटली आंसर्ड, even if these elaborated answers supported by due references do not satisfy the reviewer, please return the article as earliest so that it can be sent somewhere else without any more delay. तो ये आप अगर जस्टिफाइड हैं कि आपने कमेंट सारे जो है वो एड्रेस कर दिए हैं और देयर इज एलिमेंट ऑफ बायस, तो आप एडिटर को लिख सकते हैं in a dignified way. Then challenges may be through revision and resubmission process. How to address these, I will come to this in another case study. Then the publication and post-publication challenge. So आपका आर्टिकल आपने प्रिपेयर किया, बड़ी मेहनत के साथ सबमिट किया, और उसके बाद वो सारे प्रोसेस से रिगरस स्क्रूटनी से हो गया, पब्लिश हो गया, तो द स्टोरी डज नॉट एंड हियर. इतने कि इश्क के इम्तिहान अभी और भी हैं. तो वो इम्तिहान क्या हो सकते हैं कि यू नीड नॉट टू बी एक्साइटेड वेरी मच कि जी आप पब्लिश हो गया. जब पब्लिश हो गया तो देन यू कम ऑन द बिगर रडार, आप एक ग्लोबल रडार के ऊपर आ जाते हैं. ऑडियंस आपकी एक ग्लोबल ऑडियंस होती है कि अगर एक अच्छे जर्नल में पब्लिश हुआ है और उसके ऊपर जो है तो देन यू कैन रिसीव सम क्रिटिसिज्म आल्सो लेटर ऑन. Publication challenges may be copyright related, article processing charges related, indexing and citation. So we can address these challenges scenario 3, which arises after publication. This article was published in 2008 in Indian Journal of Dermatology, Mineralogy and Nephrology. And as we know that this is the only indexed dermatology journal in Southeast Asian region, and it has got high impact factor. So this was a great milestone, publishing this article. But after a few months, the editor of the journal received this lengthy letter. You see, this was the criticism on the article published few months back. If you see the language used, if you see the title of this letter to the editor, so it is giving us such a grave allegation on misconduct of publication ethics, plagiarism, copyright violation, duplication, fabrication, falsification, and what not. मतलब सारी जो ग्लॉसरी है, सारी डिक्शनरी जो है ना, जो मिसकंडक्ट ऑफ साइंटिफिक पब्लिकेशन पे हो सकती थी ना, वो दैट इज देयर. पहले तो काफ़ी तमहीद बांधी गई और उसके बाद फिर इसकी डिफ़ाइन किया गया प्लेजरिज्म क्या है, कॉपीराइट वायलेशन क्या है. उसके बाद वन बाय वन सारे ये एलिगेशन जो है ना, दे वर चार्जशीटेड. एंड दिस लेटर वाज रिटन टू द एडिटर ऑफ द IJDBL. We point wise we address these allegations, and they formed a high level committee to investigate all this matter, all these allegations, but they could found a minor violation and a minor omission, and nothing grave violation could be found. ये उनका आगे ऑथर की रिप्लाई और बाद में एडिटर्स रिमार्क्स. So this is the remarks one by one. इस किस्म के एलिगेशन थे कि क्लियरिंग एग्जाम्पल ऑफ प्लेजरिज्म. उसका जवाब दिया गया 10 दिन एविडेंस के साथ कि देयर वाज नो क्वेश्चन ऑफ प्लेजरिज्म. फिर दूसरा था कि ऑथर्स को क्रेडिट नहीं दिया गया, किसी की जो है फिगर जो है वो प्रोड्यूस की गई है, उसका भी अप्रोप्रिएटली आंसर था. फिर एक और चीज़ थी कि स्टडी वाज टोटली डन इन दिस पीरियड. तो ऑथर जो थे इसके स्टडी के, वो देवर एट डिफरेंट स्टेशन ड्यूरिंग दिस पीरियड. यदि ये 3 स्टेशन के ऊपर थे तो एक वक्त में ये कैसे एक जगह पे हो सकते हैं, तो इसके ऊपर क्वेश्चन रेज किए गए. इसका आंसर भी दिया गया. कलेक्टिंग डाटा एंड ऑथरशिप आर 2 entirely different issues. For collecting data, all authors need not to be present simultaneously at the same place. Same issue was again raised. एक सेल्फ प्लेजरिज्म का भी एक इशू रेज किया, तो इसका आंसर दिया कि देयर वाज नो डुप्लीकेशन. ये दिस इज द समरी. ये सारे चार्ज फ्रेम करने के बाद व्हाट द कंप्लेनर they asked from the editor. Therefore, the employers and the registering body of these authors should review their fitness to practice. Moreover, the editor IJDBL needs to take serious note of this issue. Then the article must be retracted. मतलब ये सारे एलिगेशन लगाने के बाद के आर्टिकल must be retracted, and their employers and registering body must be notified. What happened? The same article, if you see, this is still the most cited article in that publication, in that journal. अब उसमें सारी एलिगेशन को इन्वेस्टिगेट किया गया, तो देयर वाज नो स्ट्रॉन्ग बेसिस ऑफ एनी एलिगेशन. तो this article still exists and still is the most cited article of that very journal. Then there can be communication challenges during correspondence with the editor, with the peer reviewers. So we need to address these also. And so the story does not end here. अगर आपने सारा कुछ एलिगेशन भी सारी क्लियर हो गई और उसके बाद आपको जो है जर्नल में आर्टिकल भी रिट्रैक्ट नहीं हुआ. This is the last study, the last issue. So sometimes your well-wisher can go to any extent. अब उसके बाद ये एक और लेटर जो है वो एम्प्लॉयर को सेंड किया गया और डिफरेंट लाइसेंसिंग बॉडीज़ को, तो उसको भी एक एक करके आंसर दिया गया. तो इसमें देखें कि ये दिस वाज ऑन डिफरेंट फ्रंट. The most disgraceful aspect of the issue was that the article was published in Indian Journal. अब ये आप इंडिया और पाकिस्तान की लड़ाई की बात की है कि जी इंडियन जर्नल में था और पाकिस्तान की डिस्ग्रेस थी ये, और इसकी फॉर्मल परमिशन नहीं ली गई. और एक और एलिगेशन था कि दी डेटा रिपोर्टेड वाज फ्रॉम LOC, मुजफ्फराबाद का डाटा था, तो ये सेंसिटिव डाटा था जो कि इंडियन जर्नल में पब्लिश किया गया. उसका भी अप्रोप्रिएट आंसर दिया गया. वन बाय वन ये सारे सिंस द टाइम finished, I would just last one. So this was my final statement given. So the aim of presenting these real-time scenario was that we come across these sort of challenges whenever we write any, even after publication, there are peculiar kind of challenges that arise. But we have to be persistent, perseverance, and we have to adopt appropriate strategy for different type of challenges. And during this process, we can seek support from colleagues, mentors, institutions. And during these challenges, we can have their support and effective communication with the editor, reviewers, and audience. It can address these challenges. But at the last, I would say that the last two case scenarios, they have great impact on my career, on my publication, because I became more vigilant, I became more wisdom-wise, I was more wisdomful. After that, any kind of publication, we have to look these sort of omissions that we normally do.
Thank you very much, sir, for such an informative talk. One of our esteemed panelists, Dr. Usman Ali, has joined us. Madam, please come on stage and have a seat. Now, I would like to invite our next esteemed speaker, Professor Abdul Rahim Khan Bangash, Head of Department of Dermatology at Hayattabad Medical Complex, a distinguished dermatologist with extensive experience. He will share his insights on exploring written communication skills of doctors for optimal patient care and professional collaboration.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am feeling honored to be here today and presenting this talk because of two reasons. Number one, 20 years back, I started my journey of dermatology from this very city, and today I am delivering a lecture or talk as a professor of dermatology in the same very city. And the second reason is that the panelists that are sitting there are esteemed faculty members, and it includes two of my teachers and my mentors from whom I have learned a lot, and I'm still learning from them, and I'm always praying for them, for their health and prosperity in this world and their success in the eternal world. The topic that I am going to present, exploring written communication skills of doctors for optimal patient care and professional collaboration. This is not something new. I know there is hardly anyone who has not practiced this skill, and they know each and everything about it. But during my career as a doctor, I found some deficiencies in this skill. So when I was doing my master's in health profession education, I selected this particular project to work on it and to find out something that you might find fascinating. The learning objectives of today's topic are to identify basic requirements of written communication, to identify written communication skills for medical professionals, discuss the importance of a written communication skill of doctors, find out the status of this writing skill of doctors working in tertiary care hospitals of Peshawar, and discuss strategies to improve this writing skill of doctors. Communication, you all know, is literally means to commune or to make some information public to all those to whom you want. There are certain characteristics of effective communication, like it should be clear so that everybody understands it. It should be concise. It should have concrete evidences of what you are saying. It should be correct. It should be considerate, complete, and last, courteous. Like Dr. Fanul Bari said something in his talk about this thing. This is also an essence of a successful communication. So these 7 C's are considered to be important for any communication, what sort of it might be. Now, if one or more of these C's are missing from your communication, it will work as barrier to effective communication. Now, we all know that there are 3 basic cognitive, psychomotor, and affective domains of learning, and one wants that he or she must excel in each domain of learning, and he would like to see this type of picture. But whenever their learning starts in any domain of learning, it is like this. Things are tangled, and it takes times to untangle, and when you reach there will be some stages through which one must. How one can improve his or her writing skill? You all will agree that extensive reading is the mainstay for an effective writing whatever you want. You write it up, you read what you want to write, then you think of a plot on which you can reproduce what you have read. Then you start writing, and when you have completed your writing, you go through it, you review your grammar and your spellings. Then you give it to someone else for proofreading so that further mistakes are taken out of what you have written. Then you get feedback from your peers regarding your writing or whatever you want to say. And finally, you start writing, and what you do, you should avoid and you should use strong verbs, avoid passive voice, try to write in active voice, and vary sentence length because monotony is not liked by mind. And you should cut unnecessary words, especially the word "the" is used very much over here in or various writings. What is the definition of written communication? It is simple one: communication through writing. What it should contain: whatever you are writing, it must have clear expression of thoughts that you are giving to your audience. It should have precise language. You must build up a logical argument. You should take note of something that you think is deficient or you do not understand the meaning because the audience might ask about it. So you must take a note of that. You edit it, summarize it, and finally you write your report. The types of written communication can be many, but the important ones are formal, that we like applications to our dean, associate dean, principal, etc. Or you write informal, like we like letters, or we like some messages. There can be academic communications and there can be creative, like you write a story, you write something else. The academic written communication for the doctors includes history taking, lab forms, synopsis, theses, research papers, etc. And the one that I am going to talk about in the remaining part is writing medical calls. So the question is, why should a doctor write medical calls? We all have gone through these stages and we all know that our patients do not come as a single entity of disease. Your patient might have multiple diseases, and we will definitely need to take opinion of our other colleagues regarding the management of our patient. What will it do? It will increase the confidence of our patients in what we are doing. The stay of the patient will get minimized, and the patient as well as physician satisfaction will increase. So, during my previous years, I have observed that whenever I am attending a call, the purpose of call is not mentioned adequately. Either there is lack of adequate history, there is no supportive document attached with the call, there is no mention of investigations, and there is no mention of differential diagnosis or even diagnosis. Now, this is the photograph of my OPD where I'm doing in my hospital on each Monday. You see a lot of patients waiting outside. Similar number of patients will be waiting in the rooms as well as in the corridor. Now, I receive a call like this. Comment on skin lesions and advice. Now, what will I do? I have got so much number of patients waiting for me. Either I go into the details or I write this patient is having multiple papules, thank for the call, and I'll send it back. That's what I do. And what will be the implications of this on my patient? His stay will be prolonged, his confidence level will go down, and there will be frequent coming and going of the patient as well as his paper among us and many things else. And what will happen? All these things will go to waste. Now, if I want to evaluate these calls, what should I do? When I went into the literature, I could not find anything which can be included for the evaluation in the literature, and you all must agree that there is no explicit mention of this communication skill in our undergrad or postgrad curricula as well. So I had to devise a validated set of items on the basis of which I could evaluate those calls that I wanted to include in my study. What I did was that I produced an instrument, wanted to produce it. I got a questionnaire from the internet, downloaded it and gave it to 3 senior doctors from my unit for response on each item for inclusion or exclusion. The response of these doctors were discussed with other senior faculty members so that we could finalize what item we should include. Now, this questionnaire was then sent for 3 tertiary care hospitals of Peshawar for comments of the faculty, senior faculty, on those items on a Likert scale of 0 to 4. And for that, I used AMI Guide 20 that has explained all the steps. In the final, I calculated content validity ratio and kappa value for each of the items that were included. And mind you, this questionnaire contained 23 items. And in the end, what came was that those items that had content validity ratio of more than or equal to 0.78 and kappa value of more than or equal to 0.70 were included. and the evaluation of received medical calls was done against this. The identified items were 6. Reason for referral, history of presenting problem, clinical finding, results of physical examination, and diagnosis, provisional diagnosis, and explicit mention of the doctors who will receive the call. This study is published in the Pakistan Journal of Medical Sciences in year 2020. It has got a lot of other details, but I am not going to go into more details. I'll be just giving details of only 2 findings that are relevant to what I want to say. Was considered on this, there are 6 items, and if you see, only 2 items were addressed in adequate number of calls, and we thought that 50% or more, if they are addressed, it will be considered adequate. The rest, you see, it is less than 50%, the 4 other items. Now, why is it so? You all will agree that there is no mention of this skill in either in any of the curricula, and there is no written format of this in our unit. At least in my hospital it is not there. I am unaware of the units that you work in. This is the page that is used in our hospital for medical call writing, and now I am going to revise it, and I have discussed with the dean, and inshallah it will be something else in few months. Now, this is something very important. Just concentrate on those people who are writing 0, 3, and majority of the calls are written by junior doctors who are not trained for this work, and this is the result of what we get in the end. Now compare this finding with something that I introduced, that is, I wrote a structured medical call and I sent it to the 15 units in my hospital, and this is the reply. You see, none of the replies less than 50%. So my inference is that structured medical calls yield comparatively better results, and we need to restructure medical call pages of our hospital, patient charts and booklets, and I request each and everyone, if they find what I have seen, they should conduct similar studies in their unit so that this communication skill gets better. What should be done for long term? Because that is a short term achievement. Number 1, we must restructure this page of our hospital charts. We should explicitly teach this communication skill to our undergrad and postgrad doctors. We should teach this written communication skill to our house officer as well, and to our first year trainees in dermatology. Thank you very much. Jazakallah for listening so simply. Thank you.
Thank you, sir. Our next speaker is Professor Dr. Usma Ihsan. She is head of the Department of Sharif Medical and Dental College, Lahore. Today's topic of presentation is an insight into the qualitative research. Please come on stage.
In front of my mentors from whom I actually learned the ABC of research, Professor Tariq Zaman and Professor Tariq Rashid. And I'm really grateful to Professor Abdul Rahim for his elaborate talk on such a sensitive topic, and actually it has built up the preamble of my talk, and I'll take it up from where you have actually left it about the research. Qualitative research जो है, it is something totally different from quantitative research, as all of you know. And before I formulate briefly introduce you people to qualitative research, let's put these questions. And if any one of you can actually suggest a research method in the quantitative research, जो इन questions को address कर सके. For instance, let's talk about the second question. What barriers hinder female dermatologists' advancements to leadership positions? Which research design will you follow? कौन से इस पर statistical test लगाएंगे? किस तरह इसको quantify करेंगे? Can anyone answer? Obviously no. हम इसको numerical data में, हम इसको numbers में कभी भी calculate नहीं कर सकते. Because it is involving a lot of social interactions, a lot of human behaviors, a lot of deep thoughts and processes. So ऐसे तमाम research questions, ऐसे तमाम चुभते ख्यालात या सवालात जो as healthcare professional या as educationist आपके दिमाग में आए, जिनको quantify numerical data में ना किया जा सके, comes to the domain of the qualitative. And it's actually very interesting once you get even a bit of familiarity with the process, because it's actually different. हम throughout our PG training, even in the early years of our profession as consultants, we are always running after the papers and publications, not only out of our own interest but also because it's a requirement for our promotions. So most of our trainings is in the numerical data and quantitative research. So when I learned it in my Masters of Professional Education, I found it actually very interesting because I got to know that it touches those aspects of the healthcare and teaching learning which are generally ignored, or which are generally just felt but they are never talked about. Exploring the unquantifiable. This is the basic essence of the qualitative research, and as William Bruce Cameron has said, that not everything that counts can be counted and not everything that can be counted counts. So there are certain important sensitive issues that are not quantifiable, but they still are to be researched and talked about. This is all about the qualitative research. For instance, मैंने अपनी talk को कोशिश की है, obviously in 10 or 15 minutes it's not actually possible to make everyone champions of qualitative research, but even if a single person after the talk gets interest in designing some qualitative research, I think I would be successful. For instance, patient satisfaction survey. कल से हम लोग बहुत सी talk सुन रहे हैं, dermatology life quality index, Falana satisfaction score, and the scoring is very high. Actually 90% population is satisfied with this treatment, 101% is satisfied with this treatment. But when you talk about the actual issues of the patients and you talk about the patient concerns, these figures, these numbers actually fail to highlight those. So these are the areas. Similarly in educational outcomes, आपने बड़ा frequently देखा होगा metric में, FSC के results में 100% outcome होता है students का, 100% pass percentage होती है. The scores are actually very good, but if you critically evaluate the critical thinking, creativity of the students, the quantitative data is not going to reflect it. Similarly, if you have conducted a course, or if you are running a training program or whatever in your context, if you are trying to change something or ask about something pertaining to learning environment or the course content or the teaching learning methodologies, you need to sit and talk with the stakeholders in depth and explore their perceptions, right? So likewise in healthcare provider patient communication, qualitative research highlights empathy, trust and communication barriers. Application examples would include the enhancement of patient care through feedback and experiences. It may include the classroom interactions and teaching methodologies. And examples, for example, in dermatology, I found these two examples very relevant for qualitative research. How do the cultural beauty standards impact perceptions of skin health? Yesterday, Professor Tanzila delivered a very good talk regarding the colorism, and she explored, she was sharing some of the data of her qualitative research, which was meant to explore the perception of people about the whitening. Why do people seek whitening treatments? So इस why का answer find out करने के लिए you need to sit with the particular set of people and then talk to them in depth. उनकी perceptions को detail में explore करने का नाम is qualitative research. Likewise, अगर education के context में देखा जाए, for instance, what are the perceived gaps in dermatology residency training program? आप इसका बड़ा अच्छा quantitative analysis कर सकते हैं, इस unit में ये facility नहीं है, इसमें ये नहीं है, इसमें ये नहीं है. When you sit with the trainees and talk to them, believe me, they give you an insight to everything. Once they trust you that you will maintain their confidentiality, they give you a detail of each and everything, of every educational experience that a candidate passes through. It can help in policy development. Qualitative research के end में you always end up in making a conclusion and draw a theory. And in healthcare professional, you can give recommendation that can help in policy development. Through qualitative research only you can voice the ideas and you can raise the voices of the underrepresented groups. And the guidelines, for example, if you are observing the communication skills of a doctor, or you talk about the communication skills of a doctor with the patient, you can provide more latest guidelines for a doctor to be more empathetic and develop patient-centered care. Now coming to the formal introduction of the qualitative research. The collection, analysis of the non-numerical data by observing what people have to say or do. It solely deals with the concepts, the thoughts, the opinions and experiences, and it is meant to uncover the deeper meanings, motivations and perspective behind a particular human behavior and social interaction, and gives you a holistic overview of the subject matter. And here are some of the strengths of the qualitative research. As I mentioned earlier, it's always exploratory and descriptive in nature. That is why you keep the sample size the less the better, because आपने कम से कम जितने लोगों से बात करेंगे उनसे in depth बात करेंगे. And it's a very context specific data, because the study जो होती है वो एक खास set of population की होती है, and generalizability of the results cannot be done because the paradigm, the context, the situation changes with the next set of population, and it always captures the deepest meanings and essence of the research question. This is very important, the flexibility. Quantitative research may we always go by strictly by the predefined questionnaire, strictly by the predefined criteria. We cannot move out of the box of the quantitative methodology that has been decided earlier. But the qualitative जो researcher होता है उसके पास freedom होती है, flexibility. Sometimes you are talking to a particular group of people or your whatever the sample size is, and the participant says something innovative, something new which you have not expected. So the qualitative researcher has the flexibility to go out of that predefined questionnaire and talk more about it. Right? That is why you call them sometimes semi-structured interviews or focus group discussion, because it's flexible. You can actually move away from the primary point of initiation of the study, because it may sometime yield information which becomes relevant to your research question. Now the subjectivity जो है ये qualitative research की strength भी है, and it becomes challenge as well, because wherever you are doing a qualitative research, your participants are expressing their emotions, their feelings, their thoughts, जिनको आप numbers में mention नहीं कर सकते. For instance, I'm talking to these 3, 4, 5 people on a particular matter. They are talking in detail, right? I can, for instance, I am talking about any social issue, any educational issue. I cannot actually quantify that in units. ये इतने percent satisfied था, just merely by talking. ये इतने percent angry था, ये इतने percent involved था इसमें. So there has to be some subjectivity while writing. It has to be a written, documented report. So when I am interviewing the participants, I am not only talking to them. I am writing the field notes, mentioning their body language, mentioning their emotions, because later I have to triangulate all those emotions that I have written with the verbal comments that the participant has made. So the subjectivity to some extent is required in having good results in qualitative research. There are another few examples of qualitative research, for example, investigating patients' emotional responses to chronic skin conditions, or exploring the perception of a trainee resident regarding the quality of the training program. These are the various types of qualitative research. Under health, do you have the pointer? Healthcare professionals में and education के context में, these are the two types of research, qualitative research types which are very important: phenomenology and rest of the study. अगर कोई depth पढ़ना चाहे, they are very interesting, especially if you go for ethnography. Ethnography जो होती है, it is the observation of the cultural practices of a particular group, and the researcher actually has to hide his or her own identity, or he becomes the part of that cultural groups and stays with them for some time, and then he observes and write reports. I would need just 2 or 3 more things. Mixed method would involve qualitative and quantitative methods mixture. These are the steps of qualitative research. You have a pre-research where you define the topic, formulate the question, review the literature, and then select the research design and ethical approval. Then you take the data. Data is collected. All the data is transcribed. You do coding, theme identification, and data integration. This is something. It's just like that. आप एक किताब पढ़ते हैं, आप एक चैप्टर पढ़ते हैं, तो आप उसमें सबसे पहले उसका हाईलाइट करते हैं the most important things, like this is the clinical features, this is the treatment, these are the differential diagnosis, and then you follow the themes. उसमें से फिर themes means कि आपने coding की, data की, आप उस data को squeeze करने की कोशिश करते हैं. This cannot be actually explained in a 2 or 3 minutes presentation. It may require months of training to understand the coding, then themes identification, and then sub-theme identification. Likely, afterwards you do the data integration, you write the narrative and the report, and this step is very important. Whatever you write is to be reviewed by your peer, and you do the member checking. Whatever you write, you go back to your participant and tell them, is it the same thing which that you meant to say, or I have interpreted it in some other manner. This is the method by which you validate your findings and reduce the element of subjectivity. Also, the researcher reflects upon and evaluates his or her own writing process, and then you disseminate and share. You can use interviews, observations, case studies, and documentation as your data collection tools. So the data collection, data reduction, you display your data in matrices, graphs, networks, and charts, and then you draw the conclusion. Just one thing as an example. For instance, these are the themes. These at over here are the themes. The blocks in rectangles, for instance, if you take one theme, recognizing the student well-being, ये सारी themes उन्होंने introduce के बाद, अपने data की transcription के बाद, coding के बाद identify. And this is how you squeeze the data, and then these are linked to some themes. And to validate this, you can add the comments verbatim of the participant. For establishing the validity and reliability in qualitative research, हमने triangulation mention की, that you use multiple data sources, not only interviews, you take your field notes, you confirm your findings. Saturation of the data is one of the features of qualitative research. Owing to the flexibility of the qualitative research, saturation होती है कि after some interviews, the researcher thinks or feels that a similar type of responses are coming, so you can actually stop your research when the same responses started coming, and that is the saturation. Researcher always reflects back on his writing to address the reflexivity and subjectivity, peer debrief, member checking, and then audit trials. These provide strength to your findings, but it is definitely time intensive. You cannot generalize the result. It is complex, definitely. It is very hard to summarize the numerical data, but it is not impossible. It's very interesting once you understand it. The ethical consideration are more or less the same as of the quantitative research. Always prepare open-ended questions to have effective qualitative research. Always maintain neutrality while you are interviewing or analyzing your results. Accurately record. Do not add your personal bias in the interviews, and try and be ready to follow the new topics that can emerge during the talks or interviews. Future trends in qualitative research is digital integration. For instance, when we did the Masters in Health Professional Education, all of the qualitative data analysis was done manually, but now the softwares are available, AI applications are available, and it is actually now justified to use these applications because it saves a lot of time, right? For instance, transcripts आपने prepare करने हैं, you just upload your recorded interview into the AI generated applications, and within a fraction of few minutes or seconds, the transcript is in front of you. But you need training to learn how in vivo works. It's not that user friendly. Likewise, in mixed method studies, qualitative and quantitative research, healthcare professionals can be combined. I would like to take it forward if Dr. Rahim allows the quantitative results that he has just presented. It would be a very good mixed method study. Similarly, facilities for online focus group discussion and interviews to highlight some sensitive areas. So I conclude by talk over here that the qualitative research adds depth and context to understand a complex phenomena, and it has an impact because it is essential for developing comprehensive patient-centered approaches, and it's vital in healthcare to provide better patient care. And a take-home message is that being healthcare professional, आप teaching faculty में हैं या नहीं, if you combine quantitative research design with qualitative research design, the results would be well-rounded and it would have impactful outcomes. Any questions? Thank you.
Thank you very much, madam, for sharing your words of knowledge. Now it's time to invite our next and last speaker, Professor Dr. Rabia Kapoor, Head of Department at Jinnah Postgraduate Medical Center, Zaudin Hospital, Karachi. She is a renowned dermatologist and educator. Kindly come on stage, and her topic of presentation is Micro-Learning in Dermatology Postgraduate Education, a novel approach to enhance knowledge, retention, and clinical skills.
Thank you very much, Dr. Rabia Mukhtar, and she is my class fellow from FSC. Thank you so much. Today, the topic of my presentation is micro-learning in dermatology, postgraduate education. This is the agenda of today's talk. What is this curve showing? This curve is showing that when we read something and we study something, this is the state of a postgraduate entering into dermatology training. We all have passed through this stage, and We all have passed through this stage. When we enter the post graduation of dermatology, what happens? We are told on very first day that we have to study Rookes textbook of dermatology, which is 4 volumes and book, and it is not enough. We have to study Fitzpatrick of dermatology, other books, and other resources, dermatopathology books, now dermoscopy also. And so it is the situation of a postgraduate in dermatology. He is overloaded and burdened. And when we start reading Rookes, what happens? That this is this is a study by psychiatrist, and this is forgetting curve, and this implies to dermatology also, like other specialities and other learning, all the other subjects. When on the first day of reading, we think that we know it all. We know 100% of the knowledge, and after 1 week, we know only the 20%. We can recall only the 20% of what we studied 1 week back. Isn't it so? And this is this is forgetting curve after the review readings. After first reading, you can see the curve. After after fourth reading, you can see that your retention is like 80 to 90%. So this is the traditional learning method. What are challenges faced by the postgraduate residents in these methods? As we know that we have limited time of learning when we start the post-graduation. Postgraduates have to take IMM mostly, and they have to, they have kids, they have physical clinical duties, attending emergencies and other things. So they have limited time of learning, they have information overload, they study the full topic, full 100 pages or 50 pages of a topic, but they don't know what is important and what is not. And when they start reading the pathophysiology, they are lost there, and they do not reach up to the clinical features or the treatment guidelines. They are already overloaded. Then retaining difficulty in retaining knowledge. I have discussed that, the forgetting curve. We cannot recall after a few days of the learning. Then traditional teaching methods need lot of time, long lecture, making hours and long lectures, and usually the supervisors are multitasking and they don't have enough time to give to their trainees. So there is an emergent concept of micro learning. What is micro learning? Micro learning is short, focused learning experience of 5 to 10 minutes or up to 15 minutes, which are designed to meet the specific learning objectives. The features of micro learning are, they are bite-sized, they're very small, bite-sized learning modules or sessions. They are focused, they target a specific learning objective. They are flexible if it is made online or present in apps or media, social media. They can reach whenever they want. Interactive, mostly the different people may interact through these platforms, and repetitive. They can repeat these short learning modules whenever they want, in short span of time. While for reading a chapter of the book, it takes a lot of time. So what are benefits of micro learning? Improved retention. It is scientifically proven that a human brain can retain only small bits of pieces of information, and better than the longer information, or human brain cannot retain more than 10 minutes or 15 minutes. The efficacy of retention is decreased. They are time efficient because they are short, easily accessible and interesting, and focusing on the important concepts. Then the PGs also show the increased engagement. Accessibility, it can be made accessible through digital platforms, so they can access from everywhere, and everyone can access these micro learning modules. And it is personalized, that everyone can learn according to his or her needs. So what is the difference in micro learning and macro learning? Micro learning takes less than 10 minutes, and macro learning takes hours and days. Micro learning is based on the single concept. The single important concept is made into some format of micro learning of 5 to 10 minutes, while macro learning is for complex ideas and complex educational concepts. In traditional learning or macro learning, the coaching or sportive teacher is always needed. Or while in micro learning, it can be once the module is made, they can use it again and again. What are various formats? Micro learning usually utilizes the digital media, while traditional learning is traditional learning of classroom learning or class tests or the other traditional methods. These are various formats which can be used. They can be video tutorials, interactive quizzes, infographics, podcasts, virtual reality experiences, case studies, gamification, simulation, micro courses, and mobile apps. Video tutorials can be used to explain the procedural videos of complex procedures, simple 5 to 10 minutes videos. It may be about some important concept, a small topic of 10 to 15 minutes, like in dermatopathology, explanation of a slide, clinical slide, or dermatopathology slide. Then interactive quizzes, multiple choice questions, and with explanation of those questions, true-false questions can be used. Like a very good activity was done this year by PAD members, in which they used to weekly upload a quiz, a short quiz for in the PAD forums. And then infographics. Infographics is the visual. An important concept is visualized in a small picture or diagram. I will show later. Then podcasts. Podcasts can be made with expert interviews and panel discussions. Virtual reality experience, simulation-based learning is included in that. Then interactive scenarios, immersive experiences, case studies, real-life scenarios, interactive decision-making scenarios, and collaborative learning. These are various formats which may be used for micro-learning. So micro-learning in dermatology may be used for skin condition identification, like we used to do the slide sessions. That is one form of micro-learning. Treatment algorithms, topical treatment, systemic therapies, or other treatment guidelines can be, small micro sessions can be made from those guidelines. Dermatopathology is very important. We can see the various online resources by various dermatopathologists who explain one slide or two slides of dermatopathology, and we can use in this in our departments also. Then about cosmetic dermatology, dermoscopy. Dermoscopy, there are few apps also through which you can learn dermoscopy, and there may be micro learning modules, small modules of dermoscopy made, and to make its learning easier. So already discussed, journal club may be added in these micro learning sessions. Now, how we can implement this micro learning concept into the current teaching, where we are mostly practicing the traditional methods. We have to integrate this in existing curricula, and all the concepts may not be. It may not be possible for all the concepts of complex concepts to be covered in micro learning. So it is the integration or mix of the macro and micro learning. We can utilize residents it is called resident-led micro learning initiatives. You can engage residents to make these these quizzes or videos, and it can be utilized for the learning of all the postgraduates. Like what I have done, when there was a feature of WhatsApp communities, we made a community for dermatology, PMC dermatology e-learning, and made some groups, with 5 groups for clinical images, clinical cases, dermatopathology, dermoscopy, and treatment algorithm. And PGs were assigned to on a specific day, PGs were assigned to put a case in that group, and all would comment on that group, picture or that case. And a case was closed after 24 hours. So this was used from the Monday to Friday, and on next Monday a new picture was uploaded in each of these groups. Then micro-learning may be incorporated into continued professional development after one has become consultant, because you tend to forget things with time. So there are many studies. It is scientifically proven methods. There are many studies which indicate that 85% of dermatology residents reported the improved knowledge retention, and 90% of dermatology faculty reported enhanced clinical decision making in postgraduates after going through these micro-learning, teaching with these micro-learning formats. But this seems to be a very important, very interesting concept, but there are challenges for this concept also. We have to make content and ensure the content accuracy, and we have to update the content regularly. There may be technical issues like video making need technicalities. Engagement and motivation, you have to continuously engage the candidates and motivate them to use these formats. And integration with traditional learning methods is required. Advantages: improved diagnostic accuracy, effective treatment planning, enhanced critical clinical skills, better recall of the information, better retention, reduced complications, enhanced patient care, remote access is possible, flexible learning, tailored learning pathways, individualized feedback can be obtained, reduced study time, enhanced teamwork skills also. So this is learning curve, and where we can use this what are the stages where we can use micro learning. You can see in this curve that when a resident starts training, then he is very anxious and retains. But after some time, he is overloaded with information and he cannot retain much of the knowledge. And this is the place where micro learning can be used to make the content easier and more efficient learning by the trainee. Then optimum performance is reached, and then once a candidate becomes a consultant, then he then after that, if he continues to work and continues to work in like tertiary care hospitals or gain knowledge continuously, they will grow. But then, or they may become stagnant, or there may be fall of the knowledge due to the after some time, if you are not reading the content, or you are not up to date about the newer advances, you may fall. Your knowledge may fall. So you can use in your CMEs, these micro learning CMEs. What are limitations? It is not suitable for teaching complex concepts. Some syllabus fragments may seem disconnected, and content creation takes time and it needs upgradation accordingly. Take-home message: micro-learning enhances the knowledge retention and practical applications. It is quick and flexible. Social media can be effectively utilized for this emergent concept of learning, and AI-powered learning is the future of education. Thank you so much.
Thank you very much, Dr. Rabia, for such an informative talk. And this brings ends to the presentation part of this scientific session. And now this panel is open for the panel discussion and the question answer session. And I would like Professor Dr. Tariq Rashid to share his insightful words about this.
Bismillahirrahmanirrahim. I think it was a wonderful session, academically fulfilling, and all the presentations were great. Presenters were awesome, in fact. Glad to see Professor Abdul Rahim, Professor Uzma Ehsan, who are our trainees, and their talk were excellent. All the talks were excellent, but because they are our students still now, although they are professors, so I wish to congratulate them especially. Brigadier Irfanul Bari Sahab shared his personal experience about the challenges that can be faced after submission of a manuscript to a journal. And I think the lesson was that one should not become panicked when the objections are raised by the editors, and one must show persistence, replying every objection with sound, base and logic, and ultimately the article would be published. Then Professor Abdul Rahim Sahab pointed out a very important flaw in our medical wards, dermatology wards, that whenever we receive calls from other units, you are very right, usually these are incomplete. And when our residents also write and PGs write calls to other units, the same situation is there also. So there is a dire need to improve the communication skills of our PGs, our HOs, and we all must give attention to this aspect, because this will ultimately lead to improved patient treatment and ultimately will improve the skills of these future clinicians for better communication of their patients with all others. Professor Uzma Ehsan made us wise about what is qualitative research, what are its uses, what are its challenges, and how productive it can be in various scenarios where the other research would not be possible. Thank you very much, Professor Uzma, for making us wise about how to conduct and when to conduct qualitative research. And a very nice concept by Professor Rabia Ghafoor about micro-learning in dermatology. I think this concept is I think important to save the time, to utilize the time in a better way, to improve the concepts of different diseases, to make a solid foundation about any disease, about any procedure, that we study it by different means in piecemeal, bite by bite, and would definitely help to improve our concepts and knowledge and retention. I think there is a need to inculcate this concept of learning in dermatology in our postgraduate curriculums and to practice this routinely in our departments. I must congratulate all of you for your awesome presentations.
Professor Tariq Rashid very well concluded the session. That vision speakers, they are all brilliant. Uh, just my comment is the name of this session is Educational Pearls for Clinician. Is really educational, and not only for clinicians, for educationists, for researchers, for students, our PGRs as well. I congratulate Professor Nadia to organize all these papers in this session. It's a very good session, and the thodi si lacking is a thin attendance. So I think these type of sessions, for these sessions, the PGRs should attend these sessions. The teachers, the supervisors, they should instruct their PGRs to attend these sort of sessions. Again, I can congratulate all the speakers for very brilliant talk. Thank you.
Now we move on to the next segment, which is the shield distribution. I would request Professor Dr. Tariq Rashid and other honorable panelists, Dr. Tariq Zaman and Dr. Tahir, sir, kindly come forward and distribute the shields. First, I would like to request Brigadier Irfan Bari Sahab to come on stage and receive his shield. A big hand applause for him. A big hand of applause for him. Now, Professor Dr. Abdul Rahim Khan Bangash, sir, kindly come on stage. Next, Professor Dr. Uzma Ehsan. Professor Dr. Rabia, please come on stage and receive your shield. Next, my co-moderator, Dr. Uzma Mirza, kindly receive your shield, Dr. Uzma. Next is my turn, Dr. Rabin Khan.
The next segment is distribution of shields to our worthy panelists. Again, Dr. Tariq Rashid will do the honors. Professor Tariq Zaman. Dr. Tahir. And Professor Tariq Zaman, आप please Dr. Tariq Rashid. Sir. so much. Actually, next is a special announcement for the awards of e-poster. For this, I would request Dr. Tariq Rashid to stay on the stage. Professor Nadia, Madam, Professor Sabrina, please, we would like to have you on the stage. Madam is a legend of dermatology, so and we would like to have the Feroz Sons team also. Assalamualaikum. It is a pleasure for me to announce the e-poster awards of this 43rd PADCON, and these e-posters awards have been put forward by Feroz Sons Limited. And the two judges for this have been Professor Sabrina Suhail Paul and Professor Tariq Rashid, our worthy teachers and honorable patrons. The first award goes to Dr. Yassan Saqib from Gujranwala Medical College. Many congratulations, Yassan. And also I congratulate Dr. Nabila Shahzadi, who is the supervisor for this PGR. Mr. Saqib and Mr. Shuaib are here. The second award goes to Zainab Raja. Zainab is not here, but her supervisor, Dr. Sadia Masood from Aga Khan Medical University, is here with us. Many congratulations, Dr. Sadia. The third award goes to Dr. Aisha Anwar from Faisalabad Medical University. Dr. Aisha Anwar is not present with us, and if anyone from Faisalabad can, the supervisor is also not here, and I congratulate Dr. Aisha as well as Professor Azam Bukhari, who was her supervisor. They are both not here, but if somebody wants to collect on their behalf from the hall, or we can hand it over to them later. Thank you so much, madam. I think we'll stay here for a group photo as well. I would like to invite all the senior members who are sitting here, please join us for a group photo. And thank you for being so patient.
Assalamu alaikum ji, good afternoon. Myself Dr. Numan Azam, I'm working as senior registrar in Shalimar Medical and Dental College. And with me with my co-moderators.
Dr. Khansa Ismail from Gangaram Hospital, Lahore. Assalamu alaikum and good afternoon.
Welcome you all to this exciting session of 43rd PADCON, where we'll be exploring some of the latest advancement in the treatment modalities of alopecia areata.
Today's discussion will be focusing on the cutting edge approaches that are shaping the future of alopecia areata. And for that, we have a panelist of experts that include Dr. Shakila Yusuf. Madam is a distinguished consultant dermatologist and aesthetic physician at PNS Shifa, also serving as assistant professor of dermatology at Bahria University of Health Sciences. Madam has made valuable contributions to the field through numerous publications in both national and international journals. Please welcome Dr. Shakila Yusuf. Our next panelist of expert is
Sir Saeed Afaq, please join us.
So we are going to call the speakers one by one. Our first speaker is Dr. Nida Nadeem, a new addition to the consultants of dermatology. She has recently done MD dermatology from Sheikh Zayed Hospital, Lahore, now serving in DHQ Hospital, Sheikhupura. Please, Dr. Nida, come on the stage.
Hello, Assalamu alaikum. My name is Dr. Nida Nadeem. I have recently done MD dermatology from Sheikh Zayed Hospital, Lahore. Today, my topic of presentation is comparison of vitamin D and serum calcium levels and its association with the extent and severity of alopecia areata among patients presenting to a dermatology unit of a tertiary care hospital. First of all, I would like to introduce what is alopecia areata. As you all know, alopecia areata basically is an autoimmune mediated disorder, and it is characterized by non-scarring hair loss on the scalp or any hair-bearing surface area on the body. In this case, the affected skin appears normal without any signs of inflammation or scarring. Scalp is the most frequently affected site on the body, and other hair-bearing areas can be involved. Then different subtypes of alopecia areata. The first type is alopecia areata circumscripta. In this subtype, there is a well circumscribed hair loss with the widest diameter of less than 10 cm. The second subtype is alopecia areata subtotalis. In this, the widest diameter is greater than 10 cm. Then totalis, there is hair loss from all of the scalp. Then universalis, in which hair loss is from all the body as well as from the scalp. The other type is CSFO pattern. In this type, there is loss of hair from the central scalp. And the other type is O-phasis pattern. It has got the worst prognosis among all the types. In this type, there is loss of hair along the hairline, especially affecting the occipital scalp. Another type is acute, diffuse, and total alopecia. In this type, there is abrupt and sudden loss of hair from the scalp. It has got a good prognosis. It can also mimic telogen effluvium. And the last type is Mary, Antoinette, and Thomas More syndrome. As you all know, alopecia areata basically affects the pigmented hairs. So
In this case, the patient develops sudden overnight graying of the hairs. Then disease severity according to SALT score. As you all know that in SALT score we divide the scalp into 4 quadrants. The central scalp is given 40%, the sides of scalp are given 18%, and the peripheral scalp is given 24%. And the percentage of hair loss in all these areas is multiplied by the area affected, and the sum of all this is SALT score. So it is S1, S2, S3, S4 and S5. More than S3 is considered in severe hair loss. So basically my topic was to find the association of vitamin D with alopecia areata. As you all know that vitamin D is a fat soluble vitamin. It is synthesized in epidermal keratinocytes. It has got 2 roles which linked it with alopecia areata. It has got anti-inflammatory and immunoregulatory role. It modulates the growth and differentiation of keratinocytes through binding to nuclear vitamin D receptor. It has an important role in hair cycle regulation. So basically, if when vitamin D binds to vitamin D receptor, so it leads to basically anagen initiation. If the vitamin D is absent, so after the destruction of hairs in catagen phase, the anagen is not be initiated. So vitamin D is important for hair cycle regulation as well as hair cycle recycling. The other biomarker in my study was to find the association with serum calcium levels. Serum calcium level has various cellular function, regulation of cellular proliferation and differentiation, including those of hair follicles. So basically, rationale of my study is deficiencies in vitamin D and serum calcium levels may trigger an autoimmune response. So they could be a risk factor for developing alopecia areata. And vitamin D is a preventable condition in our population, and a positive association can lead to reduction in the incidence and severity of alopecia areata by timely diagnosis and treatment. So basically, there were 3 objectives of my study. The first objective was to compare the vitamin D and serum calcium levels in cases group and control groups. The second was to compare the vitamin D and serum calcium levels in different subclasses of alopecia areata according to SALT score. And the other one was to find the correlation of vitamin D deficiency with the extent, severity, and duration of alopecia areata. The benefits of study are it was easy to perform, it was non-invasive and cost-effective. It is a case control study. The sampling technique was a non-probability convenience sampling, and it was conducted in outdoor patients of dermatology unit of Sheikh Zayed Hospital, Lahore. There were 2 groups in my study, case group and control group. So I would like to mention the exclusion criteria. Patient who had history of any topical, intralesional, oral steroids, any immunosuppressants, vitamin D supplements, or topical vitamin D analogs in the previous 4 weeks were excluded from the study. Female nursing or pregnant patients, as they are more prone to develop vitamin D deficiency, so nursing or pregnant patients were also excluded from the study. The other was diabetic patient, CKD, CLD patient, malabsorption patients, and any other autoimmune disorders like SLE, rheumatoid arthritis. They are also more prone to develop vitamin D deficiency. They were also excluded from the disorder. And patient with any chronic systemic disease for the past 6 months. And if patient has got history of any other drugs like antifungals or any other drugs like anti-epileptics, these patients are also more prone to develop vitamin D deficiency. So these were also excluded from the study. SPSS version 26 was used to enter the data. In my study, there were 2 variables, quantitative variables as well as categorical variables. So I have used both. The mean, I have calculated the mean and then the standard deviation, as well as I have used the frequency table and percentages. Here is the first chart showing in the alopecia group, basically the age group, the first table. The age minimum age was over 20 and maximum age was over 45. Same is the case with control group. And in the second table, you can see there were almost equal percentage of males and females in the study, as the bar chart shows. Then history of drug intake during the past 4 weeks in the alopecia group. the blue one is showing the alopecia group. In the alopecia group, only 5 patients were having history of drug intake, and in the control group, only 9 patients were having history of any drug intake. Then in presence of family history, in the case group, 9 patients were present with a history, have positive history of family history of alopecia areata, and in the control group, 7 patients were present with a positive family history of alopecia areata. Then, as I've already mentioned, that if the patient is having any chronic disease for the past 6 months, they were mostly excluded from the study. Only 2 patients from the case group were present with history of any chronic disease for the past 6 months. Here is the table showing I have compared different serum biomarkers in the participants. The last one you can see serum vitamin D levels in the case group was the mean levels were 15.8, and in the control group was 33.5, and the p-value is 0.000, which is statistically significant. And the serum calcium levels, the mean serum calcium levels in the case group was 9.1, and in the control group was 9.00, and the p-value is 0.4, which is not significant. Here is calcium deficiency. Here you can see in the case group only 12 patients were present with calcium deficiency, and in the control group only 16 patients and were present with calcium deficiency, and the chi-square is 0.03, which is not significant. So here is a bar chart showing in the alopecia areata patient, 12 patients were present with calcium deficiency and 33 were present without any calcium deficiency. And in the control group, 16 were present with calcium deficiency and 29 were present with without any calcium deficiency. Then my main topic to find the frequency of serum vitamin D deficiency in the case and control group. You can see in the case group 32 patients of alopecia areata among 45 were present with vitamin D deficiency, and which is almost 71%. And in the healthy control group, only 13 out of 45 were present with vitamin D deficiency, which is only 30%, almost 28%. And the chi-square is 0.00, which is significant. Here is a bar chart showing in the alopecia areata patient, 32 were present with vitamin D deficiency and 13 were present without. And in the healthy control is the opposite ratio, like mostly patients were present without vitamin D deficiency. As I've already mentioned, the other objective of my study was to find vitamin D deficiency in different subclasses of alopecia areata according to SALT score and to find their correlation. So most of the patients in my study were present in the fall into S3 or S2 category. Here you can see in the S3 category almost 23 patients were present, and among these 23, 16 were present with vitamin D deficiency, which is 50%. And in the S4 group, almost 15 out of 12 were present with vitamin D deficiency, and in the S5 group, mostly there were only 3 patients and 3 were present with vitamin D deficiency. So here you can see, as the severity of disease increases according to SALT score, the vitamin D deficiency also increases, and it has got a positive correlation with alopecia severity. So here you can see the bar chart showing. Here you can see vitamin D deficiency in mostly, as I've already mentioned, most patients were present in the S3 and S2 category. Mostly S2, which is showing the red one, 16 patients were present with vitamin D deficiency, almost from 20. And from the green one is showing S4 group, and 12 patients were present with vitamin D deficiency. And the orange one is showing S5 group, and 3 patients were present with vitamin D deficiency. Then I have also found the correlation of calcium deficiency with different subclasses of alopecia areata according to SALT scoring. Here is a bar chart summarizing all this. Calcium deficiency is present only in S3 group in only 2 patients out of 21 patients, so it is not significant. The last objective of my study was to find the correlation of vitamin D levels, vitamin D deficiency with severity of the disease according to SALT scoring, duration and extent of the disease as well. Here you can see as the duration of disease increases, extent of disease increases, or severity of disease increases, the vitamin D levels also vitamin D deficiency also increases. So results, a t-test comparison of different biomarkers in the blood revealed that there was a significant difference in vitamin D levels between two groups. Alopecia areata group had a mean vitamin D levels of 15.83 and controls had vitamin D levels 33.50. There wasn't any significant difference between the groups regarding serum calcium levels. A significant difference between the frequency of participants with vitamin D deficiency was noted with 32 participants in the alopecia group. And so discussion is that the patient with alopecia had lower vitamin D levels and higher risk of vitamin D deficiency but no lower serum calcium levels. The beneficial effect of vitamin D is mediated through prevention of strong Th1 responses on antigen presenting cells while tilting the T cell responses towards Th2 cells. As alopecia areata is a Th1 response, so basically vitamin D is present. If vitamin D is present, so it is shifted towards Th2 response, and the hair follicles are not attacked by immune cells. So the benefit. Vitamin D triggers a switch from Th1 to Th2 response. It also reduces the production of pro-inflammatory cytokines by suppressing the Th17 response, and it also inhibits growth of B cell. As a result, lack of vitamin D causes loss of self-tolerance. And alopecia areata is a Th1 mediated disease. Vitamin D insufficiency could be a contributing factor. Vitamin D deficiency plays a significant role in alopecia areata. However, the role of serum calcium levels need further exploration. Limitation of my study is a small sample size. Study is retrospective, and vitamin D deficiency is widespread in our country, and its impact on disease severity warrants further exploration. So the take-home message is that normally when patient of alopecia areata comes, we don't go for vitamin D levels. So the message is that if patient of alopecia areata comes, also go for vitamin D levels, as it is strongly linked with alopecia areata. Thank you.
Thank you, ma'am. Our next speaker is Dr. Behin Vyas. She is a postgraduate resident from Shalimar Medical and Dental.
It's a matter of immense honor and pleasure for me to present my research work to such a distinguished panel of experts and dermatologists all over the country. I'm Dr. Behin Vyas. I'm working as postgraduate resident in the Department of Dermatology, Shalimar Medical and Dental College. And today, I would like to dive into a topic that affects millions worldwide: alopecia areata, a condition that causes distressing hair loss and patches, impacting not just the physical appearance but also emotional and mental health. So researchers have recently drawn attention to the potential role of vitamin D as a treatment option. Now, this presentation explores our finding on the efficacy of topical calcium for the treatment of alopecia areata. I have no financial disclosure or conflict of interest with the presented material in this presentation. Now, let's begin by exploring what makes this condition so impactful. Alopecia areata is a complex autoimmune disorder that primarily affects hair follicles and results in non-scarring hair loss. It is a global health concern affecting 160 million people worldwide with a lifetime incidence risk of 2%. It affects individuals of all age groups without any gender or ethnic predilection. So it has a varied clinical presentation ranging in severity from mildest form of patchy alopecia areata to severe, where there is diffuse thinning of hair all over the scalp. Then ophiasis pattern causes a band-like hair loss over the scalp. And alopecia areata totalis, which causes complete hair loss all over the scalp. Then universalis pattern, which causes hair loss not just on the body but also including eyelashes as well as eyebrows. Its pathogenesis is believed to be mediated by an immune disruption of hair growth cycle. So our hair growth cycle consists of 4 phases: anagen, catagen, telogen and exogen. Anagen, being the phase of active hair growth is the longest one, lasting from 2 to 5 years. In patients with alopecia areata, there is a pathological shortening of this phase, which results in a rapid transition of hair follicles from this phase to the other phases of hair growth cycle and premature hair shedding. Now, hair follicles are the site of immune privilege, which prevents an autoimmune reaction against antigens on the surface of hair follicles. This immune privilege is maintained by a reduced expression of MHC1 and 2 receptors on the surface of hair follicles, presence of regulatory T cells in perifollicular area, and CD8 positive and natural killer G2 T cells suppression. Now, in alopecia areata, this immune privilege is lost and it causes increased expression of MHC1 and 2 receptors with increased self-antigen presentation, increased interferon gamma activity, and increased expression of natural killer G2 ligands. So what happens is that it creates an inflammatory environment. It causes recruitment of more and more CD8 positive T cells in perifollicular area, which in turn damage hair follicle epithelial cells, resulting in hair loss. Now, vitamin D is believed to play a vital role in hair growth cycle as well as in the maintenance of immune privilege through different mechanisms. For example, it decreases interferon gamma levels, it causes down-regulation of natural killer G2 and activating CR3 ligands, and it causes inhibition of JAK-STAT pathway, and finally attenuation of oxidative stress response. Calcipotriol is a vitamin D analog. It's a synthetic drug which acts by binding vitamin D receptors on the surface of hair follicles and mediates its potential effects. Now let's talk about our study. So our main objective was quite straightforward to determine the efficacy of topical calcipotriol 0.005% for the treatment of alopecia areata, particularly mild to moderate disease. It was a descriptive case series which was carried out for a period of 6 months in the Department of Dermatology, Shalimar Hospital, and we took a sample size of about 100 patients who were taken into the study by doing a non-probability conjunctive sampling. According to our operational definition, alopecia areata was defined as focal or patchy, non-scarring hair loss, and its severity was graded into 3 grades based upon the percentage of scalp hair loss, with mild cases having less than 20%, moderate cases having 21 to 49%, and severe cases with 50 to 100% scalp hair loss. Now, hair regrowth scale was used for the assessment purpose, and it was also categorized into 4 grades based upon the percentage of hair regrowth. Scale 1 showing 0 to 25% and scale 4 showing 76 to 100% hair regrowth. And efficacy was defined as achievement of more than 50% hair regrowth or hair regrowth scale of 3 or 4 by the end of 12 weeks period. In our study, we included all the patients who were of either gender, and they ranged in age from 5 to 65 years and had mild or moderate disease. And we excluded all the patients having severe disease or alopecia affecting other body sites and other patrons including alopecia brutalis, universalis, and ophiacis. We also excluded females who were pregnant or lactating, patients using topical or systemic steroids, vitamin D supplements, or other immunosuppressive drugs in past 1 month, and all those having active infection at the lesional site. Now, all the patients, they applied calcipotriol topically in the form of ointment was 0.005% strength, which applied twice daily on the patches of alopecia areata for a period of 12 weeks. Now, this drug was funded by our funding department, and also we used the drug of same company to avoid any conflict of interest. Efficacy was measured at the end of 12 weeks period. Now, I'm going to explain some of the demographics of my patients. So we found that 96% of our patients, which means major chunk of our patients, they belong to age group of 5 to 40 years. 64% patients had a mild disease, while 36% patients had a moderate disease. This bar chart shows a near equal gender distribution, with 54% patients being male and 46% females. Only 20% patients, they had a positive family history of alopecia areata. Now let's reveal the results. We found that our drug was effective in 69% of the patients, with 31% patients not showing the desired treatment response. We stratified efficacy of our drug with respect to certain variables such as age group, gender, duration, family history, and severity of the disease, with the severity being the only variable that had a significant impact on the efficacy of our treatment. So let's elaborate this one. So this chart shows the stratification of efficacy with respect to the severity of the disease. And here we can see among the patients having mild disease, 89.1% patients, they responded effectively to the treatment, while among those having moderate disease, 33.3% responded favorably. So patients having mild disease, they had a better treatment response. In the end, we compared our study results with some of the locally and internationally conducted studies, and we found that there was a generally higher efficacy across across different studies. We found that German et al. Reported his efficacy to be 69.2%, which was quite identical to our study results. Naranki et al. Found it to be slightly lower of 59.1%, and Jaswal CS et al. Reported it to be 52.8%, showing slight variability which might be due to different study conditions and sampling techniques. In conclusion, calcipotriol can be used as a safe and effective treatment options, particularly for the patients having mild to moderate disease of alopecia areata. However, our study also emphasizes the need of more extensive control trials to further validate these results. Our limitations were that it was carried out in a single center. We had a small sample size and there was a lack of long-term follow-up, which we recommend addressing in future studies. Thank you very much for your active and patient listening. In the end, I have shared some of the references.
Thank you, Dr. Maureen. May I Professor sir, can you join us on the stage, panelists? Now, next speaker is Dr. Sharika Khan. She is a postgraduate resident in Turkey Hospital.
Assalamu alaikum. I am Dr. Sharika Khan, PGR from Gurki Trust Teaching Hospital, and today I will be presenting on efficacy and safety of tofacitinib in patients with alopecia areata. This study is partially facilitated by Hirani's Pharmaceuticals. Giving a brief review of the alopecia areata, as we all know, it's an autoimmune disorder mediated by CD8 positive T lymphocytes that target the hair follicle bulb region. It is the second leading cause of hair loss. Its chronic course of the disease contributes to substantial psychosocial burden among the patients. The treatment of moderate to severe alopecia areata is particularly challenging, as it's often refractory to the conventional use therapies, that is corticosteroids, cyclosporine, methotrexate. The emerging drug JAK inhibitors, tofacitinib, that inhibits Janus kinase 1 and Janus kinase 3, it blocks the progression of alopecia areata by modulating the cytokines, mainly interferon gamma, interleukin 15. It acts to the Janus kinase pathway, inducing immune suppression. As there is a huge psychological burden of alopecia areata, the conventional therapies for the disease have a limited efficacy. So more effective and safe treatment options are urgently needed. That gives the rationale of this study. The objective of this study is to determine the efficacy and safety of tofacitinib in patients suffering from alopecia areata in our population. The patients included in this study were aged between 12 to 60 years. They were both male and female. The duration of current episode of the disease was more than 6 months. Patients who were having SALT greater than or equal to 30%, alopecia totalis and alopecia universalis were included. Those patients who have refractory disease or treatment failure after using one or more first-line therapies for alopecia areata. The patients were excluded who were suffering from other scalp and hair disorders such as telogen effluvium, trichotillomania, and tinea capitis. The patients having other systemic disorders such as in the previous 6 months before starting the treatment, such as chronic renal failure or any malignancy. Patients taking any systemic immunomodulatory medications or biological agents, and patients who show hypersensitivity reactions to tofacitinib or any of its components, and pregnant and lactating women. This is an ongoing quasi-experimental study being conducted at LMDC Gurki Trust Teaching Hospital, Lahore. The approval was taken by the Ethical Review Committee. Written informed consent was taken from the patient, and the pre-treatment laboratory investigations such as complete blood count, liver function test, renal function test, fasting lipid profile, hepatitis B and C, surface antigen, IGRA were done before starting the treatment. Tofacitinib 5 mg was given twice daily for 6 months, and the patients were followed for the next 3 months. The severity of disease was measured by SALT score calculation. The SALT score was calculated first at the baseline and then at each follow-up visit on 4, 8, 12, 16, 20, and 24 weeks. The efficacy was measured on the basis of SALT score improvement greater than 50% at 24 weeks of the treatment. Safety was measured in terms of adverse events noted on a pre-recorded performer. And patients were assessed at 32 weeks for the relapse. 37 patients were enrolled to date, and one patient dropped out at 8 weeks. The results of the study showed the gender distribution. The males were 58%, the females were 42% in the study. The age range from 12 to 55 years. The maximum patients were between 20 to 39 years of age, as shown in the graph, and they were 54.1%. The mean age of the patients was 23.4. Majority of the patients were students, that is 56.76%. Then 18.92 were office workers, 13.51 were manual workers. The duration of the current episode of the disease falls between 6 months to 2 years, and the total duration falls between 5 to 10 years in majority of the cases. The comorbid conditions in most of the cases, there was no comorbidity, but in 11% had allergic rhinitis, 2% had vitiligo, 3% had rheumatoid arthritis, and 3% had atopic dermatitis. The type of alopecia in most of the cases was patchy alopecia areata, that is in 57% of the patients, and 43% had alopecia universalis. The nail changes in most of the patient, they had no nail changes. The 24% of the patient had ridges, 14% had pitting, and 5% had rough cuticle. So our result showed that SALT at the baseline was 60.89, which shows a significant improvement. That is, at 24 weeks it was reduced to 14.34. So a significant improvement was observed with a p-value of less than 0.05. The majority of our research showed that majority of the patients were intermediate responders. That is 50% of the patient that showed 5 to 50% improvement in the SALT score. Then 41.2% of the patients were strong responder, and 8.8% of the patients were non-responder. That is less than 5% of improvement in SALT score. These were the adverse events noted, which were mild. That is, headache was present in 11.11% of the patients, fatigue was there in 8.3%, abdominal pain in 2 patients, and that is 5.5%. Diarrhea was there in 11.1%, pruritus was there in 5.6%, cough was there in 5.5%, and upper respiratory tract infections were there in 8.3%. Acne was there in 5.6%, and major adverse cardiovascular events, reactivation of tuberculosis, herpes zoster, and thromboembolic event was not reported in any patients. Neither there was no laboratory abnormality noted. These are the images of some of the patients. On the left is the pre-treatment, and on the right shows the after post treatment. So it is concluded that tofacitinib is a safe and effective medication for the treatment of alopecia areata in our population. As already described, 41.2% of the patients were strong responder, 50% of the patients were intermediate responder, 8.8 were non-responders, and 18.9% of the patients showed relapse at 28 to 32 weeks after discontinuing treatment at 24 weeks. Thank you so much.
Now we are done with the presentations. I would like to ask the respected members of panels to please ask if they have any questions.
Hello. Any questions from the audience?
Sir, if you are having any question with the speakers, you can ask as well.
I think on the whole, the studies were good, and we really enjoyed. I mean, these are the tofacitinib is being used for some time and has very good effects, and the way she has shown seems to be very promising. And the vitamin D and calcium level, and I mean treating their deficiency and giving them as a supplement, it seems very good results. I mean, something new coming up, that not only that the immunosuppressants and the steroids, they have their effects, and the previous, I mean, the growth promoting agents used as in addition to them, these things should also be considered. But I mean, these are not all. You have to take into account all the aspects of the person's life, the other contributing diseases, the other deficiencies like iron levels, etc. They also promote the hemoglobin levels and any other diseases which are being, which are running in the family. And it is that you have continued, if they have for some restricted period of time, but there should be long-term follow-up. That because the disease is running, I mean, you may continue it for 12 weeks, maybe 3 months, maybe 6 months, but the disease is sometimes running, and when you stop the drug the relapse occurs. So it has to be continued, and you have to follow the patient for long term.
Okay, Professor Dr. Tahir sir, if you are going to give some valuable comments.
Thank you very much. As Dr. Abab already told, since we are dealing with some of the chronic recalcitrant conditions, so definitely there is always room for newer modalities, and there should be any hesitation using them, because anything which was used as a first modality, at that time nobody knew what's going on. Now what we are doing after good trials on animal and human, so we should not be reliant, number one. And number two, definitely for chronic conditions, the follow-up and sample size. These two things are very important, and I hope these young dermatologists in future, they are going to learn, and they will continue it, and they will come up with studies which are of more substance. Thank you very much.
Dr. Shakila Yusuf, madam, please give your valuable comments about the presentations.
Sir Afaq and our respected professor have already given very valuable comments, and I think we are already running short of time. But as we already know that alopecia areata is not a disease. It's actually have very strong impact on patient life. So we have to see the patient as a whole, and we have to investigate all the treatable causes first, and then we should definitely try the newer options which are giving hope to the family and the patient. Thank you.
Thank you so much, everyone. Now we are going to start the shield distribution. I would request the member of panel to please come forward. We are going to call our speakers one by one. Our first speaker, Dr. Nida Nadeem. Please come on the stage for receiving shield. Dr. Maheen Khayas, Dr. Sharika Khan, Dr. Sharika Khan. Now we are going to have shield distribution for our member of panelists as well. And Sir Dr. Afaq, please come forward. Thank you so much. Next, Professor Dr. Tahir Saab. Dr. Shakila Yusuf. Now we are having shields for moderators as well, so please. Dr. Numan Bukhari. Then for myself, Dr. Khansa.
Thank you everyone. This is all for the session.
Bismillahirrahmanirrahim, in the name of Allah, the Beneficent and Merciful. The PAD conference, the PAD conference so far has been really wonderful, and I should pay my gratitude to Dr. Nadia and Dr. Louise and their team for being so wonderful. Let's not waste any more time. Today this session is about a technique about which I cannot say that that is an innovation, but that was a lost treasure, and it was refound, and we are fortunate enough to have those people here who have been the pioneers of this technique and those people who are patronizing this technique here. And now we are at such a stage that we have research papers, and today we'll be having those research regarding epiluminescence microscopy, which is also known as dermatoscopy. Before I move any forward, first of all, I would like to request the panel of experts to please come onto the stage and take their seat. First of all, I would like to request Dr. Tahir Jamil Ahmed, and he doesn't require any introduction. He is a professor of dermatology. He is a person who has brought about a lot of innovation, and my heartfelt gratitude to sir for reintroducing this dermatoscopy in Pakistan.
Our next panel of experts is Dr. Aisha Kayas. She is Associate Professor in Dermatology at New Hospital, Lahore.
Dr. Aisha is doing a wonderful job regarding dermatoscopy and introducing AI into dermatoscopy. Whatever you talk about dermatoscopy pertaining to Pakistan, you can never miss out her name. Thanks, madam, for being here. Our next panelist has come all the way from Multan. She also doesn't require any introduction. Dr. Shazia Zubair, she is serving dermatology for so long, and thank you, madam, for giving this grace to the occasion and to the stage. Madam, please come onto stage.
And our final panel of experts is Dr. Uzair Qureshi. He is ex-consultant in dermatology in Qaid-e-Azam Medical College, Bahawalpur. He has also been on the various posts in the PAD, from president to joint secretary to journal secretary. Dr. Uzair, please come on the stage.
I must say before moving on any forward that if these great people sitting on the stage lighted the torch, we need a torch bearer to spread that light. And I'm pleased to know that our upcoming dermatologists are conducting some really good research into it. Let's not waste any more time and call onto stage our first speaker, Dr. Mohammad Wajahat, a postgraduate resident from Mayo Hospital, Lahore, with his research on to find the frequency of various dermatoscopic features in clinically diagnosed cases of plaque psoriasis.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. My name is Dr. Mohammad Wajahat. I'm postgraduate resident in Department of Dermatology, Unit 2, Mayo Hospital, Lahore. Today I'm going to present you frequency of various dermoscopic features in plaque psoriasis. My home institute, King Edward Medical University, my dear Mayo Hospital, and my dear department headed by Professor Dr. Anil Askar. Psoriasis, everybody of you are very much familiar with this disease. It is a group of common chronic inflammatory and proliferative skin diseases that is characterized by erythematous, scaly plaques present particularly over the extensor surfaces and the scalp. The incidence of psoriasis is increasing in our part of the world. Annually, the patients of psoriasis are increasing. The objectives of the study are to characterize psoriasis by looking at following features on the dermoscope for definitive diagnosis. We will look for diffuse scales, we will look for dotted vessels, we will look for vascular morphology, and we will go for background erythema. My dear colleagues, psoriasis is a common disease that is usually diagnosed clinically. Sometimes there is an overlap between psoriasis and eczema. Here we have to go for the biopsy. Sometimes either the patients are reluctant to go for the biopsy, or because of unavailability of the resources, we can't do it. And the patient wants to go for the diagnosis. Here comes the role of dermoscope. By looking at various clinical features of dermoscope, we can easily differentiate psoriasis from the eczema. Dermoscope. Dermoscope is a new age, increasingly popular diagnostic tool of great value. It is a non-invasive tool that has emerged as an indispensable guide for diagnosis of many skin diseases. It involves the better vision of skin disease by a combination of magnification, illumination, and depth. Yesterday, we had a very nice talk by our ma'am, Dr. Aisha and Dr. Huma, and there was a lot of audience, and I'm very happy that the trend of dermoscopy is increasing in our part of world. The dermoscopy of psoriasis is characterized by dotted vessels, symmetrical and regular distribution, diffuse white scales, and light or pink background. The dermoscope that I used in our department is DermLight DL4. It has a magnification capacity of 10 times. However, we can also digitally magnify the image by capturing the image in our phone. The dermoscope it has a rechargeable battery, 18 LEDs wide efficacy. The combination of these four characteristics that I have already mentioned have a diagnostic specificity of 100%. Methods and materials. This study was conducted in our Department of Dermatology, Unit 2, Me Hospital, Lahore. Study design was cross-sectional study. Study duration was 6 months after the approval of synopsis. The cases that were enrolled were 45 patients. Sampling was non-probability consecutive. Inclusion criteria. Clinically diagnosed cases of plaque psoriasis with the age of 16 to 60 years, and patients of both gender were included. Exclusion. Those patients who were on topical or systemic treatment like corticosteroids, methotrexate, retinoids, biologics for the duration less than 1 and 6 months respectively before recruitment, and those patients who had concurrent skin infection were excluded from this study. Data was analyzed by SPS version 20. This was a patient presented to us, 50 years old male, with a history of psoriasis from last 15 years. My colleagues, you can appreciate dotted vessels that are evenly and symmetrically distributed, background erythema and diffuse white scaling. This is what I want to show. Initially I told you we can easily, by dermoscopy, we can easily differentiate psoriasis from the eczema. In psoriasis, these red dots, dotted vessels, are symmetrically and equally distributed. However, in case of eczema, there is irregular distribution of these vessels. This was another, you can also see dotted vessels, background erythema, very good, and white scales. Another picture with the same, can you appreciate dotted vessels? Here dotted vessels, background erythema, and white scales. Similarly, the results on dermoscopic examination of psoriatic lesions, these were characterized by light red to pink background in 60% of patients. Regular distribution was present in 80% of the patients. White scales were present in almost 90% of the patients, and dotted vessels were present in all 100% of the patients. In my study of 45 patients, there were 27 males and 18 females. Dotted vessels were present in all 45 cases. White scales were present in 40 cases. Regular arrangement was in 36 cases, and light red background in 27 cases. I've compared my study with other studies as well. The one study that was conducted in China, accuracy of dermoscopic and reflectance confocal microscopic criteria for diagnosis of for the diagnosis of psoriasis. Here, the results were psoriatic lesions were characterized by a light red pink background in 65%, with dotted vessels in 100%, their regular distribution in 85%, and white scales in also 85%. Another study was conducted in India, cross-sectional study to assess the role of dermoscopy in diagnosis of palmar psoriasis. The results were characterized by dotted vessels in 76%, their regular distribution in 71% of the patients, diffuse scaling was in 76%, and white scales were in 65% of the patients. So my conclusion is dermoscopic diagnosis of plaque psoriasis can be made with confidence and this may ameliorate the need of biopsy in most cases. These are the references from where I took all the guidelines, and thank you very much.
Our next presenter is Dr. Kubaib Tahir from, he is the PGR in Lahore Medical and Dental College. Dr. Kubaib, please.
Bismillahirrahmanirrahim. My name is Dr. Kubaib Tahir, and today I am going to be presenting my topic on association of onychoscopic features and nail plate potassium hydroxide test positivity in diagnosis of onychomycosis. Onychomycosis is a chronic fungal infection of the nails which is caused mainly by dermatophytes and candida species. It occurs mostly in humid and warm environments, impaired immunity, poor hygiene, and trauma conditions. It clinically presents as nail thickening, brittleness, subungual debris, and discomfort. The main patterns of nail involvement are distal and lateral subungual, proximal subungual, superficial white, and total dystrophic onychomycosis. The main diagnostic techniques that we employ are potassium hydroxide test, which dissolves keratin to visualize the elements. It has the limitations of that it does not confirm the specific species and limited sensitivity. The other technique is culture, but it is very costly and time consuming. Onychoscopy is non-invasive and it helps us to identify the nail changes and differentiates fungal infections from other disorders. The rationale of our study was to use onychoscopy alone for diagnosing onychomycosis, especially in resource-limited settings like Pakistan, if the features associate significantly with the test. The objective was to estimate the association between the features and the test. We included adult patients of both genders who were treatment naive or who hadn't taken treatment in the past 3 months. And we excluded the patients of other nail disorders and those who were autoimmune, those who had autoimmune diseases or who were immunocompromised. This was a cross-section study conducted in the dermatology department of Quality Trust Teaching Hospital on 52 patients after taking approval from the Ethical Review Board. Initially, onychoscopy was performed with high delta microscope under polarized and non-polarized light, and the photographs were captured. Then, distal edge of nail was clipped and subungual material was collected. The sample was placed in 20% KOH and kept overnight for 24 hours. This was later examined under the microscope at 10, 40, and 100x magnification to identify the Hyperion scores. The study tool included patient demographics, comorbid conditions, number of nail involvement, test results, and presence or absence of the features. Now for the demographic characteristics, our study had 42 females and 10 males. The average age of participants was 42.4 years, and the average disease duration was 11.9 months. The most common comorbid conditions that we encountered during the study were diabetes and hypertension. The most common type of onychomycosis we encountered was distal and lateral subungual, followed by total dystrophic melanoma. These are the clinical images. In the first image, we can see subungual hyperkeratosis and jagged edge with proximal spikes. And in the second image, we can see fungal melanonychia and bromonychia. Here, the first image shows longitudinal stria, jagged edge with spikes, and distal onycholysis. And the second image again shows fungal bromonychia with onycholysis. Here again, you can see fungal melanonychia, and in the second image, you can see longitudinal stria resembling the aurora borealis. The first image here shows longitudinal stria, distal irregular termination, subungual hyperkeratosis, and jagged edges. And the second image shows us longitudinal stria, distal onycholysis, and fungal melanonychia. Here again, we can see subungual hyperkeratosis and distal irregular termination. And in the second image, we can see jagged edges, longitudinal stria, and hyperkeratosis. Now, through data analysis, 43 of the patients had positive KOH test while 9 had negative. This is an image which shows association of the features against the positive test. As you can see, onycholysis it was present in 40 patients, out of which 37 were KOH positive. Similarly, jagged edges were seen in 35 patients, out of which 34 were KOH positive. Distal irregular termination has the least number of KOH positive cases. Onycholysis had high sensitivity and a positive predictive value, and its p-value was significant when we compared it with less than 0.25. Subungual hyperkeratosis had a moderate medium positive predictive value, while its p-value was significant and its sensitivity and specificity was low. Longitudinal stria had high positive predictive value, but sensitivity and specificity were low, and its p-value was not significant. Jagged edges had the highest positive predictive value and specificity, and its p-value was highly significant. Chromonychia had high positive predictive value, but low sensitivity and specificity, and it did not have a significant p-value. Distal irregular termination had medium positive predictive value, while with low sensitivity and specificity, and a significant p-value. To summarize, onycholysis and jagged edge had high sensitivity and statistically significant p-values. Chromonychia and longitudinal stria had moderate sensitivity and positive predictive value, but they were not statistically significant. Subungual hyperkeratosis and distal irregular termination, while being statistically significant, they had low sensitivity and specificity. The limitations of our study was a relatively small sample size, reliance on a single diagnostic test. There was limited comparison with alternative diagnostic method which restricts the comprehensiveness of the assessment. There is definitely an observer bias as onychoscopy relies on visual interpretation, which may vary between every patient. And there is lack of follow-up as the study cannot assess the progression of the features over time or treatment outcomes. To conclude, while onycholysis and jagged edge are promising indicators, integrating multiple features and further research in multi-feature diagnostic algorithms will improve the diagnostic accuracy. Thank you.
Thank you very much, Dr. Khubaib, for enlightening us with a use of dermatoscopy beyond malignancy. And now we know that it's not only limited to the diagnosis of dermatoscopy, but in addition to the diagnosis of malignancy, it can be put forward to the uses of in diagnosing infection and inflammatory skin condition, as we saw in the first paper about psoriasis. Now let's move on to our next speaker, who is Dr. Javeria from Services Hospital, Lahore, and let's see that what new innovation has she brought about in dermatoscopy.
Assalamu alaikum, respected seniors and esteemed colleagues. It's an honor to stand before you. I'm Dr. Javeria from Services Hospital, and today we'll be discussing about the frequency of various dermoscopic patterns of pityriasis versicolor. So the rationale of this study is it contributes to the non-invasive, practical and accessible diagnostic strategies for the dermatologists all around the globe, particularly in areas like our country, where laboratory facilities for diagnosing pityriasis versicolor like fungal cultures are scarce. So we are all aware that pityriasis versicolor affects millions of people globally, and it is the most common superficial fungal infection. However, it is diagnosed clinically, but sometimes we experience certain worrisome lesions which have mimicking differentials like vitiligo and P. alba. for those, we require microscopic analysis and cultures. But the KOH mounts, or the microscopic analysis, is not enough specific or sensitive for pityriasis versicolor. And also, the cultures are very time consuming and are not always available, especially in our part of the world. So dermoscopy has emerged as a non-invasive technology which is used to examine such worrisome lesions. So the objective of my study was to analyze the frequency of various dermatoscopic patterns of pityriasis versicolor lesions presenting as hypo or hyperpigmented plaques in our part of the world, in our population. So it was a cross-sectional observational study done in Dermatology Department of Services Hospital in a duration of around 6 months from April to September 2024, and a sample size of around 75 patients were enrolled, and the sampling technique was non-probability consecutive sampling. All the patients, male and female, were included with positive KOH scrapings from age 10 to 60 years. Only those patients were excluded who had a history of use of topical treatments for the last 4 weeks and who had coexisting skin conditions mimicking pityriasis versicolor, as discussed earlier, and negative fungal scrapings. So this is an ethical approval of my research. The so now coming on to the data collection procedure, the areas from the representative lesions were examined using dermoscope. That was Heine Delta 30 dermoscope connected to S20FE camera, polarized mode at 10x magnification. The dermoscopic patterns of pityriasis versicolor were noted as per operational definitions and were filled in the pre-formed proforma. So this was the proforma of my study. And all the patients underwent KOH scrapings. The positive KOH scrapings patients were included into the study. And this is the fungal scrapings as the pityriasis versicolor has a typical spaghetti and the meatball appearance, which is clearly shown in this picture, the meatballs and the spaghettis. So now coming on to the demographic data. Most of the patients that were included in the study that we conducted at Services Hospital were from 21 to 40 years, followed by 10 to 20 years age group. Most of the people so coming out of the gender distribution, most of the people included in the study were males, 68%, and 32% were females. Most of the patients had a normal BMI, followed by overweight patients. Most lesions that we examined and did dermoscopy were of more than 3 months old, and followed by 1 to 3 months old lesions. The types of lesions were hyperpigmented, hypopigmented, and mixed ones, and among them the hyperpigmented lesions predominate. These are the hyperpigmented lesions and the hyperpigmented lesions and the mixed lesions of my patients. The most commonly involved site was the trunk, followed by the trunk and upper limbs. The pattern analysis, the patterns were analyzed and the data was put into the SPSS and it was then analyzed. So these are the patterns that we noticed. This is non-uniform pigmentation, which is characterized by uneven distribution of the pigment across the lesion as shown in the figure. So this was the most common and most prevalent pattern noted among the hyper and the hypopigmented lesions. Next pattern is the vascular pattern. The dotted vascular pattern, the linear branching or the branching vascular patterns were all observed in pityriasis versicolor. However, in our study, the most frequent pattern observed was linear branching, and it was most commonly observed among the hypopigmented lesions. The next pattern is a clearly demarcated border, which is characterized by a rim of a clearly demarcated or a well-defined rim of hyperpigmentation around the lesion, and it was most frequently observed among the hypopigmented lesions as compared to the hyperpigmented ones. Now coming on to the inconspicuous ridges and furrows, which are the subtle ridges or furrows or ill-defined grooves. They were more predominant in the hyperpigmented lesions as compared to the hypopigmented ones. Then comes another pattern, the perilesional hyperpigmentation, which is characterized by not that well defined, but the diffuse hyperpigmentation surrounding the lesion and separating it from the normal skin. So it was more frequently observed among the hyperpigmented lesions as compared to the hyperpigmented ones. Another pattern observed was the hair follicle invasion, which is characterized by a white dot around the hair follicle, as you all can see in this picture. This is because of the Malassezia yeast invading the hair follicle. This pattern was most frequently observed among the hyperpigmented lesions and in comparison with hypopigmented ones. Next is the scaling. Numerous patterns of scalings were observed in the lesions, which include the patchy scaling, diffuse scaling, perilesional scaling, and perifollicular scaling. However, the most frequent scaling observed in our study was the perilesional scaling, and it was more commonly found in the hypopigmented lesions in comparison with the hyperpigmented ones. There was also another phenomena that was observed known as the satellite phenomena, in which a large lesion, a large hyperpigmented lesion, is surrounded by baby or small lesions in the peripheries. So now coming on to the role of confounding factors, well, the inconspicuous ridges and furrows were significantly more frequent in the male patients with a p-value of around 0.02. Hair follicle invasion emerged as the most common dermoscopic feature, particularly in the lesions that were located on the trunk, and p-value was 0.03. And additionally, in the lesions more than 3 months, clearly demarcated border was identified at a statistically significant rate, and p-value was 0.0006. So the dermoscopic patterns of pityriasis versicolor are observed all across the world, and numerous studies are being conducted recently as well in India, Canada, and England. Well, in Indian studies, the population, as we share the same, we are from same subcontinent area, the perifollicular and diffuse scaling, along with non-uniform pigmentation, was among the most common frequent pattern noted in P. versicolor lesions. And in England, scaling and non-uniform pigmentation was noted as the most pronounced pattern. And patchy scaling was observed frequently in the patients in the study done in Canada. Perifollicular involvement was reported within lower frequency. The strengths of my study are it's novel and it is relevant. It enhanced the diagnostic accuracy, and it has a clinical utility. It is a comprehensive analysis, and it can serve as a foundation for the future studies. There were few limitations to my study. Only those cases were included who were confirmed by KOH, and as we all are familiar with the fact that KOH is not 100% sensitive for pityriasis versicolor. And fungal cultures were not done to relate dermoscopic patterns to fungal species. So now I'm concluding my study by the vascular patterns, clearly demarcated borders, and perilesional scaling were the most common patterns observed in hyperpigmented lesions. And in contrast, the hyperpigmented lesions commonly displayed non-uniform pigmentation, hair follicle invasion, perilesional hyperpigmentation, and subtle ridges and furrows. Non-uniform pigmentation was the most frequent pattern observed in all the lesions, and perilesional hyperpigmentation was the most frequent pattern observed in hyperpigmented lesions. So there's no conflict of interest, and these are the references to my study. That's all for today. Thank you so much for your attention.
Thank you so much, Dr. Javedia. Our next presenter is Dr. Iman Aisha. She is also a postgraduate resident in Lahore Medical and Dental College. She will be talking about dermatoscopic assessment of nail fold capillary patterns in the different autoimmune connective tissue diseases.
Bismillahirrahmanirrahim. I am Dr. Iman Aisha. I'm a postgraduate resident at dermatology in Khurki Trust and Teaching Hospital. The topic of my presentation today is dermatoscopic assessment of nail fold capillary patterns in different autoimmune connective tissue diseases. Okay, starting with a brief introduction about my disease and the dermatoscope. As we all know, dermatoscope is dermatoscope is a non-invasive tool to detect the proximal nail fold capillaries. It signifies the development of vascular alterations in the connective tissue diseases, which can detect early morphological changes before the development of the clinical symptoms. Thus, it aids in disease assessment and progression of the disease. The objective of my study was to identify the nail fold capillary patterns in different autoimmune connective tissue diseases, and then I would correlate those capillary patterns with the disease severity in each of the following diseases. Okay, it was a cross-sectional study done at Ghurki Hospital with a sample size of 96 patients, and the sampling technique was non-probability convenience sampling. The study started after taking ethical review board from the Lahore Medical and Dental College. A retained detailed pro forma was filled in and consent form was signed from all the patients. Patients were examined for the nail fold capillary patterns with the handheld Hind Delta 30 dermatoscope, and the involved areas were photographed. The inclusion criteria included all those patients which were aged more than 15 years. They were both genders, male and female, and the following diseases were included in my study. That included systemic sclerosis, SLE, systemic lupus erythematosus, dermatomyositis, and the rheumatoid arthritis. Smokers, diabetics, and those patients who had ungual or periungual disease were excluded from my study. So this is the frequency of the diseases which were included in my study population. Most of the patients which were seen belonged to rheumatoid arthritis, followed by systemic lupus erythematosus, then systemic sclerosis, and the least number were the dermatomyositis patients. Before proceeding for the results, I would like to explain a bit about the nail fold capillary patterns which can be seen by a dermatoscope. As you can see, the normal nail fold appears like a hairpin looped like picture. It can be serpentine and can be branched. The normal diameter is less than 20 micrometer. It could be regularly enlarged or can be irregularly enlarged. They can be regularly organized and they can be irregularly disorganized. The number of nail fold capillaries per millimeter is 7 to 12. It can be increased and it can be decreased as well. On the basis of these nail fold capillary patterns, we divide the dermatoscopic patterns in three main categories. Number one, the normal pattern. Number two, the scleroderma pattern. And number three, the non-specific pattern. The scleroderma pattern is basically when more than two lesion morphologies can be seen, and non-specific pattern is when there's less than 2 morphologies. Coming towards the results. Sorry for the interruption again and again. Starting with the demographics, majority of the patients in my study were females. The mean age was 36 years and the mean disease duration was 1 to 10 years. The normal patterns which were seen, majority of them were the normal category, followed by the tortuous loops. Again, the normal densities were seen in most of the patients, followed by increased number of capillaries. Diameter was also enlarged, followed by the enlarged capillaries. Basically, focal microhemorrhages, as you can see in the picture, were seen in most of the patients, and absent new angiogenesis was present. There were discrete devascularization zones which were seen in most of the patients. So on the basis of these patterns, the 96 patients were further divided into the 3 patterns which I've already discussed. 28% had normal pattern, non-specific pattern was seen in 29% of the patients, and 43% of the patients showed scleroderma pattern. So the dermatoscopic pattern in each disease, as you can see from this graph, that the patients, majority of the patient in the systemic sclerosis and SLE had a scleroderma pattern, while the non-specific pattern was seen in the majority of the dermatomyositis patients, and the rheumatoid arthritis showed equal percentage of normal and scleroderma pattern. This is the scleroderma pattern containing 2 or more morphological changes, microhemorrhages as you can see here, and the avascular zones. These are the avascular zones which show no capillaries. Non-specific pattern which showed only 1 or less than 2 changes. These are the number of capillaries which were increased, and again avascular zones. These are few pictures showing again the focal microhemorrhages, the avascular zones. As you can see here are also the focal microhemorrhages. So the next objective was to assess the disease severity. So I used certain criteria to assess my disease severity. For systemic sclerosis, it was Valentini disease severity index. For systemic lupus erythematosus, it was SLEDAI criteria. For dermatomyositis, MyoAct disease activity index. And for rheumatoid arthritis, it was -28, CRP-28 criteria. So as you can see from the graphs, this is basically a correlation between the disease severity and the patterns observed. Here it shows that the majority of the patients who had normal pattern exhibited mild disease severity, while those patients who had non-specific pattern had 60% mild disease and 40% of the patients had moderate disease severity. Scleroderma pattern showed equal distribution of mild and moderate disease severity. This is the disease severity graph for systemic lupus erythematosus. Again, most of the patients who had normal disease, normal patterns showed mild disease severity index. Non-specific pattern was seen in the patients had mild, 60% the mild, and 40% had moderate disease severity index. And in those patients who had scleroderma, 92% of the patients had moderate disease severity index, while 8% had mild disease severity. For dermatomyositis patient, all of the patients had moderate disease severity. Here, there is the graph for the rheumatoid arthritis. Again, we can, as you can show, mostly normal patients had mild, remissions. More had remissions, which had normal pattern. And in scleroderma pattern, mostly patients had moderate disease severity index. I would like to conclude by saying that dermatoscopic patterns may reflect underlying disease activity and severity, providing a potential non-invasive biomarker for monitoring patients with autoimmune connective tissue diseases. And I would like to end by saying that the eye only sees what the mind is prepared to comprehend. With dermoscopy, we train our minds to see beyond the surface to detect what others might miss. Thank you very much.
Thank you very much for this presentation of use of dermatoscope in connective tissue diseases. Now let's come to the last paper, and the topic of this study is in nail psoriasis. There's a comparative study between the dermatoscopic and clinical NAPSI score. Dr. Mahnoor Tahir from Lahore Medical and Dental College.
Assalamu alaikum. I am Dr. Mahnoor Tahir, resident dermatologist at Brookes Hospital, and Bismillahirrahmanirrahim. Today my topic is nail psoriasis, a comparative study between dermoscopic and clinical NAPSI score. There were no conflicts of interest. Introduction. Psoriasis is a multi-system disorder influenced by multiple genetic and environmental factors. Typically diagnosed on its clinical presentation, up to 50% of the patients with psoriasis are affected by nail psoriasis. Nail psoriasis may be found in 80 to 90% in psoriatic arthritis, and it can substantially affect the quality of life. So nail psoriasis can cause diverse alterations in the nails involving its different segments. Vascular alterations being the major aspect of pathogenesis. The microcirculation of the skin in psoriatic patient is considerably different as compared to the normal individuals. So we divide it into two types, type 1 nail matrix and type 2 nail bed signs. What is the histological hallmark? Angiogenesis that leads to the elongated dermal papillae with tortuous and dilated capillaries. On dermoscope, it appears as fuzzy motile glanula with red spots, longitudinal erythema of the nail bed, dilated nail bed capillaries, dilated hyponychial capillaries with white halos. So we have a severity index that is known as nail psoriasis severity index, and this index involves on the nail bed signs and nail matrix signs. So onychoscopy magnifies the nail features, and it can provide up to 10-fold magnification. There are two modes, non-polarized mode and a polarized mode. Ultrasound gel is superior as an interface medium for the examination of nail varieties. Examination with ultrasound gel enhances the visibility of the nail bed changes by improving its transparency and light penetration. So objective of the study was to assess the clinical features with the dermoscopic features of nail psoriasis using the NAPSI scoring and dermoscopic NAPSI in identifying the early nail changes in the disease. The study was conducted in outpatient department of Brookes Hospital. Approval was taken, written informed consent, and hind delta 30 dermoscope field view of 30 mm was used. Having 1 point each for nail bed signs and nail matrix signs, the severity was defined as 0 is equal to no nail involvement, 1 to 3 mild, 3 to 6 moderate, and 6 to 8 severe. Age above 18 years, both genders, and diagnosed patients of chronic plaque psoriasis were included in the study. Exclusion criteria: pregnant women, diseases affecting the nails, onychomycosis, lichen planus, alopecia areata, eczema, exfoliative dermatosis, and patients already getting benefit from other therapeutic modalities. So nail findings were divided into nail bed and nail matrix. In nail bed, we saw splinter hemorrhages, subungual hyperkeratosis, distal onycholysis, oil drop site, dilated hyponychial capillaries, and in nail matrix, nail plate thickening, pitting, leukonychia, transverse grooves, tracheonychia, red spots on lanula, crumbling, and longitudinal ridges. Males were 56% and females were 44%. Mean age of the patient was 39.9 years. Duration of the disease, 40% of the cases fall in 9+ years category. Association of duration of the disease and the NAPSI scoring. The correlation between the disease duration and the NAPSI score is approximately 0.06, indicating a very weak positive association. This low value suggests that there is no linear relationship between the duration of the disease and the NAPSI score. Increased disease duration does not significantly correlate with higher NAPSI scores. So the most common comorbidity found was psoriatic arthritis with the frequency of 48%, then diabetes 25%, hypertension 21%, and ischemic heart disease 6%. This is the comparison of both of the scores. Pitting was the most common finding in nail psoriasis, and leukonychia, transverse grooves, tracheonychia, and longitudinal grooves being in moderate amount. Red spots on lanula were the rarest finding that we have seen in the study. These are a few of the pictures of the findings. Pitting, leukonychia, red spots on the lanula, mottled lanula, transverse grooves, Bu's lines, crumbling of the nail plate, pachyonychia, longitudinal grooves. On nail bed finding, the most frequent finding was splinter hemorrhages and distal onycholysis, but the major difference was of dilated hyponychial capillaries that were best measured by dermoscope. And the difference was of 4, we only found 4 in the clinical NAPSI and 45 cases in dermoscopic NAPSI. So these are the picture of nail bed findings. Distal onycholysis, these are the dilated hyponychial capillaries that were only visible during dermoscopic examination. Subungual hyperkeratosis, splinter hemorrhages, oil drop sign, also known as Sarwell patches. So comparing the scores, both NAPSI and dermoscopic NAPSI shows similar means and values, but dermoscopic findings were slightly higher with mean and maximum, indicating that the use of dermoscope can predict a higher severity levels and additional features of nail psoriasis. So the relationship between PASI and NAPSI, a correlation coefficient of 0.371, implies a moderate positive relationship between the PASI score and the NAPSI score. Indicates that as psoriasis severity increases, nail involvement also tends to increase. Diagnostic significance of dermoscopic NAPSI over NAPSI. The plot demonstrates that NAPSI and dermoscopic NAPSI are highly correlated with a Pearson correlation coefficient of 0.953, indicating that both scoring systems provide similar assessments of nail psoriasis. This strong relationship supports the use of either method, but dermoscopic being the superior one. So conclusion of my study was, if both scores are available, they provide mutually reinforcing assessments. However, if resources are limited, either score could potentially serve as a reliable indicator. The strong correlation between NAPSI and dermoscopic NAPSI highlights their consistency in assessing the nail psoriasis, making either method suitable for clinical or research use. Dermoscopic NAPSI can act as a dependable alternative to NAPSI if required. Thank you.
Thank you so much. Now we would like our panel of experts to please come on the stage here and distribute shields among the speakers. Please, Dr. Tahir, Dr. Shazia, Dr. Aisha, Dr. Uzair, please kindly.
First,
First of all, Dr. Tahir will present sheet to Dr. Aisha Ghayas because she has to go. Afterwards, our first speaker, Dr. Muhammad Wajahat.
Dr. Wajahat among two icons of dermatoscopy. You are the blessed one. Our next speaker, Dr. Hubaib Tahir. Followed by Dr. Javeria Bushra Toki from Services Hospital. Next is Dr. Iman Aisha, again from Lahore Medical and Dental College. It feels as if the next hub, the spot for dermatoscopy is Lahore Medical and Dental College. And last but not the least, Dr. Mahnoor Tahir from Lahore Medical and Dental College, Gurki Trust Hospital. It's an honor to receive a shield from your father, but Mahnoor, I should tell you this is a big responsibility once you are born to an icon. Next, we would like to present the shields to our panel of experts. First of all, I would like to request Dr. Lamis Mahmood Malik, our organizer of this PADCON, along with Dr. Nadia Ali Asfar, to please come on to stage and present the shields to the panelists. Madam, we want to see the face of this PADCON, the faces behind all this effort. First of all, Dr. Shazia Zubair, a pretty expert all the way from Multan. Thank you, madam, for being here. Next, Dr. Uzair Qureshi, all the way from Bahawalpur. So thank you for being here. And again, last but not the least, Dr. Tahir Jameel Ahmed. Sir, I'm taking the liberty to say that wherever there is dermatoscopy, though you have a lot of contribution to dermatology, wherever there is dermoscopy in Pakistan, you would always be there. Ji, bilkul, bilkul. He's everywhere, by the way. Thank you very much, all the audience, for being a part of this session. And I would like to conclude this session with the remark that dermatoscopy is an upcoming technique and it is going to become a part and parcel of dermatology. So being a dermatologist, try to familiarize yourself with dermatoscopy. Thank you very much.
Assalamu alaikum. Good afternoon, everyone. We are going to start today's last session, which is about role of biologics in pediatric dermatosis. This conference serves as a platform for all of us to exchange knowledge, deepen our expertise, and ultimately improve outcomes for the patients we serve. I would like to invite our panel of experts, Dr. Sumaira Hanif. She is currently working as an assistant professor at Services Institute of Medical Sciences. Dr. Mariam Saeed. She is currently working as an assistant professor at Faisalabad Medical University.
Thank you so much, Dr. Hira. My name is Dr. Nayab Arif Tukal. I'm a consultant dermatologist from Gujranwala. Our next panel of experts, there is Dr. Umair Bajwa, consultant dermatologist, worked as head of dermatology department at Nawaz Sharif Social Security Hospital for 27 years. Thank you, sir, for coming. Now I would like to invite our first speaker, Professor Nadia Ali Asghar. She has worked as professor and head of dermatology department previously in Gujranwala Medical College, National Medical University, and now currently working as professor and head of unit Allama Iqbal Medical College in our hospital, Unit 2. She is also a scientific chairperson of 43rd PADCON. She has keen interest in clinical and research, and there's multiple publications on her name. Thank you so much, madam, for coming.
Thank you, Dr. Nayab and Dr. Hira, who is currently working with me as a senior registrar in the dermatology department. Before starting the presentation, I would like to thank you all for being here for the scientific program. And this is the last session. The session has ended in Hall B and the GB meeting is going on. And we will just try to wind this up also within an hour, hopefully. We have just 2-3 speakers here. So starting with the topic, actually biologics, you've heard a lot in the past 2 days. Biologics have been discussed by many speakers who are international, as well as we have also had a pre-conference workshop in the use of biologics in dermatology by Dr. Huma Jafar. But today we would also like to focus a bit on the pediatric group of patients in our society, because pediatric dermatology is our upcoming field. This is the disclaimer which I have put. Now the objectives of the current presentation are to understand the mechanism of biologics, the indications in pediatric dermatology accordingly, and the efficacy, safety and tolerability of these agents for the pediatric patients. The pediatric patients are also our dear patients, and we have been starting with the conventional therapies. We start with the topicals, then we move on to the conventional agents which we have been using, some systemic steroids or other autoimmune therapies for the autoimmune disorders. And we are always reluctant to start the biologics. So again, this is a narrow spectrum. We have to be very careful in our choice of biologics in this group of patients. So there are challenges and limitations which we will be talking about, and a little bit about the future directions. They are the biologics. What are biologics? Briefly, they are the genetically engineered proteins which are produced by living organisms and target specific points of inflammatory cascade, including antibodies against cell surface markers, cytokines and adhesion molecules. In pediatric dermatology, biologics are used primarily for the immune-mediated conditions. So not only in dermatology, but other problems like Crohn's and other autoimmune disorders, we always use biologics. Starting off with psoriasis. Now psoriasis is a condition which is a serious condition that affects more than skin. It also involves the joints. I will not go into the detail. It affects more than 125 million people worldwide. Sadly, we don't have the data in our population, but we see every day in our OPDs indoors that there are a lot of psoriatic patients, and children are coming up with various morphological variants of psoriasis every day to us. So there is a large burden of disorder. Prevalence of childhood psoriasis differs across the globe, as you can see here. Up to 2.1% of children suffer from psoriasis. In pediatric dermatology, now what are the agents which we can use? Number one, we have recombinant human cytokines and growth factors. Then we have monoclonal antibodies, and then we have fusion proteins as well. These are some of the conditions in which we can think of using biological agents. One is atopic dermatitis and psoriasis, as I talked. Then we have vitiligo, chronic urticaria, alopecia areata, and hidradenitis suppurativa. So what are the agents which we use in psoriasis? One is secukinumab, then we have ustekinumab and etanercept. Then we have alopecia areata, in which we have the JAK inhibitors, which we are currently using in many patients. Then we have atopic dermatitis, in which we use dupilumab, which is not available in our setup, but it is all available worldwide, and dasatinib. Then we have chronic urticaria, in which omalizumab is used. For vitiligo, again tocilizumab can be used, and hidradenitis suppurativa, in which we have the adalimumab, which is also available now to us in Pakistan. So what does secukinumab do? It is the evolution of a targeted approach. It is, we all know, anti-interleukin and there is a comparison here. You can see interleukin 17 inhibitors compared with the other biological agents. So it is very specific in inhibiting. So what should be the approach, non-biological versus biological approach? As you can see, we use methotrexate, apremilast, tofacitinib, and there is a comparison with secukinumab. We have a lot of side effects. This is not to say that there are no side effects with secukinumab. We have multiple side effects with that as well, but this is a table or a guideline which give us a holistic approach towards patient management when they are affected by certain conditions. For example, a patient having tuberculosis or kidney effect and the liver function test. So we have to be careful when we use methotrexate, and we have to monitor. And apremilast, we experience diarrhea. Tofacitinib, again, we have certain palpitations or cardiac problems as well. Other biological agents, again, you can see this is also in the nutshell. We can see how they act and how what is the molecular structure. We have TNF-alpha inhibitors, then we have again interleukin 12 and 23 inhibitors, and 17 inhibitors as well. Now in children, secukinumab is approved for children of more than 6 years of age, but when there is psoriatic arthritis, there are guidelines for use in age more than 2 years. Dupilumab is a wonderful drug used in atopic dermatitis. It inhibits interleukin 14 and interleukin 13, and it can be used in moderate to severe atopic dermatitis in children aged 6 months and older. It has a marvelous efficacy is good. It reduces the symptoms and it reduces the itching and the problems associated with atopic dermatitis. There are certain side effects as well. There could be conjunctivitis, upper respiratory infections, and other few problems as well. Then we have ustekinumab. As you can see, the mechanism of action, and again it is indicated for children of more than 6 years of age with moderate to severe psoriasis. It has side effects like headache, upper respiratory infection, and there is a potential risk of infection. Here you can also see the, I think we'll just skip this slide, repetition. Then we have omalizumab. This is used for urticaria. Again, the indication can be in children of more than 6 years of age. And when to use, when the antihistamines are not very effective. Now we come to hidradenitis suppurativa. Sometimes it becomes a menace for us, and in children it creates a lot of psychological problems as well. When they are affected by this problem, they are depressed and their mental health is also disturbed. Adalimumab can also be used in children more than 12 years of age. The side effects include injection site reactions, infections, and there could be a potential risk of malignancy, so we have to be very careful. Tofacitinib, again, we have started using in alopecia areata, but according to my experience, there have been relapses with tofacitinib when we taper it off. But the indication is, again, we know the pathway, the JAK-STAT pathway is inhibited by the JAK inhibitors, but refractory alopecia does respond. But again, relapses are common, so you have to be quite selective in choosing your patients. It has also been used, tocilizumab is being used in vitiligo. Now, vitiligo is again a disorder which affects the mental health of the patient, especially children. So we have to find, other than the conventional therapies or phototherapy and other topical agents, we have to look for other agents as well when the vitiligo is not responding. So this could be another option. The safety concerns, yes, they have to be kept in mind about infections. We have to take care of the effect of the growth and development, which is under study, and immunogenicity of this as well. There are certain challenges which we experience, and this we all experience, like the cost is very high and mostly we cannot afford, and it is quite a problem to start the biological agents for children. And again, long-term data is being collected. We have evidence-based trials, but they are few. We are lacking in evidence-based trials in our setup. So we have to, again, this is a path which we are taking up, but it has to go a long way. We have to go a long way where biologics are concerned in the pediatric population. So these are certain candidates, how to select. There is an exclusion criteria which is more important, like a person or the children having chronic or active infections, immunocompromised, and this doesn't go with children, the rest. Future directions, of course, we have to try to come up with, as I mentioned, evidence-based literature. We should start research. We should start using carefully in our pediatric population, and we should collect data, and then we try to establish the role of biologics in future as well. And because we yet to have identified the long-term efficacy and safety of these agents. Thank you so much.
Thank you, madam. Our next speaker is Dr. Kulsoom Javed, working as an associate professor at Faisalabad Medical University.
Assalamu alaikum everyone. I'm Dr. Kulsoom Javed, Associate Professor Dermatology Department, Faisalabad Medical University. And today I'm going to discuss the role of interleukin inhibitors with special emphasis on pediatric population and psoriasis. Here are the disclaimers. So what we are going to learn today are biologics, pathogenesis of psoriasis, rationale of biologics, psoriasis in pediatric population, and about its safety profile. So what are biologics? They are large, complex molecules used to diagnose, prevent, treat, or cure the disease. Biological products are generally produced through biotechnology in a living system, a microorganism, a plant, or an animal cell. While biosimilar is highly similar to and has no clinically meaningful difference in safety, purity, and potency from an existing FDA-approved reference product. Biologics in psoriasis are categorized according to the cytokines they target, like tumor necrosis factor alpha targeting biologicals interleukin 17, interleukin 23, and interleukin 36. TNF alpha inhibitors include adalimumab, etanercept, and infliximab, while interleukin 17 inhibitors include brodalumab, secukinumab, and ixekizumab. IL-23 inhibitors ustekinumab, gozalumab, and risankizumab, while IL-36 inhibitors fazolimab is specific for pustular psoriasis and not available in Pakistan. Starting a brief about psoriasis, which is all of us know, which is much more than just a skin disease. It is a progressive inflammatory disease with comorbidities. And patients experience other chronic and serious diseases at a higher frequency than the general population. These contribute substantially to the morbidity and mortality in these patients. So in these patients, we need a safe, lifelong, and holistic management We cannot address the genetic predisposition, but we can modify the risk factors, we can address the trigger factors, we can deal with the comorbidities and the psoriatic disease as such. We have seen evolution of psoriasis management since 1959 from the conventional non-biological agents, conventional DMARDs, towards the biological agents in the recent past. And this progress reflects better understanding of immune system and pathophysiology of psoriasis, leading to more targeted therapies with better efficacy and safety profiles. We all know that we start with topicals and phototherapy, and then we need to consider non-biological oral DMARDs in case of severe disease, then the conventional biologicals and the advanced biologicals. And as we move on towards this array, the efficacy and safety of these drugs definitely improves to a greater extent. Comparing the anti-TNF class inhibitors, which are conventional, with the anti-interleukin class inhibitors, which are more specific and targeted interleukin inhibitors. Evolution from this broad to targeted therapy reflects our better understanding of the disease. This is the general algorithm of treatment of psoriasis in adult patients, and you can see we have the options of topical therapy in case of mild, we have the option of mild or narrowband UVB in case of moderate disease, and for severe, in addition to topical therapy, if narrowband UVB fails, we need to move towards systemic therapies first. We move on to the conventional DMARDs, and then in case of their failure, we have to consider about the biological agents, either conventional or selective. But in case of pediatric psoriasis, the algorithm is quite different. We have the first top choice of phototherapy, narrowband UVB in severe cases. And if it fails, and we need to move towards systemic therapy, the non-biologicals are off-label, while the biologicals are on-label. So, starting with biologicals for psoriasis, it may seem to be a bit repetition, but interleukin 12 and 23 lead to activation of T helper 1 and T helper 17 cells, which further lead to production of TNF alpha and interleukin 17. So, in this pathway, different inhibitors can be used at different points. You can use TNF alpha inhibitors, etanercept, adalimumab, and interleukin 12-23 inhibitors at an earlier level, while interleukin 17 inhibitors at an advanced and more targeted step, like at the level of keratinocytes. Looking over the pathogenesis of psoriasis, the cytokine feedback loop. Targeting interleukin 17 is basically a selective action at the level of effector cytokines, preserving the other immune functions and sparing all the previous cytokines which need to be spared in maximum cases. IL-17A is the key cytokine responsible for inflammation in psoriasis, psoriatic arthritis, hidradenitis suppurativa, and axial spondyloarthritis. It is the link between innate and adaptive immunity. Its direct inhibition is a promising new target for treatment of psoriasis. You can see the level of inhibition of these conventional biological agents and the specific biological agents at the level of keratinocyte. Interleukin 17A, it directly inhibits the activation of keratinocytes, macrophages, and fibroblasts. Again, the visual representation as it is a link between innate and adaptive immunity. Focusing towards our biological agents for pediatric psoriasis, which ones are approved are adalimumab, etanercept, ustekinumab, and secukinumab. Immunological safety profile of all of them shows that immunogenic responses, that is anti-drug antibody formation, in all of these cases, secukinumab has lowest level of reported immunogenicity as compared to other biologicals, even much less than ustekinumab, same class of drug. And the reason being behind that this is fully humanized monoclonal antibody. This shows the evolution of humanized to fully human monoclonal antibodies. Safety concerns with conventional biologicals that were anti-TNF class inhibitors were many, like immunosuppression, serious infections, opportunistic infections, tuberculosis, reactivation of Hep B and Hep C, congestive heart failure, malignancies, lymphoproliferative disorders, infusion reactions, hematological reactions, hypoglycemia, and especially CNS demyelinating disorders. In long-term safety profile of all these conventional biologicals compared with ustekinumab and secukinumab shows them to be quite superior. There is no increased susceptibility of tuberculosis and hence no monitoring is required. No association with CNS demyelinating disease, no contraindication in patients with moderate to severe heart failure, no increased frequency of serious infections, and no impact on disease management due to drugs half-life in the long run. If we compare secukinumab versus adalimumab, the results published in 2017 in Journal of American Academy of Dermatology, secukinumab proved to be better in a study over 52 weeks to achieve PASI 100. The results of secukinumab were definitely superior to adalimumab. Another study comparing anti-interleukin 17 inhibitors with anti-TNF alpha inhibitors, it showed that secukinumab at higher doses, that's 300 milligram, was definitely superior at a duration of 52 weeks. PASI 100 could be achieved with secukinumab higher dose in 36.2% of the patients as compared to 9.9% of the patients only in patients treated with etanercept. Just a few slides about secukinumab. It is a novel biological agent which targets interleukin 17. It is a fully human monoclonal antibody. Following its first global approval in Japan in 2014, secukinumab was approved by European Commission on January 15, 2015, and just a few days later by FDA. Here are its FDA approved indications. In pediatric population, 1/3 of the psoriasis, if we consider, 1/3 of the total patients of psoriasis, first symptoms of psoriasis manifest in childhood, at the mean age of 9 years. Psoriasis in children of less than 16 years constitutes 4% of dermatological problems in this age group. The triggering factors in children slightly differ from adults, like trauma, stress, and bacterial infections are the triggering factors mainly. Because of skin lesions, children with psoriasis often face stigmatization, which dramatically decreases their quality of life, causing social isolation and difficulties in learning. Among children with psoriasis between 5 to 16 years of age, health-related quality of life is reduced by 30.5%. So how to measure psoriasis severity in children? Again, the same scores: body surface area, psoriasis area severity index, but dermatology life quality index is children dermatology life quality index and investigator global assessment. Secukinumab is indicated for treatment of moderate to severe plaque psoriasis in children from ages 6 years and onwards who are candidates for systemic therapy. NICE, National Institute of Clinical Excellence in UK, recommends secukinumab in children with PASI score of more than 10, but only if the disease did not respond to other systemic treatments, including cyclosporin, methotrexate, or phototherapy, or these options were contraindicated or not tolerated. Dosing and schedule. You can see for less than 50 kg body weight in children, we can opt for 75 milligram. Exact 75 milligram pen is not available in Pakistan. For more than 50 kg body weight children, 150 or even higher side doses, 300 milligram can be given. And the schedule is very simple. First 5 doses at weekly intervals, 0, 1, 2, 3, and 4, and then at every 4 weeks, once a month doses at the same dose, which was opted according to the patient's body weight. Risk of Candida infection is there with interleukin inhibitors, that is secukinumab and adalimumab, but no serious Candida infections have been reported in many of the studies. Starting with literature review, efficacy of secukinumab across subgroups, overall safety in pediatric patients with moderate to severe plaque psoriasis. It was 52 weeks result from phase 3 randomized study, and it was published in Journal of Pediatric Drugs in 2022. And it showed that the pediatric patient responding both to the doses regime, the lower dose or high dose, across a 52-week treatment period, and the results were quite similar. After randomization, in achieving PASI, here you can see in achieving PASI 75, both the low dose and high dose groups were comparable, 92 and 93%. But if we consider achieving PASI 100, definitely high dose group responds better, 70%, while the 53.5% of the low dose group responds to achieve PASI 100 in 52 weeks. Again, the same results. Another study published in Journal of European Academy of Dermatology and Venereology in 2021. It was a phase 3 double-blind randomized controlled trial of 52 weeks results, and it showed that both doses, low dose and high dose, the low dose is advised considered to be 75 or 150 milligram, while higher side doses were 150 to 300 milligram. Both doses showed high and sustained efficacy up to 52 weeks with a favorable safety profile in pediatric patients with chronic plaque psoriasis as compared to etanercept. These were the comparisons with etanercept, and the graphs are easily understandable. Secukinumab low and high dose did not have much difference as compared to the difference with etanercept. Here is the continuation of the same study published in 2023. The long-term efficacy and safety of secukinumab. These were the 2-year results from phase 3 double-blind randomized control trial. It was the same clinical trial, and its result published after its continuation for 2 years. And the results showed that favorable safety profile in pediatric patients with severe chronic plaque psoriasis. A review in moderate to severe pediatric plaque psoriasis showed that treatment with secukinumab provided fast and durable skin clearance with continuous improvement in health-related quality of life in children and adolescents aged 6 to 18 years with moderate to severe plaque psoriasis. The benefits of secukinumab were maintained over longer term, and the drug was generally well tolerated. With a convenient 4-weekly maintenance dosing regime and the option of caregiver administration, as the self-injector pens are available, so parents can inject the dose conveniently at their homes themselves. Secukinumab is a valuable option for the treatment of moderate to severe pediatric plaque psoriasis. If we consider safety, the overall safety profile in pediatric patients was consistent with that of the adults. Infections, neutropenia, headache, IBD, infusion site reactions, and risk of suicide, self-injury were not that much seen. But neutropenia was seen more in pediatric population as compared to adults, but that may be due to the reason that children do have naturally low levels of neutrophil count. No new or unexpected safety signals were reported in pediatric population treated with secukinumab, and overall safety profile was consistent as seen in the adult population. No increased susceptibility of tuberculosis, no association with onset or exacerbation of CNS demyelinating disease, no contraindication in patients with moderate to severe heart failure, or it does not cause onset or worsening of the heart failure. So final notes from my side. There is significant evolution in biological agents for plaque psoriasis, moving from a broader TNF-alpha approach to more specific interleukin approach. Interleukins is a new generation of targeted therapies which is clinically superior to the conventional anti-TNF therapies. Anti-interleukin 17A is the latest generation of biologics. It has raised the bar from PASI 75 to PASI 90 and even PASI 100. Higher PASI means better quality of life of the patients, and the most important consideration is setting the new standard of care. It has clearly become the new standard of care. It is proved to be safe and effective medication in pediatric patients with psoriasis. Clinical trials and studies are many. I've just mentioned a few of them. They show it is highly effective drug with rapid and sustained clinical response. Being fully human monoclonal antibody, there is no risk of immunogenicity, and relatively infrequent need of administration of the drug increases its acceptability for children and their parents. Individualized and holistic medical care ongoing with close monitoring as well as good contact between doctor and parents of the patients can help in safe treatment with secukinumab. References were provided with each and every slide, and this is all from my side. Thanks a lot. Any questions? Or at the end of the session?
To invite Dr. Metier Brookes. She is an assistant professor in Koji Foundation Hospital and has experience in dermatology and aesthetic for over 15 years. She is here to talk about American Board of Regenerative Medicine and certification process in Pakistan.
My name is Dr. Metier Brookes, and I'm here representing American Board of Regenerative Medicine, and I'm here to give you good news of the course and certification process of American Board of Regenerative Medicine, and that is being starting in Pakistan from next month. So please save the contact numbers here for the workshop that is being arranged for all of you on 7th December, Saturday next month, inshallah. So see you all there, And one thing I must tell you that this American Board of Regenerative Medicine gives you a certification to become a diplomat. And I have done this course from USA, and they have approved. The good news is that they have approved the Pakistan, Islamabad, and Lahore two centers for conducting the oral exam as well as the written exam to become the diplomat of ABRM, or American Board of Regenerative Medicine. And the mission of ABRM is to provide global leadership in the education and certification of physicians and scientists in the specialty of regenerative medicine. We are already doing regenerative medicine, all of us. Being aestheticians, we are doing PRPs, we are doing exosomes, we are doing stem cells therapy. Only we have to get registered and do a course of 3 months and then appear in oral and written exam. This is basically a credentialing authority. It's a US government recognized official medical licensing authority. And ABRM has assisted the US government in drafting the regenerative medicine policies and guidelines. And the center is located in Colorado, USA. And these are the centers. 27 countries all over the world, they have their centers in of regenerative medicine. And the diplomats and the benefits is that you will not only get the in-depth knowledge in regenerative medicine, but at the same time you will become an acknowledged expert, and there will be an automatic registration in the American Society of Regenerative Medicine. So you will become a member of that society as well. Thank you very much. Please save the contact number, and you can WhatsApp your name and the city. Thank you very much.
Now I would like to invite Professor Muhammad Haroon. He is the head of Department of Dermatology at Fatma Memorial Hospital, Lahore. He has authored so far more than 100 publications in international scientific journal. Thank you, sir, for coming.
Assalamualaikum everyone. It's an absolute pleasure to be here to talk about something that has been very close to my heart for so many years, and that is psoriatic disease. So talking a little bit about what the psoriatic disease is. So rather than talking about a skin disease, arthritis, and so many other comorbidities that come with this particular disease, we'll talk about a psoriatic disease, right? The psoriatic disease, in other words, is a conundrum, but it is like an enigma. So it encompasses, as you can see, a lot of different the tissue manifestation. For example, they could be an involvement of the eyes, they could be an involvement of the joints. You talk about the gut, for example, 90% of the patient would have subclinical gut inflammation. So in other words, there's a lot of inflammation happening in a lot of different tissues. So that's why we preferably talk about psoriatic disease rather than talking about skin psoriasis or psoriatic arthritis on its own. I'm sure we all agree, the dermatologists and of course the rheumatologists as well, that it's too naive to think that psoriasis is a skin disease or a psoriatic disease per se is just a skin disease. We all agree that we talk about a lot of comorbidities that come with this, and we know, for example, the metabolic syndrome a lot of times comes down to the core of different the risk factors that associate or comes with the longevity of the disease, which we'll talk about in this particular slide. So this is what we call a psoriatic disease complex, right? If you, for example, we are starting from right at the bottom. So we're starting from the left, right, the leftmost, the inferior corner. So in the predisposed individual, which is, there is a genetic predisposition there. So some environmental triggers, they cause the new cascade of events leading to this whole skin psoriasis, for example. And then gradually with the longevity of the disease and all this, what comes is when there is a systemic inflammation, right? If you're just following this around your x-axis, for example, the skin disease, the skin psoriasis, it doesn't take long when it becomes a more systemic inflammation. then gradually it becomes a comorbidities coming, for example, cardiovascular disease and other psychiatric illnesses. And then the last thing what we generally, that's the time when most of the patient will land under you guys, under us, is when there is a significant consequences as got the burden of disease and the impact of psoriatic disease on their overall body. So subclinical vascular inflammation is extremely common among the patient with the psoriatic disease. For example, here what we are seeing is a PET-CT scan. On the left-hand side, as you can clearly see, there's a control patient, slim smart. So there is hardly any vascular markings visible on that particular PET-CT. On the other side, on the right-hand side, is the typical psoriasis patient. What you're seeing there is of course an obese patient, and what you're seeing is a lot of subclinical inflammation in the different vessels. On the bottom, what you're looking at, the cross-section of the same is the arch of aorta level of cross-section. On the left-hand side is your control patient. There's hardly any major vascular inflammation signals coming from the aorta. But on your right-hand side, in the same cross-section, what you're looking at, an arrow, there's a significant vascular inflammation. There's a significant high signal there. And the same study, one of the studies which are referenced below, but they've actually looked at what are the risks, what are the association of these vascular inflammation among patients with the skin psoriasis. What they found out was that it was directly associated with the high PASI scores, not associated with other things, not associated with the traditional other risk factors. So your vascular inflammation, which is subclinical, is directly associated with the severity of skin psoriasis. Again, comorbidity, you name it, there's hardly any organ which is spared of the different comorbidities that come with skin psoriasis. The association of obesity with the psoriasis and arthritis, psoriatic arthritis, is very good. For example, this is the most simplistic way if you want to understand the link. So whenever there is the high calorie intake, so the same adipocytes, they increase in their size. So when these increased size of those adipocytes, they generate TNF-alpha, and that TNF-alpha works on your endothelial cells, and they cause these MCP1 production, which of course generate the whole subclinical inflammation in these areas. So subclinical inflammation, as I said, is the most simplistic way to understand the link between the obesity and the subclinical inflammation that become possible. This is another interesting study, recent enough on the market. What they looked at was, again, the link between the skin psoriasis, the development of skin psoriasis, the severity and all this, and again, talking about the same, for example, the effect of BMI, waist circumference, waist hip circumference, and the 10 years weight change in the longitudinal study. And what they found out was there was a direct association. Obesity and high abdominal fat doubles the risk of development of skin psoriasis. Long-term weight gain was again substantially increases the risk of skin psoriasis. And naturally, if you can prevent this, there is a potential benefit. This is another very interesting study that's very sort of important for all of us to understand that the development of psoriatic arthritis at a very early age, how we can predict. So in this one particular study, the BMI at the age of 18 can predict the future development of psoriatic arthritis. For example, if you look at the red bar, for example, so these are the patients at the age of 18 have the BMI of more than 30. They would have only 35% chance that they will be without the development of psoriatic arthritis. But if somebody has a BMI of less than 25, they would have a 75% chance that they will not develop psoriatic arthritis in future years. So very early years, the BMI and all this will be predictive of the development of psoriatic arthritis. Very important study for all of us. And very important that this association was independent of the other usual risk factors, meaning this particular study was a controlled study in terms of that the younger age of women have psoriasis, nail psoriasis and all this, they were controlled by this particular development. Again, talking about the BMI and the development of minimal disease activity, meaning the control of psoriatic arthritis. If your BMI is more, there's a very less likely that that particular patient would be able, that the rheumatologist would be able to achieve remission in that patient. But if somebody's BMI is less, there's a much higher risk. The odds ratio is 5.4 of not achieving minimal disease activity. It means 5.5 times there is a lesser chance that that particular patient, rheumatologist will be able to achieve remission in these patients. But if the BMI is less, as you can can see, there is the achievement of the remission in these patients is very high. Achievement, again, is talking about the anti-TNF drugs and the achievement of minimal disease activity in these patients. As you can see, these patients were longitudinally followed up and they went under weight loss. So if there's a less than 5% weight loss, we're talking about the most left side one, the 23% of the patient, they were able to achieve the BMI. If the weight loss was up to 10%, the 44% of the patient were able to achieve remission of psoriatic arthritis. But if the weight loss was more than 10%, around 60% of the patient they were able to achieve remission as regards psoriatic arthritis. So talking about the same thing, that the arthritis and the obesity and the reduction of weight loss, there is a significant difference. There's then another study talking about again of the same thing, that these longitudinally followed up and all of these patients, there was a weight loss of around 18 kg, and majority of the parameters that we talked about, the tender joints, swollen joints, inflammatory markers, all these patients have a significant reduction of all those parameters. Talking about obesity and treatment outcome, again the BMI is less, there's a much higher chances of achieving PASI 75 in these patients. If the BMI is of course other way around, that patients will not be able to achieve remission. I mean, we talked about there's a hell lot of different longitudinal studies, the control population, the cohorts, talking about exactly the same. We talked about the cardiovascular risk, for example. So not only cardiovascular risks and the cardiovascular diseases are more among the patient with skin psoriasis and arthritis, but rather the severity also increases depending on the severity of skin psoriasis. For example, if you look at the light green part, and that's a patient with the milder psoriasis, the darker one with the patient with severe psoriasis, mean the PASI is more than 10. You can see the cardiovascular death, myocardial infarction, and the strokes. So they are more depending on the severity of the underlying skin disease. And here we are looking at the overall comorbidities. For example, in these patients, Charles comorbidity index, we all know that it encompasses a lot of more than 20 different comorbidities. Again, very nice linear relationship that if you have no psoriasis, mild psoriasis, moderate psoriasis, severe psoriasis, very nice linear relationship that the severity of skin psoriasis would lead to higher prevalence of comorbidities. So this is one of our patients, that's when I was in Ireland, so I'm not going to go with all this, but this was the patient that we are longitudinally following up. Very severe skin arthritis, and this is all the skin volume. And he has been treated with a lot of different treatments. And we're talking about 2010, we were starting with biologics at that time, and then he was in complete clinical remission. But these are the very important things, and that's the time when my PhD was starting, and we were looking at what sort of novel things we need to look at. And this is the true patient that led to at least my PhD. So this is the patient who came to me and that time like this disease is complete clinical remission. So the question is he healthy? Is achieving clinical remission, is that's all what we should be bothered about, right? Or shall we be looking at the totality of the risk because that patient has got a certain long-standing disease, established disease? Or shall we be considering what the factors associated with the mortality risk? So we did the cardiovascular screening for this particular patient. So as you can see, BMI is more, hypertensive, fasting glucose was moderately high. So based on all those parameters, he was diagnosed with psoriatic metabolic syndrome. So the question again is, so is at this particular time, the BP lipids are normal, should we write back to GP about his hyperglycemia and hyperglycemia? So these are all the things that we were literally going through, me and my boss were talking about, and we ended up doing a CT coronary angiogram of this patient. That's purely, we're talking about the research side, purely research side, right? And then, this is the true patient slicing of the coronary artery CT. So this is the left and descent. And seriously, the same day, in the morning he had the CT done, and the evening he was called in, and he underwent an urgent stent because his LED was massive. So this led to a lot of things. So we went into and worked on this, our future sort of lot of studies we went around. And this particular study was published where we then 50 patients we got this CT coronary angiogram. The control does that. And very importantly, what we found out was that the coronary artery plaque burden was independent of metabolic syndrome. So no matter how high your cholesterol and all this is, but it was much higher associated with the severity of underlying systemic inflammation. So the magnitude of the risk of underlying systemic inflammation was much more than metabolic syndrome. That was very important to understand. So we know about the metabolic syndrome with the prevalence of metabolic syndrome in psoriasis, psoriatic arthritis. Generally comes down to 30 to 50% of the patient with the psoriasis and psoriatic arthritis. And again, this study not only showing that there is high prevalence, but also, again, I mentioned about linear relationship there nicely, as you can see, the body surface area, the higher the body surface area, the higher chances are of development of metabolic syndrome. This is one of our studies which also showed that in psoriatic arthritis, there is a higher prevalence of metabolic syndrome. This is another study, longitudinal study, talking about the psoriatic arthritis patient, longitudinally followed up, and in 1 year there was a 104 new cardiovascular events, and when they looked at what could be the association, so rather than again the metabolic things, what they found out was that it was the severity of underlying psoriatic arthritis, which was predictive of cardiovascular events. So this is one of our another study which we looked at the performance of our usual cardiovascular risk scores, and what we found out was that rather than looking at the simple scores, there should be multiplication factor of 1.5, just like when we talk about the diabetics, when we talk about rheumatoid arthritis, here in psoriasis and psoriatic arthritis, there should be a multiplication of 1.5 if you want to get the true cardiovascular risk factors in the general population. So, this fine slide, I hope I haven't bored you much, but I'm just was hoping to give you a very sort of a bird's eye view of the association of the cardiovascular risks and the metabolic risks, and how closely they are associated with not only the prevalence of psoriasis and arthritis, but also the severity will also dictate the same. That how, if we can control these, not only the inflammation, but also the metabolic things if we can control, especially the obesity, that the risks of all this we can reduce. The additional cardiovascular risk factors, as I mentioned there, that they contribute, of course, naturally, but they contribute a lot less compared to the underlying systemic inflammation in the form of either skin psoriasis or psoriatic arthritis. Great. Thank you. Any questions?
Thank you so much, sir. Now there's house is open for any question and answers. Anybody?
Now I would request to our worthy chief organizer of 43rd PADCON, Professor Ramesh Mahmood Malik. Madam, please come on stage and distribute shields among speakers, panel of experts and moderators. Dr. Umair Rajpal. Dr. Sumaira Hanif, Dr. Megan Said. Dr. Kalsoon Javed, Professor Muhammad Harun, thank you everyone for your valuable contribution. Here we conclude our session.
اچھا وہ یہ ہے کہ ہمارا جو کلچرل پروگرام ہے دیٹس گوئنگ ٹو اسٹارٹ ایٹ 8 PM ہیئر ان دس ہال. Prize distribution for the best paper award and for the residents only. It's only for the residents. صرف residents کے پیپر assess ہوئے ہیں, seniors کے پیپر جو ہیں وہ ہم نے نہیں assess کیے. تو residents کے پیپر award پلس جو ہے وہ کچھ اور 1-2 awards تھے, کچھ لکی ڈرا کے اور کچھ quiz وغیرہ کے awards ہیں وہ, اور پلس cultural program. That's going to be in this hall at 8 PM which will be followed by dinner.